My name's Leanna Lavoie, and I'm the Program Director for Tobacco and Substance Use Prevention at Maine CDC. Welcome to our Maternal and Child Health Substance Exposed Infants Conference today. We are very excited. I think we have nearly 400 people registered for a very exciting two-day conference. I'm going to hand it over to Marion.
Good morning, everybody. It's so great to see everybody. I'm glad that we were able to have this conference, even though it's virtual, but I think that gives us some other opportunities as well. So I'm Marion Harakul. I'm the Maternal and Child Health Program Director here at the Maine CDC, and I partner with Leanna on putting this conference on. I do want to say a big, giant thank you to Dara Frichter for pulling this off for us. She was really the woman behind the scenes, and so you'll hear that name throughout the next couple of days. And so if you get a chance, you can say hello to her and thank her. And with that, I am just going to introduce our keynote speaker this morning. So with us, we have Dr. Amy Belisle. She is the Child Health Officer for DHHS. Amy, would you like to kick us off?
Great. Thank you very much, Marianne. And thank you very much, Lana. And good morning, everyone. We're really delighted to have you joining us today for the Maternal and Child Health Substance Exposed Infant Conference. For many of you, we have met before, both in person and last year virtually, and we're really delighted to have you all today. I'm going to start the conference just talking about our priorities at the state level around children's health. I'm going to review some of the work that's been happening during the COVID-19 pandemic to set the stage, because I don't think that we can get into a conference at the state right now without acknowledging the elephant in the room around COVID-19. And then I want to review some of the work happening at the state level around building early childhood systems. And then thinking nationally how all this work fits into the focus on relational health that is really happening at both the state and national level. So at DHHS, our goal is to provide leadership on children's health across both DHHS and the state. DHHS has 8 priority areas, and one is a focus on that Maine children grow up in safe, healthy, and supportive environments, allowing them to thrive throughout their lives. When Governor Mills restarted the Children's Cabinet in 2019, 2 of the goals are focused in this area: that all Maine children enter kindergarten prepared to succeed, and all Maine youth enter adulthood healthy, connected to the workforce and/or education. This morning, I'm going to focus a little bit more on the early childhood aspects, but there is a lot of work happening around adolescent health. So as we start the 2 days, I just want to level set and acknowledge that we are in a challenging time. Over the past year and a half with the COVID pandemic, it has really impacted our children and families and all of the systems at the state level. We do follow closely the number of children and youth in the state who have COVID-19. And it's about 18% of the children under 18 have had a case of COVID-19, about 30% under the age of 25. You'll see this data is on the Maine CDC website. Not only do they track the data daily around COVID cases, but the maternal child health epidemiologists every 2 weeks are publishing more detailed data on the children and youth under the age of 25. We are following their hospitalizations, we're following age breakdowns, and actually through more detailed information, we're following their symptoms and the information that they're finding out of the case investigations. And I say that because COVID-19 has impacted all of our lives. It has changed in ways that we could not have imagined 2 years ago. And we know that many of you are offering programs for families in your communities and at the state level. And I want to acknowledge that this has been tough, and in many ways, all of us are a little broken from COVID-19 and the impact that it's had. But there are a lot of good resources out there for families with young children, and also families in general who are quarantined or need to isolate. So WIC has put together a nice handout for folks around some of the services at the state level for young children, and I would encourage you to continue to refer them, both to get medical coverage or to get assistance through Cradle Me with Maine Families or Public Health Nursing, or to get nutritional assistance with WIC, or help with early intervention services through Child Development Services and the Children's Special Health Care Needs Program. We also know that COVID-19 has impacted different groups in the state disproportionately, those who have lower socioeconomic status or racial and ethnic groups or different geographic areas. There is help that DHHS has put in place around isolation and quarantine support to families. The state has partnered with 25 ethnic community-based organizations to provide both testing and vaccines, but also help for when people are in isolation around culturally appropriate meals. There's language and cultural support, help with financial assistance and transportation and getting to medical appointments. And I would encourage you all to reach out if you have a family in your communities that needs help during this pandemic. So with all the things that have happened with COVID-19, I think we do need to emphasize that this will end eventually, and there is hope on the horizon. We have had hope in the fact that our youth greater than 12 have been able to get vaccinated starting in the spring, and there was really an all-out effort between the schools and community organizations, and we have between 50 and 60% of the state over the age of 12 fully immunized, and for that I applaud all the efforts. And we know that the vaccines for younger children are on the horizon. I saw this morning that Pfizer filed their data for the 5 to up to 12-year-olds this morning, and so I think that that is great news, and that gives us hope for moving forward in this pandemic. I also want to praise you all. Some of the hope that we're seeing is just that you're all getting very skilled at pivoting during COVID-19. When something happens or changes, something new that you weren't expected, we're all figuring out ways around this to help families and create more resilient families and communities. And so for that, I applaud you. I think that all these lessons learned are going to help us in the future. Because right now, we're really at a window of great opportunity at the state level. We have a tremendous opportunity with new federal funding coming to the state to really accelerate system building around children and families. We're going to hopefully take some of the positive lessons from COVID-19 that we have learned and apply them to future systems-based work. We also are going to use some of the funding to encourage developmental promotion, developmental screening, and making sure that children are identified early for early intervention services. And we want to enhance family engagement in all of the programs and ensure that we're hearing family voices. At the same time as this window of great opportunity, we want to make sure that we are achieving the best possible health outcomes for all children and families in the state. We want to promote nurturing healthy environments. We want to make sure that all the programs that are being developed really honor diversity, equity, inclusion. And in day 2 of this conference, you'll have a wonderful panel talking about some of these efforts moving forward. So another big theme as we start these 2 days is just talking about building systems and how we can focus on maternal child health at the state level. We've been doing a lot of work over the past several years on really strengthening our perinatal system of care with the time from preconception to age 1 or postpartum out to the first year of life. The Maine CDC was just awarded an early childhood comprehensive systems grant called the ECCS grant, which will focus on prenatal to 3. So hopefully that will connect our perinatal system with our early intervention services and really get to a systems approach at the state level. Through LD 1712, that was recently a bill signed into law, the Office of Child Family Services will also be setting up the Help Me Grow program in the state, which will connect our birth to 8 services. And we're hoping to mesh all of these systems together to provide systems through a no wrong door approach to families in the state. In terms of our perinatal systems of care work, as we look back, we did an infant mortality needs assessment back 2 years ago to really try to better understand why Maine has one of the highest infant mortality rates in New England. And we're really doing a lot of work right now, and our goal is to try to get our infant mortality rate closer to 4 infant deaths per 1,000 live births over the next 5 years. Many of you have been working on improving care for pregnant people with substance use disorder and substance-exposed infants over the past 10 to 20 years, and we acknowledge all of the work that's been happening at the community and hospital level. We have seen great progress in this, and over the past 3 years, the Eat, Sleep, Console work has been implemented at all the birth hospitals in the state. We're going to hear in a few minutes with the panel around the plan of safe care work happening between the Office of Child Family Services and the Maine CDC. And Maine Care has launched the Maine Moms Program. So that there's a lot of work happening in this family, and we hope that this will continue to strengthen our perinatal system of care. We also launched 2 years ago the Safe Sleep campaign led by the Maine CDC. In addition to the public health campaign that many of you saw, the hospitals worked on a quality improvement project around safe sleep. And there was a lot of work at the different DHHS offices to try to standardize how they interact with families around safe sleep. In the end, all 26 birth hospitals became Safe Sleep certified, which was quite an accomplishment with Cribs for Kids, and we really applaud all of that work. And with the work focused on safe sleep last year, we did see a 50% reduction in infant deaths due to unsafe sleep position from 12 deaths per year down to 6. So we are seeing good progress, but there is still more progress that needs to be made in this area to reduce our infant and maternal mortality rates. We do have a perinatal system of care work group that's been meeting quarterly over the last 2 years. It started right around the time of the COVID pandemic. We've been working with the hospitals on maternal and newborn levels of care called Locate. And we are finishing out this project over the next 3 months, where we'll have a levels of care document with the hospitals. And we've also had 2 subgroups working on risk assessments for preterm delivery and maternal transport. And those groups will be working on piloting some of that work over the next year as part of the ECCS grant funding. And upcoming work at the state level of DHHS, there's currently work happening with Maine Care and the Office of Family Independence on developing policies for expanded pregnancy and postpartum coverage. Some of these were passed through the legislative session over the past year. The state will also start to try to institutionalize the quality improvement work happening in the perinatal system by joining the Alliance for Innovation of Maternal Health, called AIM. The quality improvement work is part of the ECCS grant in a partnership with the Maine Medical Association and the Perinatal Quality Collaborative for Maine. With the Help Me Grow work that's going to be centered at the Office of Child and Family Services, this was passed as LD 1712. And the funding will start to be available 90 days after the legislative session, which is at the end of October. So the Help Me Grow system, many of you probably have heard about it before, but there are many states using this, and this started in Connecticut. The components of Help Me Grow is that we are providing care coordination and assistance in developmental promotion for families birth to 8 through different efforts, including a centralized telephone access point and a referral and resource guide. Will be one component of Help Me Grow. The second component is working with child health care providers as well as child care providers around early detection and intervention. I'll talk a minute about the ASQ online system. It's really helping people to do developmental screening with their families. There will also be a lot of family and community outreach that's going to happen, as well as data collection and analysis. So we're excited about this project. It will take a couple of years to get up and running at the state level, but hopefully it will have a long-term impact on our early childhood systems. Maine Care is also in the process of working on getting the ASQ online system set up, the Ages and Stages questionnaire for the whole state, and this will be one component of the Help Me Grow system. We are looking to pilot this in late fall of 2021. And sites will have access to both a developmental and social emotional screening tool. This will be utilized by child care providers, by our home visitors, our public health nursing, our Head Starts, and our healthcare providers. And we're really trying to centralize the way we can do this so we can track this information over time and really support families on getting to early intervention services sooner. And then finally, as we start to do all this planning at the state level and we're looking ahead, we're also looking to see what's happening nationally. And nationally, you've probably seen that there's more of a focus on what's called relational health. Relational health refers to the interpersonal interactions that are growth fostering or mutually empathetic and empowering. And I think all of you in the audience, all 400 of you who are joining us today, have probably figured this piece out over the last 20 years in your professional lives. It's probably the secret sauce to everything that we do in maternal child health, is really building relationships with our families, encouraging connectiveness. It allows us to build resiliency and hear our families' voices. So this is something that we are focusing on the state level as we look at how do we meet both our state, but also our community and local priorities in the programming that we're doing, and also look at developing 2-generational approaches. The Office of Family Independence is working very closely with many of the agencies on this conference on what's called the whole families approach. And it's a really exciting approach to work with both the families and the children at the same time to address multiple issues that will allow them to thrive. And finally, part of the relational health focus is highlighting stories of hope and recovery. I know last night some of you joined us as there was a pre-conference with Gigi George, who wrote Down East, the 5 Maine girls and the unseen story of rural America. And there was a nice conversation with Mch Program, who is the Maine Care director. So he highlighted 5 stories of girls growing up in the Down East area. And today and tomorrow, we will be highlighting several stories of hope and recovery that will really hit home as to why we do this work and where we should be going moving forward. So we encourage you to join us and listen to those stories very carefully. And finally, I want to thank you for all the work that you've been doing over the past several years. It has been a challenge with COVID-19, but things are looking a little bit better and things will get better in the future. But I just want to thank you all. Dr. Peter Glor, who is a professor at MIT and works a lot in innovation, says that change and innovation happens when we're all working together in the same direction. And we have 400 of you in the audience, and we encourage you to be 400 stars, but to have those stars come together and really be a galaxy and a network so that we can move forward and build better early childhood and maternal child health systems. So I encourage you, don't be a star, but be a galaxy. But at the same time, we know as we work through this pandemic and how hard it's been on people, that it just takes one caring adult to make a difference in a child's life. So not only are we working at the systems level, but we're working at the individual level. And I encourage you to reach out to those that you're working with in your families and communities and make sure that everyone's doing okay, and really to be the one. And this is a bumper sticker that Maine Health put together last year. So I appreciate all the work that you've done to make sure that we have the best health outcomes for all the children in the state. And we really look forward to the next panel that we have. We'll talk about the state of the state and all the different programs happening across the Department of Health and Human Services. So thank you, Leanna, thank you, Marion, and thank you, Dara, for inviting me today. And we really look forward to working with you all in the future as we start to build better systems at the state level for women and children. Of the state panel. My name is Amy Belisle. I'm the Child Health Officer at Maine Department of Health and Human Services. We're really delighted to have a wonderful panel today from across the offices at the Maine Department of Health and Human Services. We're going to start at our first conversation with Marion Harakul, who is the Maternal and Child Health Program Director at the Maine CDC, who will be providing updates from all of the work happening at the Maine CDC. So welcome, Marion.
Thank you, Amy. I'm just going to go ahead and share my screen. There we go. Perfect. Well, good morning, everybody. I'm delighted to have the opportunity to give you the Maine CDC update. I am filling in for Jamie Cottonwar, who's our Associate Division Director of Disease Prevention, who was unable to make this morning and sends her regrets for that, but I get to fill in for her. So I'm going to talk a little bit about each of the programs within our division, and then I have a little CDC update at the end. So I'll start with maternal and child health, since that's the program that I oversee. We have multiple programs within our program, and I won't go through and read all of these because I know that you guys can see them. But as you can see, we have a wide variety of programs within our big program. So I think looking at this, we have everything across the age range. We have children with special health care needs pieces. We have all of the newborn screening, which you guys will get to have an in-depth conversation about tomorrow. So I'm not going to talk a lot about that today. But at the very end of it all, we have the maternal, fetal, and infant mortality review panel, which really ties together all of these other pieces that we have. So I'm going to go ahead and start talking a little bit about the accomplishments of the MCH program, and then I'll go through the rest of the programs within the division. So a couple of the things that we are really proud of that we've been able to accomplish over the past year, Amy has talked about a little bit, but we completed the locate tool working with all of the birthing hospitals in Maine to really look at those levels of care and see what we can do to improve our perinatal systems of care. Our newborn screening program added 4 new conditions to our blood spot screening, which is huge. And Jody's going to talk about that tomorrow, but I did want to highlight that as something that we're quite proud of, because it's a lot of work to get conditions added to that screen. If you want more information about that, here's the link to it. One of the things that I'm very proud of is that we work together as a department, as Amy had said, to get all of those all of our birthing hospitals certified through the Cribs for Kids program as Safe Sleep certified hospitals. It's huge. This is a very, very large accomplishment, and we're very proud of it. So in addition to that, one of the things that the Maine CDC did is we created what we call the Safe Sleep Kit reimbursement. And what this does is it allows hospitals to submit invoices to our program, and we will reimburse them for what we're calling the Safe Sleep Kit, which is a crevette, a fitted sheet, and a sleep sack for any family who needs them. No income requirements or anything. And because we want to make sure that every baby in Maine has a safe place to sleep. And one of the other sort of more broad accomplishments that we have is just building those relationships. And as Amy had said earlier, that really is the key to maternal and child health work, is building relationships and knowing who to call and knowing sort of, when things go south, that I have somebody that I can connect with and I know where to go. And so we've really worked hard to build those relationships across the department. So within Maine Care, we have multiple programs that we work with. And then also in the Office of Child and Family Services, we've really become truly partnering with OCFS on numerous things, which you're going to hear about over the next couple of days. And the other thing that's been really exciting is the work that we've done with the Department of Education and the Children's Cabinet. So a couple of things, upcoming projects. I'm really excited about this. We are adding the perinatal mood and anxiety disorders to the Maternal and Child Health Block Grant priorities, because we feel as though that is the next step for women in the state. We were awarded an early childhood grant, and so we'll be working within the early childhood system to make it easier for families to navigate through our large network of social services that we have available. So be on the lookout for some of that work. And then we also, like as Amy had said earlier, we're working to develop those systems for the ASQ online. And in addition to that, we're looking to expand some services and partner with OCFS on the Family First Prevention Services Act. So a lot more coming in the coming year. It's going to be a good, exciting year. All right, so WIC is the next program I'm going to talk about that's within our division. So WIC was very, very proud of this. They moved from paper benefit checks to e-WIC. It was last August that they did that, all during a pandemic. Incredible work done by WIC. They also got all the approved grocery stores e-WIC capable within the last few months, which is a big thing. I mean, you think about, it's easy for the larger stores, but those little stores, it's a lot harder for us to work with. So WIC did a great job getting that taken care of. They've also instituted some technological things. They now have a chat bot on their website. If you haven't checked it out, the link is here. So you can go in and chat with them and ask questions and whatever else you need to do. They've done a lot of things to go remote. So some educational type things. They've done telehealth appointments. And they also have instituted the two-way texting with participants. They've always had one-way texting, but now they're really starting to use that back and forth. And so that's really enabled them to be able to connect with their clients a lot better. Some more accomplishments all around breastfeeding support. They've really been able to increase their texting program that they have to provide support for moms who are breastfeeding. Also, their peer counseling staff hours are now funded 100%, which is a big thing. And in addition to that, they now have numerous types of breastfeeding supplies available for their clients. And you can see those listed here. Upcoming projects. So one of the things that WIC does a lot of is the farmers markets in the summer. I'm sure you all have seen those. Participants, they'll be able to use their fruit and vegetable vouchers not only at grocery stores, but they can go to those farmers markets, which is great. They also have the farmers markets will be able to accept electronic payments, the same as the stores do. So that'll be coming in the spring. That'll make things a lot easier for folks to access those fresh fruits and vegetables. In addition to that, there's always staff training happening. So they always have some things going on around breastfeeding. And then also the developmental screening, that'll be happening in January or so. And then they will also continue to do that two-way texting with participants. So chronic disease is the next program I'd like to talk about. And within chronic disease, they have multiple programs. And so you can see those listed here. So it's a rather large program that has lots of little programs in it, all important. Few accomplishments from the chronic disease program. They were awarded three new grants, which actually added 2 new programs to their larger chronic disease program. Colorectal prevention, as well as the Alzheimer's disease and related dementia. They also got a $100,000 grant from the National Association of Chronic Disease Directors, which will actually permit Maine Care actually to pilot coverage for the national diabetes prevention programs. So that's a great partnership between those 2 programs. In addition to those 2 accomplishments, they also were able to publish a 5-year cancer plan. Some upcoming projects. So they've got the diabetes prevention and control website that should be either launched now or will be launching very, very soon. So here's the link if you want to go and check that out. They also will be launching the asthma self-management education program, which I'm sure you'll see more about as we move forward. And then they're going to be developing the state's Alzheimer's disease state plan, which is very exciting. This is new work, and they're doing a great job at it. Tobacco and substance use prevention is another one of those programs that has a couple of other programs within it. So they have the tobacco prevention and control, substance use prevention, and they also have the adolescent health and injury prevention, which includes suicide prevention. Couple of accomplishments from that team. They have created a couple of strategic plans, one for tobacco and the other one for substance use prevention. They've also done quite a bit of work around the secondhand smoke campaign, which I'm sure you guys have all heard or seen around. It's a really cool campaign. So if you haven't seen it, you should check that out as well. They also have some support, a family navigator program created to support youth for suicide prevention. It's a peer-led program, but it's provided to schools to help those kiddos who may need some help. I don't know what's going on my screen here. There we go. Sorry. So the other thing that they have is they've created a prevention toolkit. It includes a fact sheet on marijuana use and pregnancy, which is one of those emerging issues that we're really trying to work with. And so if you want to get more information about that or check out the toolkit, the link is here for you. Some upcoming projects from this team. You can expect to be seeing a test of an incentive project to get pregnant women to reduce smoking among pregnant women, as that is an issue around in Maine. So you can expect to see a pilot test of that. We're also going to be seeing some work around addressing health disparities and including those minority populations. I think you're going to really see that across the entire department, actually. We're going to be looking at expanding the SEOW work website. We want to include some pregnancy and substance use dashboards so that we have a better picture of the story of what's happening in Maine. In addition to that, we want to be able to strengthen those supports for folks who are at risk of suicide. We're seeing a bit of an increase with that. And so working through telehealth and trainings and best practices, we're hoping that we can provide some additional support around that. Whew, that was a lot. That was all just from our division. And one of the amazing things about that is that all of that work happened during the pandemic. So on top of many of those staff who are within those programs that I just talked about, many of those staff were actually deployed to work on COVID, and they were still able to accomplish all of those things, which is completely amazing. So thank you to them for all the work that they've done around maternal and child health. In addition to that, though, we also have some other accomplishments from other divisions within the CDC that I would like to highlight. One of those things is that we have created the Maine CDC Office of Population Health Equity. And there is a new director or associate director of that. His name is Ann Yackney. So hopefully you guys will all get a chance to meet him at some point, but we're very excited to have that office within the CDC. Some other things that are happening around, we've been doing clinics, vaccine clinics for children ages 12 to 17 to get them their COVID vaccines. I'm assuming and I'm hoping that as we get closer to getting the 5 to 12-year-olds vaccinated, that the Maine CDC would be a big part of that as well. We also have been working to provide catch-up vaccines for children of all ages, because what we found was there was a drop in kiddos getting their regular vaccines throughout the pandemic. And that's a really important thing that we wanted to keep up. So that's something that we've been working as a team to do. The other thing is that the dental clinics and services, there's a directory around that, and that has been updated, and you can check that out on the website listed here. Some upcoming projects. So like I said, preparing for the COVID-19 vaccine for the younger children. So we'll definitely be working around that. It is starting to be cold and flu season again. And so offering those flu vaccine clinics so that we can get as many people get their vaccine as possible. A couple of other things to think about too is the Maine legislature actually mandated schools to test drinking water for lead. So the Maine CDC has been working with those schools, and they will be starting that actually October 1st to work with those schools to get their water tested. So, and PHN has actually, I think I haven't highlighted them quite enough, but they have been working really hard with our immunization program, both on that COVID vaccine distribution, but also the flu vaccine. And so they've played an integral part, not only in the maternal and child health world, but also within the vaccination world. And so a huge thank you to them as well. And that is what I have for updates from the Maine CDC. If you have any questions, our contact information is all on here, and we'd be happy to answer any questions that you have. Thank you.
Great. Thank you, Marianne, and thank you for the wonderful overview from the Maine CDC. As you know, the Maine CDC has been working very hard to both do the work during the COVID pandemic and do the regular programming to protect public health. So we really appreciate and value everyone that has been working hard at the Maine CDC throughout the state. So our next panelist is Erica Lichter. She is the lead maternal and child health epidemiologist at the Maine CDC, and we're delighted to welcome Erica and also acknowledge all of her team that works on maternal health, child health data at the state. So welcome, Erica.
Thanks, Amy. Just going to share my screen. Can everyone see that, or do you see my notes page?
Oh, we can see you fine.
You can see the regular part? Okay, great. Thank you, everyone. As Amy mentioned, I work as an epidemiologist at the Maine CDC, and I'm also a faculty member in public health at the University of Southern Maine. And I think as a theme that's going to be throughout this conference as around COVID-19, and as Amy and Marion mentioned, it's been a long 18 months. And as an epidemiologist, one of the things we've been focusing on is what is going to be the impact of the COVID-19 pandemic on children and families in Maine. In the 12 minutes that I have with you, I will not be able to answer this question, but I will be able to tell you a little bit about the things that we're monitoring and the changes that we've seen over time, and what is the Maine CDC doing to answer that question. So here's what I'm going to be showing you today. So we're going to review a little bit about some COVID-19 prevalence and trends among children, talk about some MCH successes, a little bit of data on health equity related to maternal and child health populations, and then I'll have some slides at the end for you if you want to dig in and find your own data related to these populations. So as Amy actually showed you in her presentation, there is a PDF, and it actually is now being updated every week. It had been being updated every 2 weeks, but due to the increase in the rise of cases among youth, we are now updating this PDF on a weekly basis to highlight what's going on with COVID-19 among youth. There's also been recently published data on vaccination rates among students by school administrative units. So I have both of those links there for people who are interested. So what is happening with COVID-19 in youth? And I know you can't see anything right now, but as many of you are aware, children under 12 are not yet eligible for the COVID-19 vaccination, and children 12 to 19 have some of the lowest rates of COVID vaccination in the state. So as of this week, when I looked, only about 58% of youth aged 12 to 19 have been vaccinated, and in some counties it's closer to 40%. And so what we're seeing is an increasing rise in the number of cases among youth across all age groups. And so this chart shows the total number of cases since the start of the pandemic among youth and young adults under the age of 25. And you can see this sharp increase starting around this summer and just keeps going up from there. Currently, youth under 12 make up about 16% of all COVID cases. In January, it was only about 7%. So in this graph, you can see the percentage of cases among those over the age of 20 has been declining over time as the percentage of cases under 20 has been increasing. And the percentage of cases of those under 12 has surpassed those of 12 to 19-year-olds. And as Amy showed you in one of her slides, there have been 59 known hospitalizations among youth under the age of 25, and 27% of these have been among children 0 to 4. So I encourage you to go to the Maine CDC's website if you're interested in seeing more data from this PDF. One of the things we're also trying to do is get a handle on COVID-19 and pregnancy. And so to do this, we're actually currently linking the COVID-19 case data to our birth certificate data. But what we do know, based on a checkbox that was added to the birth certificate to indicate whether or not a woman had COVID during her pregnancy, and what we know is that this year, in 2021, there have been 391 births in which the mother had confirmed or suspected COVID-19 during pregnancy. Some research suggests that this could be linked to some poor birth outcomes, so this is something we're hoping to explore in the next year. Sorry. We've been monitoring the data closely in general, although we haven't looked specifically at whether or not women who had COVID-19 had worse birth outcomes than women who did not, but we have been closely monitoring our birth outcomes data on a monthly basis to determine whether or not there's been changes due to the pandemic. And we have not actually seen any changes in our rates of preterm birth, low birth weight births, or cesarean section births during this period of 18 months during COVID-19. We have looked at some other factors that we have seen some trends. Not all of these necessarily, though, have been related to the COVID-19 pandemic, but these are where we've seen some significant trends over time. So for example, breastfeeding rates have been declining since 2019. So this decline in breastfeeding rates started prior to the pandemic, and it has continued and is something we're going to keep watching. So this is breastfeeding when women leave the hospital, when they're discharged from the hospital, are they breastfeeding? And you can see it hasn't been a huge decline, but it's gone from about 88% to 85%. One of another concerning issues, and Marion highlighted the importance of the WIC program and all the hard work that they've been doing to get people enrolled and to make it easy for them to stay enrolled. However, we have been seeing decreasing enrollment in this program, again, that started prior to the pandemic, and the pandemic, it's been challenging to continue this enrollment, as you can see, so it's been continuing over time. Prenatal care is another factor that the pattern is difficult to interpret, but there's been some interesting changes. One thing you can see is the rate of women who received adequate or adequate plus prenatal care during their pregnancy started to decrease around November or December in 2019. So these women were actually pregnant prior to and receiving prenatal care prior to the start of the pandemic, but that's where we start to see the decline. And this decline continues until around September, October 2020. Now, the women who gave birth at this period, most of their pregnancy did occur during the pandemic, and so it's likely that some of their prenatal care was impacted as the result of COVID-19 when doctor's offices and things may have been shutting down, or women may have been fearing going to the doctor's office. The good news is that we have seen this rebound, and of women who gave birth in July of 2021, almost 88% had received adequate prenatal care during their pregnancy. So people are going back to the doctor and they're getting their prenatal care visits again. Another increasing trend that we've seen that again started prior to the pandemic and then continued throughout is an increase in planned home births. Home births have become more common in recent years, and the trend has continued throughout the pandemic. It's difficult to know whether the ongoing increase was due to the pandemic or whether this is just an upward trend in women's desire to give birth at home. So what you can see is that in 2019, on an average month, about 17 births were at home, planned to be at home, and that increased to about 20 per month in 2020. And so thus far in 2021, it's an average about 23 home births per month. I know another issue that's been on people's minds a lot during the pandemic is around mental health and the impact of how the pandemic has affected the mental health of adults as well as children. So we have limited real-time data on children's mental health. Sorry, I'm going to go back for a second. The Maine Integrated Youth Health Survey was postponed this year, so it's actually happening this fall, but it was supposed to happen in the spring, but because of remote schooling, it was unable to be administered. But we will have some data that's important on adolescent health when that happens this fall. So we've been relying on monitoring outcomes such as suicide and suicide ideation throughout the pandemic. So based on data from the death certificates, we did not see an increase in suicide deaths among all Mainers aged 10 and older in 2020. And thus far in 2021, there's been about 138 deaths as of July of this year. Similarly, we did not see an increase among youth to ages 10 to 24 in 2020. So these data suggest that despite the mental health challenges that a lot of people face, it did not necessarily result in an increase in suicide deaths. However, we did receive a grant from the federal CDC to start monitoring emergency department visits for suicide ideation and attempts using Maine CDC's syndromic surveillance system. And I don't have a graph for this, but as you can imagine, during the pandemic, overall, the number of emergency department visits decreased in the early months. Fewer people were going to the emergency room. However, if we think about those who did go to the emergency room during this time, what we find is the proportion of those visits that were attributable to suicide ideation and attempts increased over this period. So you can see this is around the period of the pandemic. And there was a sharp increase in I think what happened in March is probably a lot of people stopped going to the emergency room, but the people who did go, more of them were going because for suicide ideation and attempts. So this is among all youth and adults aged 10 and over. And you can see the same pattern for youth under the age of 19. There's that increase during the pandemic of the proportion of those ED visits that are related to suicide ideation and attempts. And when we looked at this by gender, what we saw is that a lot of this was driven by girls. So what we saw was that girls were more likely to be going to the emergency room and driving up that proportion of ED visits attributable to suicide ideation and attempts. So this is something that we've been thinking about and working on addressing. So thinking about some other factors in Maine, not necessarily related to the pandemic, we're going to just look at some overall trends going back to 2014. One success is Maine continues to see a decrease in our smoking rates during pregnancy. And as Marion mentioned, the tobacco program is focusing on this. And this is a big win from between 2014, about 18% of women had smoked during pregnancy. And in the most recent data from 2021, it's down to about 9%. Our infant mortality rate has overall decreased since about 2013. There was a slight increase in 2020, but most recent data from 2021 suggests that it's going back down. And as Amy mentioned in her presentation, we did see a large drop in the number of SIDS deaths in 2020. It was about half as many as that we had seen in prior years. And we are hopeful that this is a result of all the safe sleep efforts that both Amy and Marion highlighted, and that we'll continue to see this decrease moving forward. Another outcome that we've been analyzing on an ongoing basis is the incidence of neonatal abstinence syndrome, as well as opioid use disorder among pregnant women. And we've been analyzing this using Maine's hospital discharge data sets. And what we found is that prenatal opioid use disorder has not really changed very much between 2016 and 2019, but Maine has seen a decrease in neonatal abstinence syndrome. That said, Maine still has the second highest rate of neonatal abstinence syndrome in the US, but we are heading in the right direction when a lot of other states are actually heading in the opposite direction. So this is a good sign and something we continue to work on. Oops. As part of the maternal fetal infant mortality review panel that Marianne mentioned, we are monitoring pregnancy-associated deaths, and we know that in 2020 there were 6 pregnancy-associated deaths. Almost all of them occurred between 43 days and 1 year of delivery. So a definition of a pregnancy-associated death is any death of a woman during pregnancy or within 1 year of delivery. And as right now, sorry, I don't know why I keep saying that. What we believe, and this is provisional, is that there may have been 1 death of a woman with COVID due to COVID-19. So just talking quickly about some health equity data, because one of the things that the Maternal and Child Health Program is doing is centering health equity as part of its work and making sure that we are analyzing data to examine where are the health disparities so we can better address some of these issues. So I'm just going to highlight a very few of some of these findings and our plan in the next year, so it's to really dig in and learn more about what's going on. So what we do know is African American and Native American women in Maine are less likely to have adequate prenatal care. So this is data from 2015 to 2019. And as you can see, about 2 in 3 African American women had adequate prenatal care, compared to about 83% of white women. Some other disparities we've noticed that infant mortality and low birth weight are higher among African American women. But African American women are actually less likely to smoke during their pregnancy and more likely to breastfeed their infant. Native Americans have higher rates of adolescent birth and are more likely to smoke during their pregnancy. And women enrolled in Maine Care, which is another group that has a lot of disparities compared to those who are insured by private insurance, tend to have higher rates of infant mortality, preterm birth, and low birth weight infants, and they're also less likely to receive adequate prenatal care. So we'll be working with our partners in the new Population Health Equity Office, as well as Maine Care, to look at some of these health disparities. As I mentioned, I wanted to share some additional sources of data. If you're interested, Maine's community shared community health needs assessment is the website link is right there. There's a lot of data from all different areas of health and well-being, and they're going to be updating that data with a new dashboard launching actually just in October. So be aware of that and keep checking for that dashboard launch. For more information on maternal and child health, you can look at Maine's Maternal and Child Health Block Grant application website. There are some fact sheets on there, or also the federal government has a link with all of the states' annual reports with data on the performance measures that each state is required to report on. Maine CDC's Data Research and Vital Statistics Office has dashboards on infant births and deaths, as well as the Pregnancy Risk Assessment Monitoring System. And as I mentioned, the Maine Integrated Youth Health Survey was last done in 2019, but it is being administered this fall in 2021, and we hope to have data on that by next spring. So thank you all very much, and I appreciate you taking the time.
Great. Thank you very much, Erica, for the wonderful presentation. It's always great to see the data, and you have a great way of telling the story. So thank you. And I want to acknowledge that you have a team of folks behind you at the University of Southern Maine working with you. So thank you to everyone on your team, including Fleur Hopper and Sydney Mervis and your whole group. So thank you so much. And next, we're going to turn to Catherine Kuchu, who is the Treatment and Recovery Manager at the Office of Behavioral Health. Welcome, Catherine, and we're excited to hear about your programs.
Thank you, Amy. Share my screen. Can you all see that?
Yep.
Excellent. So first, I'd like to start with some Obh infrastructure updates. We've increased full-time employees on our housing, SUD, recovery team, administrative support, and we've also added a clinical director, Dr. Deb Bader. We've added grant management positions. This is to help us align our grants with the needs of the state. Also, 13 new staff were budgeted for OBH in the state fiscal year 22-23 budget. We've been able to make the opioid response project manager and our deputy director positions permanent. We've also been able to add additional SUD team members as well as CCBH staff. We've also been able to expand positions on the data team so that we can improve our data collection as well as analytics and dissemination. One of our proudest accomplishments this past year has been our options campaign. This is our overdose prevention through intensive outreach naloxone safety. This was announced by Governor Mills in July of 2020. It includes public and targeted outreach campaign and also our direct interventions, which are liaisons. You may have heard them referred to as co-responders. We also have our website, knowyouroptions.me. So our public health media campaign has 4 primary calls to action. And basically this is to improve the understanding of the Good Samaritan law, increase calls to 911 when overdoses are suspected, invigorate our Have It On Hand campaign to increase the distribution and availability of naloxone, educate those at risk on safe drug use practices, reduce using alone and the risk of overdose, and also connect people with local prevention, harm reduction, recovery, treatment, and general resources, as well as our option liaisons. There have been over 14 million impressions achieved throughout our media campaign. The other side of the options campaign is our statewide co-responder overdose intervention network. Currently, we have 14 counties that have option liaisons with only 2 counties remaining, and they are actually in the hiring process at this time. So basically it's substance use professionals corresponding with law enforcement and or EMS to calls that where there's suspected overdoses. There's also post-overdose follow-up. They can also accept referrals for at-risk individuals and then connect with harm reduction, treatment, or recovery services. Basically, we want to meet the people where they're at and make those connections. Another thing we're very proud of this past year has been the governor's opioid response seminar series. So that basically free virtual seminars. They're the first Friday of every month. They focus on the opioid response strategic action plan activities. And there's several topics. In the past, we've had our upcoming one this Friday is actually on the Tech Spike Alert Initiative. And then we've had topics such as naloxone distribution network and our options campaign. Another initiative that we've really expanded was our Maine naloxone distribution initiative. This is basically provided multilateral naloxone distribution throughout the state. And it's boosted our multimedia public education resources and destigmatization around overdose. So our Have It On Hand, Know Your Options, and the inclusion of our OD MAP initiative. There's been over 100,000 doses of naloxone distributed since the project started. We've increased the access to MAT for incarcerated individuals. So OBH has supported the expansion of the DOC MAT programs. So every one of our DOC sites is now inclusive of an MAT program. We've expanded the MAT to residents at 9 of our county jails. We've developed a Maine model policy for MAT services to be implemented within the county jails that focuses on best practices. And we've also standardized the services provided in the county jails, and that's still a work in progress. A Strengthen Me campaign has been the behavioral health response to the COVID-19 pandemic. Basically, it provides supports to individuals. It's free and confidential emotional first aid, stress management, wellness, and resilience, connections to all kinds of resources throughout the state. The Strengthen Me call center provides emotional first aid connections to behavioral health providers. The main frontline warm line is healthcare first responders and education supports, as well as several other supports. This is the website if you'd like more information on the Strengthen Me campaign. We've also implemented, what's going on here? One-on-one and group support via community health workers, serving new Mainer populations, Black community, Latinx communities, Native communities, and older adults. We've had expansion of the Sweets Are Intentional Warm line, which is the peer support line. We've increased the NAMI text line, continued to support that. We've worked workplace wellness supports, providing free employee assistance and work-life programs to healthcare and public service agencies statewide. Behavioral health trained staff at 211 has been included in this, and funding for COVID-related outreach by contracted mobile crisis response agencies. Some of the initiatives that we have in development for the next year or so is the regional 24/7 walk-in crisis stabilization units. We've also designed of mobile crisis services that includes SUD response and harm reduction. We're also in the process of the development of certified community behavioral health clinics. It's highly integrated and coordinated mental health, SUD health, physical health care. There's certification standards that are involved to ensure the quality of that care. We're providing comprehensive funding for population health approach, and it includes outreach 24/7 access to the core services and also accepting all referrals. We're in the process of developing the SUD learning community. We're looking at low barrier MAT models to increase access to those types of services. We are looking at expansion of SUD residential to additional regions. We have a shortage of that, and there's been a few initiatives to expand those programs. We're working on a Somali community recovery initiative, and we're also in the process of implementing a stimulant use disorder pilot utilizing contingency management and community reinforcement model. And that's what we're doing among many other things here at OBH. Thank you.
Great. Thank you, Catherine. And just as you highlighted in your presentation, we've talked about before, one of the big resources for many of the providers here that you can take advantage of during COVID is the Strengthen Me program. And so really just a reminder to take care of yourselves and take care of those in your family and in your community. And there are resources available at the state level through the Office of Behavioral Health. I want to thank you for all the work that you've been doing and your whole team. And I will turn this over to Bobby Johnson, who's the Associate Director of Child Welfare Services at the Office of Child and Family Services. Welcome, Bobby.
Thank you, Amy. So I am here to speak on behalf of the Office of Child and Family Services and the ways that we've been supporting children and youth ongoing through this pandemic. So the Office of Child and Family Services, our North Star is that all Maine children and families will be safe, stable, happy, and healthy. And our practice model outlines the ways, our values and the ways that we do our work. So child safety first and foremost. Parents have the right and responsibility to raise their children. Children deserve to live in a safe and nurturing family. Children deserve a permanent family. And the way that we do our work is as important as the work that we do. We have 4 service areas that are designed to meet the needs of Maine youth and families. We have the child welfare services, children's behavioral health services, child care services. Associate Director Alyssa Wynn is the individual who oversees both of those programs. And then we have children's licensing and investigation services, and Janet Witten is the program manager for that area. Systems collaboration is a necessary component of how OCFS and DHHS is able to do our work. So we collaborate both within OCFS, as you've heard today, and then also across state and community partners. And our program initiatives are designed to both support and strengthen the system and families. And knowledge of and support for these initiatives is important to collectively move forward. And this is just an example of some of those partners that we are collaborating with to support families. The Office of Child and Family Services is a part of the social safety net for children and families, and we recognize that our work is not done in a vacuum. Other factors such as domestic violence, substance use, poverty, mental health all impact child safety, and we continue to work as a department to build improvements across the system of care. And some of the ways that we've done that are by expanding the access and affordability of child care, increasing rates for main care services to expand accessibility to mental health and behavioral health services. We've been partnering with domestic violence and sexual assault advocates and the University of Southern Maine to conduct a system-wide need assessment so that when we think about domestic violence and sexual assault services, we're able to make sure that we have the right services in place for the survivors and to inform future funding and policy decisions. We are preparing for the implementation of the Family First Prevention Services Act. Maine was the first state in New England to submit its plan to the federal government, and we received approval for that plan on September 13th. And our implementation date is scheduled for this Friday, October 1st. And then in partnership, we continue to tackle the opioid crisis, including options, which Catherine just talked about, and being part of that, and focus on addressing substance use disorder in youth. A couple of the initiatives I'm going to mention today have longer presentations later in the conference, and so I'm just going to really touch on them at a high level. Family First Prevention Services. This is has two different focus areas. So one is prevention services for children and families and bringing additional trauma-informed and evidence-based services for mental health, substance abuse prevention and treatment, in-home parenting skills, and kinship navigator services to our state. And then also increasing the quality and appropriateness of residential care. So making sure that children that are in need of residential care are there for, it's intensive short-term residential treatment, that we reduce their placement in these types of settings in any way possible, and that we also are working in partnership with our residential treatment providers to enhance the quality of care for children in those programs and build an aftercare structure for when they leave those programs and transition back to their homes. We've been focusing on child health and well-being, and so we really have sort of three different phases. So we have the initial medical screen that when children enter care occurs within 10 days. Information gathering begins at this point. They have a visit with a physician or nurse practitioner, and preferably their own primary care physician. It's an opportunity for resource parents to get the medications that they may need or other medical equipment, and to understand the needs of the children. Immunizations are updated, lab work's completed. And then within 30 days, we are scheduling the comprehensive health assessment. We're also making referrals to CDS for children under the age of 3 and completing a pediatric symptoms checklist for children over the age of 3. They're evaluated by a physician or nurse practitioner and a psychologist or a social worker. So we're looking at both the medical and the emotional, behavioral, social, developmental needs of children, and a health plan is created from this visit. Ongoing, we are establishing a medical home for children, ensuring that well child checks, dental and vision appointments are happening, looking at and addressing developmental and behavioral health services and therapies as needed, and then ensuring continuous communication and follow-up with care providers. And this has been critical during the last 18 months as we've tried to ensure that the needs of children are met on an ongoing basis while our healthcare staff have really been trying to manage the pandemic at the same time as the ongoing care of children and others. Substance-exposed infants and maternal health. So OCFS captures and tracks extensive data regarding substance-exposed infants. On average, we receive 45 to 90 notifications that a child has been born substance-exposed per month. And we, in state fiscal year 21 to date, we have received notifications for mothers age 14 to 19. That's been 50 different notifications. And this is down from 58 in state fiscal year 20. The bottom of this chart shows the substance-exposed infant referrals received per calendar year. And I know that Erica talked a little bit about some of this data. And so this shows that trend line and the year to date for 2021. We've been working in partnership with other parts of DHHS, with hospitals and medical providers, with the Maine Moms Program, and with parents and others to develop our process for the Plan of Safe Care in Maine. This is another topic that there'll be a longer presentation on later. The Plan of Safe Care is federally required, and OCFS is the agency that's required to do the reporting back to our federal partners on this. So it's a plan that helps to ensure that families are supported, that safety, well-being, and best possible long-term health and developmental outcomes for substance-exposed infants, their mothers, and other family members are met. It identifies needed services and resources and helps to define the plan for how families will get connected to those services. And this plan can be created prenatally or immediately after birth. It should be created with the family whenever possible. And all families can benefit from a plan of safe care when we're thinking about how they're going to support their child once the delivery occurs. Within children's behavioral health, we have been working to ensure that families receive the services and supports they need to live safe, healthy, and productive lives in their home, school, and community. It's really important that we are able to connect children to the right services at the right time in the right place. We want to make sure that they're getting the least restrictive services in their homes and schools and communities whenever possible. We have a strategic plan and priorities that guide that work. I'm just going to highlight one area in particular that I had mentioned earlier, and that was youth substance use disorder. So Maine youth rank 9th out of 50 states in terms of number of children impacted by the opioid crisis. And so 9th is not a good ranking. It also includes any sort of impact that a child might have experienced. So it's not just their own substance use. It could be a parent who has, used substances. It could be coming into child welfare custody as a result of substance use disorder. It could be a sibling that has issues with substance use disorder. So there's many different ways that youth are impacted. It could be a child who has ingested substances, and that's what this is reflecting. So 38 out of every 1,000 children in Maine are affected. The Office of Child and Family Services works closely with the Maine CDC to meet the substance use disorder needs across the continuum of care. And so within the Office of Child and Family Services and the Maine CDC is really responsible for promotion, prevention, and then OCFS is responsible for treatment and recovery services. It's a collaboration that we work on together as well as with our community partners. We've hired a dedicated staff person to analyze and research the current system of care for youth with substance use disorder. We've applied for 2 federal grants to address gaps that are identified. We're currently working with the Office of Behavioral Health on a training for adolescent medically assisted treatment. We're working with community providers to provide additional training on medically supervised withdrawal, evidence-based health treatment services for adolescents. And then through a grant that we received, the Mentor Me grant, we are supporting youth affected by the opioid crisis and drug addiction. We've applied for this grant. We hope to hear this week. And there's a proposal to supplement Big Brothers and Big Sisters with a focus on youth affected by substance use disorder and experiencing homelessness. If this grant is awarded, it would kick off on October 1st and would be funded for 3 years. And all of this, the Office of Child and Family Services has done within the context of the pandemic. I just wanted to, end by highlighting some of those guiding principles that we've used as we've made decisions about how to adapt our practices and our policies in order to best continue to serve families and children. And so we've used the data that we've gotten from the CDC, from our own office metrics that we've kept related to the number of children who have tested positive, the number of staff and resource parents. We've worked to ensure the health of children, families, stakeholders, and also our staff. In order to respond, we need to have a healthy workforce. We've done this in close collaboration with public and private partners and have relied on each other in order to continue to accomplish our mission and to make sure that children are safe within our state. And we've been committed to protecting the most vulnerable as we've responded. Here's my contact information, so if there's any questions, I would be happy to answer any of those questions. And I appreciate the opportunity to present today. Thank you.
Thank you very much, Bobby, for the presentation. It is wonderful to hear all the work happening at the Office of Child and Family Services and a lot of the new initiatives that are happening. So thank you very much to you and your team. I'm going to turn now to Ariana Whiting, who is the Early Intervention Program Manager at Child Development Services, and we are pleased to have the partnership of Child Development Services across many of the programs at DHHS and Department of Education around early intervention services. So welcome, Ariana.
Thank you so much. And thank you everyone for being here. I'll just share my screen. So I thought I would start just by kind of getting us grounded in the work that CDS does every day. And I think that that is the primary kind of way that we are supporting maternal and child health. I'm sitting in for Jamie Mch, who is our Part C coordinator for the state of Maine. And I work for the Early Intervention Program, as you mentioned, Amy. But I also want to make sure that I touch upon Part B, we call it 619 services. I might refer to these as Part B and Part C because those are kind of the law in the Individuals with Disabilities Education Act, which is what we follow. And of course, we are focused on child development, but just the way that our work occurs, we support the entire family. So CDS is comprised of 9 sites across the state. If anyone would ever like to refer to CDS, I put the link here to find out which site covers the geographic location that you may be in. But at the end of the presentation, I will also give our state number so that you could call and make a referral or go online. And then the state will kind of siphon your referral to the appropriate site. So I recognize that we're here to talk about maternal health, but I also wanted to kind of bring up that CDS follows a line in the Maine Unified Special Education Regulations that essentially outlines that we provide services where the child lay their head. So I certainly won't stray too much from maternal health, but I also wanted to recognize that we work with all sorts of different families and caregivers. And I just jotted down some words that someone might think of when they think of maternal. But especially in Maine, we have a very high incidence of kinship caregiver placements, whether that's formally through DHHS or kind of more informal. So I just wanted to kind of outline that we're thinking about supporting children and families in addition to moms that may be experiencing substance use disorder. So this study, I took all of these points from a study that was done by Alexa Craig, actually, if anyone's familiar with her. She's a pediatric neurologist in Portland. And I really just wanted to highlight attachment and how important that is with all caregivers and children, but specifically that this study found that there's kind of a reciprocal relationship, of course, between the mother and the baby, and that kind of the challenges inherent in substance use disorder and the symptoms of the baby with NAS kind of create a little bit of a challenge in that initial attachment. And I also wanted to kind of highlight how, as providers, the way that we approach our work can either contribute to a parent's feeling of guilt and shame or helping them feel really supported. And this study showed some ways that families feel supported is receiving some ongoing education before their baby is born and then after birth on their diagnosis, and consistent communication with providers. So that leads me to share just a little bit about CDS and the work that we do and how we do it. Our whole model is based on kind of supporting that attachment, meeting families' basic needs, and creating a relationship with one consistent provider so that that family really has that constant communication and that support with one consistent person. And so we have two roles at CDS. One is the PSP primary service provider in the early intervention program. And then we have service coordinators who are essentially educational case managers. And the work that the PSP and the service coordinator do together is really the meat of what we do. And I think the best way that we support moms, families, and little babies. So we help families a lot with accessing resources or identifying resources in the community. Sometimes the primary service provider might go to outside appointments with a family if they're feeling really nervous. And then in addition to just the primary service provider, we have a whole team of people that they can call upon if they need kind of to bounce ideas off of each other in the weekly team meetings that we have, or if they'd like to bring someone out with them. We try to look at the whole child in all areas of development. And so in order to establish eligibility for our program, two of these people from two different disciplines to give different perspectives on the child's development do an eligibility evaluation using the Battelle Developmental Inventory tool. And we look at all areas of development, and there are different ways that a child can be eligible. But I really want to focus on our other path to eligibility, which we call established condition of risk. And essentially, we have a many-page list of medical diagnoses that research shows have a high incidence of being associated with developmental delay. And we can make those kids automatically eligible for our services. So for a very long time, NAS has been on this list, and that created some challenges for us making more children eligible and being able to support more families, because especially as the medical treatment shifted away from kind of medication withdrawal treatment and more towards the attachment-based treatments like the Eat, Sleep, Console method, children were receiving different diagnoses such as substance-affected infant and those related diagnoses. So we expanded our criteria to include those, which has been really wonderful. In addition, we very recently were included in the Cradle Me online referral system. Thank you so much. So this combined with some outreach initiatives that our regional staff and our state director, our state coordinator have really focused on, have increased our birth to one population so far this year. And I think that we do kind of attribute it to these efforts, especially as I believe that the birth rate in Maine is decreasing. So this is really great to see. So I want to make sure that I touch upon early childhood special education just a little bit, Part B, although I don't work in that program. But I think one thing that we've done that could benefit babies with the NAS diagnosis or that were exposed to substances in utero, we're kind of toying around with the idea of doing a repeated evaluation when a child exits early intervention and potentially enters into special education. Their intake process is just a bit different, and they look at very specific areas of need that are kind of reported by the parent and the primary service provider if the child has one. So in doing these exit evaluations, we'd be giving some really rich information to that team to make informed decisions about that child's educational future. And our kind of theory in early intervention, and it is proven by the research, early intervention is key, and the earlier the better. So our goal really is, we're not really devastated if a child is not eligible for special education services, since that hopefully means that they have kind of caught up. So we have been participating, some of us have been participating in the implementation of the ECHO model through University of New Hampshire in collaboration with the LEN program. We call it SCOPE, but it is supporting children of the opioid epidemic. And this is a really in-depth structured training program. And a lot of the faculty are actually presenting at this conference. They are brilliant people. And it has provided us with an opportunity to bring our staff together across the state and learn a little bit from New Hampshire providers. And we're learning a lot about kind of the social determinants of health and the societal factors that kind of can lead to a parent becoming dependent on substances and thereby lead to a child being born impacted. So that opportunity to bring people together across the state, site by site, has kind of led us to realize that we don't have a lot of opportunities for our providers to kind of get to know each other and support each other outside of our regional teams. So we are working on a couple of initiatives that we recognize that the people that are doing this work are compassionate, professional, brilliant people, but it's really hard work. So we want to make sure that we're providing resources for people to kind of feel supported, fill their gas tank, and just keep going and not burn out in doing this work. And as a component of that, we really want to make sure that our supervisory team has the skills that we need to support people ongoing. And I know we've talked a little bit about COVID during this panel, but certainly I think COVID and shifting over to mostly remote visits has been really challenging. So we want to make sure that we are gaining the skills to support our staff. So we have written into our budget for the next couple of years, a couple of formal training series that we're hoping all of our staff will choose to participate in. The Brazelton Touchpoint series is available, of course, online to anyone that wants to take it. But we are hoping to offer the opportunity to all of our staff to go through this to kind of support building relationships with families and supporting families with whatever they need help with, which is kind of what we do. And we are also doing the same with the newborn behavioral observation system. So this is an attachment-based relationship building tool between the child and the parent. And it really trains the providers to reinforce the wonderful things that parents are doing and point that out to them. So I've listed my references here. I consulted a couple of really great studies to get some of my information. And if anyone has any questions, please let us know. Or I'm not sure if people can see it with Zoom's features, but I've put our phone number and our intake form web address up at the top if anyone would like to refer to us or ask any questions.
Thank you very much, Ariana. It's a wonderful presentation, and I know that you're doing a lot of work at CDS to ensure that all children are able to access early intervention services. So thank you for all the work that you're doing.
Thank you.
Really appreciate it. Next, we're going to turn to Liz Remillard, who's the Program Manager for the Maine Mom Initiative at the Office of Maine Care Services. So welcome, Liz.
Great, thank you. So I am going to put my slideshow up. Okay, can see that? Thumbs up from somebody on my panel. Okay, great. Thanks, Leah. Hi everybody, I'm Liz Remillard. I am a program manager at the Office of Maine Care Services, and my role is to manage the Maine Mom Initiative. Maine Mom is a part of a national model to provide support and funding to our Department of Health and Human Services and our Office of Maine Care Services to design a service for pregnant and postpartum people living with opioid use disorder. This is one of our many accomplishments over the last year at the Office of Maine Care Services that we want to walk through and really talk about some of the upcoming activities that we're doing within this initiative. So Maine Mom has begun testing services at 16 sites across the state. We have had the success in the last 3 months of enrolling 25 patients and have a goal to reach 300 patients over the next year. So by July of 2022, we hope to see that we've improved the lives of at least 300 pregnant patients and or parenting patients within Maine Care living with opioid use disorder. Also, over the next year, you can see, you'll see updates to our Maine Care Benefits Manual. We'll have proposals for new rule changes and service updates to include Maine Mom as a part of that, a part of our benefits manual, and really allow an expansion of services and expansion of providers offering Maine Mom across the state. These 4 partners, Maine Health, Maine General, Northern Light, and Pines Health Services, have been working with us over the last 2 years to really test how we can integrate maternity care and substance use treatment services for pregnant people across the delivery system. And the ways that we have been working through that and designing this service is looking at whole person care and paying for a service that provides a team-based approach to care where you're integrating a substance use treatment provider with a maternity care team, inclusive of recovery coaching and counseling services for a person. And the big piece that Maine Mom is looking at is the coordination of care related to a pregnant person and an early parenting person's life, including the infant needs as well. So social support services and perinatal care are really the forefront, as well as connecting to that substance use treatment service. So I just mentioned a few of the core services for Maine Mom and what a person can expect when they enroll in a provider, enroll in our program or is being provided care by one of our Maine Mom sites. There's an offering of peer services where a person can have access to group counseling, as well as recovery coaching, access to medication for addiction treatment, so medications for their opioid use disorder, as well as referrals and care coordination with supportive services like Maine Families or public health nursing, many of the programs that we've already heard presented by the panel. There is an expectation of our Maine Mom sites to have frequent communication with those supportive services and the care providers that can help a person during the prenatal and postpartum period, including partnerships with birthing hospitals. delivery care services are not included as a part of our Maine Mom core set of services, but that partnership with the birthing hospitals is. So what we expect of our Maine Mom sites is supporting a person in understanding what is expected within that delivery care, within the labor and delivery, that their education about the substance exposed infant notification, that is a law within our state. And then also having the birthing hospitals that they're partnering with practice evidence-based cares like Eat, Sleep, Console. You've just heard Ariana mention that, as well as pain management protocols for people who live with opioid use disorder, because during that labor and delivery process, that's a really important consideration. As well, in our expectations for Maine Mom services, we expect our providers to have conversations about family planning and contraceptive care as a person is entering into early parenting and either expanding or starting their family. Maine Mom over the last 2 years and Maine Care as a part of that has engaged many stakeholders through conversations, meetings, large group gatherings to give input and insight into the design of our services. This also includes intentional inclusion of voices of parents in recovery. We convene a monthly group of people who identify as mothers to give their perspectives on the way that we are intending to design services, enroll people into our programs, as well as other initiatives. Many of the initiatives that you just heard about have been supported by these parents in recovery. It's a really valuable resource that we're really proud of. So as I had mentioned, Maine Mom has just begun to launch services in July of 2021. We're really excited to promote mainemom.org, which is our referral resource, which allows anybody, the public and other referring providers, to find a Maine Mom site. And additionally, we have added to our Cradle Me referral, state referral system, Maine Mom Services, and an actual staff person who can be a supportive liaison to connecting people to a Maine Mom site. And just yesterday, we have launched a public awareness campaign to help people find a Maine Mom provider, to bring awareness about substance use in pregnancy. And before I close and pass off to my partner, Leah, I wanted to play a clip that you might be hearing on the radio related to Maine Mom and how to find our services.
My name is Sarah, and I'm in recovery. I always thought that if I got pregnant that I could stop, but that wasn't the case. I realized how sick I would be without those drugs. And so you do anything that you can to not feel that way. If I can do it, so can you. Pick up the phone and ask for help. It's hard, but you can do it.
Substance use disorder doesn't get to write the story of your pregnancy. You do. Take
the first step today and visit mainemom.org is how our ad finishes, or our public awareness campaign finishes. I would encourage any of you who are interested in learning more about Maine Mom to visit our website, mainemom.org. There you can get access to our state website and state resources for clinicians and partners, and find ways to learn more and communicate with our team at Maine Care about our initiative in the future. So now I'm going to pass this over to Leah, who is our partner at the Office for Family Independence, to talk about some of the upcoming Maine Care eligibility changes that we're really excited to let you know about.
Good morning. Thank you, Liz. I'm Leah Studholm. I'm with the Office for Family Independence, and we are responsible for the eligibility and enrollment functions of Maine Care or Medicaid. So here at the Office for Family Independence, two of the things that we're seeking to do for pregnant women is seeking federal approval for changes to our Medicaid program. So the first one will be to seek a state plan amendment through our Children's Health Insurance Program to create a coverage group for pregnant women who would be eligible for Medicaid, but for their immigration status. So this coverage group allows pregnant women, regardless of citizenship or immigration status, to access prenatal care for the health of their unborn child. And then the second option we're looking to include is to extend our postpartum coverage. So currently, states can only provide Medicaid coverage for 60 days postpartum, but the American Rescue Plan Act created a new option for states to extend that postpartum coverage from 60 days to 12 months. This option provides a full Medicaid benefit during the pregnancy and the extended 12-month postpartum period. And then once enrolled, it continues until the end of the postpartum period, regardless of changes to the individual's income. Go to the next one, Liz. So Maine isn't alone in this effort to expand coverage. There are other states that are also moving forward, and prior to the American Rescue Plan option, the only way that states could extend this coverage is through a waiver via CMS, which is a long, more complex avenue for changing coverage. There were a few states that managed to get through the approval process in blue or seeking approval. But now that it's a state plan option, there are many more states, those listed in orange and yellow there, that are moving towards extending the postpartum coverage through legislation or have expressed interest in submitting a SPA. And next. So if you want to follow up on these upcoming changes, as OFI submits state plans or proposes rules for implementing programs to provide coverage and access to care, they will be posted on our rulemaking website. That's it. Yep. Thank you very much.
Thank you.
Great. Thank you very much, Leah and Liz. We really appreciate your presentation and all the work that you're doing. There's wonderful work happening at the Office of Family Dependence, as well as with Maine Care, supporting women, children, families, and caregivers. So thank you very much. We just have a couple of minutes, 4 minutes before the end of the panel presentation. We've had a few questions around the data, so I thought we might start with Erica Lichter, just to try to answer some of the data questions. One question, Erica, for you is thoughts on why NAS is lower even though substance use stayed the same during the time period?
I think you're referring to the prenatal opioid use disorder didn't change, but neonatal abstinence syndrome diagnoses seem to decrease. And to be honest, these data come from Maine's hospital discharge data set, and they're based on ICD codes that are provided by those hospitals based on diagnoses made by medical providers. So it could be that they're using different criteria to diagnose whether someone has a disorder related to opioids versus whether or not an infant has been exposed to opioids and then demonstrates symptoms of neonatal abstinence syndrome, which is the most likely explanation. And as far as I know, there's not necessarily, we're not clear whether or not providers are using the same definitions for those diagnoses, and whether or not there are set criteria for whether or not a provider chooses to diagnose someone with either an opioid use disorder or an infant with neonatal abstinence syndrome.
And here's another, I think, definition question that's being asked, just in terms of how is the diagnosis of NAS versus now being picked up? What criteria is being used, and how are you using that from a data perspective?
So as I mentioned, we're using the definitions of neonatal abstinence syndrome that are recommended by the Health Resources and Services Administration. So there are specific ICD-10 codes that are in the hospital discharge data for that, and I'd be happy to provide those codes for anyone who's interested. That may be different than excuse me, the NOWS, the opioid withdrawal definition. I can look into that, but we typically use the federally recommended definition for NAS.
And generally, the providers are using a clinical definition when they use the NAS or NOWS in their both diagnosis and also billing codes. One thing that just generally we have seen with the Eat, Sleep, Console program being implemented at all the birth hospitals is that there are a much lower number of children who are getting pharmacologic treatment for those withdrawal symptoms. Most of the treatment being offered at the hospitals is non-pharmacologic. So around eating, sleeping, consoling, comforting, working with families around attachment. So that is something that we have seen over time with Eat, Sleep, Console. This may be a question for you or Bobby. Bobby, these are around the SCI notifications. In terms of breaking down the numbers, do you know how many of the SCI reports are for moms that are in medication-assisted treatment versus those that are using illicit substances?
We don't have it broken down in that way yet, Amy, but it is something that we are trying to capture.
And then with SCI notifications, if there's a parent that's less than 21, are they considered to have illicit substance use because of just the age of when substances are legal in the state?
I think that is a great question. I'm not sure we break it down to that level, but I'm going to follow up on that as well.
Great. And
because we capture the substance that's used at this point. So I don't think that we break down, like, for example, if it's marijuana, I don't think we're breaking it down by age of parent. But that's certainly something we could look at. And then we don't have it within our system, whether it's illicit use or not.
Mm-hmm. Another question is just around polysubstance use. I'll just make it more of a general question. How much are you seeing polysubstance use impacting substance exposed infants versus a single substance use?
That's for OCFS, Amy.
That's for you. Yep.
Okay. I think it's quite common. I don't have the numbers in front of me, so I don't want to try to present any data, but I think it's common that we see polysubstance use as well as single use.
Great. And I'll just for the large audience, the Office of Child Family Services does release data on an annual basis around the substance exposed infant notifications. In that report that is public, they do break down the substances, types of substances, and they provide more information. So when that report comes out, that is something that can be shared publicly so people can get more information. So I want to wrap us up today to make sure that we have time for our next keynote speaker. I know Dr. Stephen Patrick is joining us in a few minutes with Gordon Smith. So I want to thank you all on the panel for joining us today and talking about the programs happening at the state level. And I want to encourage all of you in the audience to reach out and connect with us so that we can continue to build very strong early childhood systems. So thank you very much for joining us today. And we look forward to seeing you all in a few minutes for the next panel. So thank you.
Time when I was 22 years old, so I may have been 21. And this was like in the middle of my addiction. It's funny because I thought that becoming pregnant would be the cure-all, that for one reason or another I'd be able to stop using. You know, it wasn't like I wanted to continue to use every day. I just didn't know how to live without it. And, you know, part of me believes that substances kept me alive because, feeling alone and isolated and just the sadness and grief that I felt really kept me disconnected, because a month after I had my daughter, my best friend committed suicide, and that was it. I was off and running again for 2.5 more years. And the next time I got sober, it was because I had lost jobs. I was evicted from the place that I was living. I was bouncing from place to place, living out of my vehicle. Just a place of complete desperation and hopelessness, feeling like I was not worthy of living. And at this point, my grandmother knew that I went to detox. She said that Me, my daughter, and my boyfriend could go stay in her basement, which was really incredible in itself, because a few months before that, this was like, one of those things that really pushed me to get recovery, is that my grandparents have always been a staple in my life. They've always been the safe haven for me. Like, no matter what, they provided me with unconditional love and support, and were always available. And my grandfather passed away a couple months before I went into detox, and I had gone into my grandmother's purse and stole money that was given to her for funeral arrangements. And I remember that moment still today, because I stood outside of her door and just put my head down and said, "Chantel, go put that back. It's not yours." But the other piece was like, you're going to be sick and you have to get to work, and you just pay it back tomorrow. But tomorrow comes and I'm in a deficit again, and there is no paying it back. So for her to still allow me in her space after I had done something like that was incredible. Like, a lot of times people who are in recovery or with substance use disorder are not trusted because we break trust. Not because we're bad people, but because we're sick people. Recovery has taught me that my purpose can just be this. It can be to share my story. It can be to provide hope. It can be that I just get to be a kind person today. I've learned that I don't have to have this magnificent purpose or super special skill. What I would say to healthcare providers or anybody that is helping or supporting or treating somebody with substance use disorder is that we're human. We're people. There's been instances where I walk in and I'm instantly judged because I have a background of medicated assisted treatment, or because I have a background of substance use disorder, or because I have legal records, right? Like, all of a sudden I'm this person that doesn't care about my kids, or that I'm somehow a bad person. And we're not bad people, right? We're not bad people. And we have gotten into this place where we're unaware of how we're treating people. I think most people have really good intentions. Most healthcare workers have really good intentions. They wouldn't be in the field if they didn't want to help people. But sometimes we overlook, like, simplicity. We overlook really checking in with somebody instead of, like, what's wrong with you? Why did you do this? Like, how are you? What's going on? What happened to you, right? Because these people that are coming in today were once children and probably have trauma, probably have some things that nobody's asked them. What happened to you? How did this happen to you? My name is Chantel. I'm a person in long-term recovery, and I think the most important part is that I'm a person, I'm a human, I'm a mom, I am a daughter and a granddaughter and a sister. I am so much more than a person who is no longer using substances.
Good morning, everybody, and again, welcome. I'm Dara Fruchter, Project Manager, Infant and Maternal Substance Use Prevention Coordination on both the maternal and child health and prevention teams at the Maine CDC. It's an honor and a privilege to have the responsibility of planning and overseeing Maine's annual Maternal and Child Health and Substance Exposed Infant Conference. Along with the support of a planning committee and countless colleagues, both within DHHS and beyond, our planning meetings for this conference began this past spring. However, we'll start thinking and talking about our 2022 conference this fall. So if you have an idea for next year's conference, a topic you'd like to see highlighted, or know someone who wants to share their recovery story, I'd love to hear from you. I also lead the Substance Exposed Infant Internal Work Group, the Substance Exposed Infant and Maternal Use State Steering Committee, and Maine's Substance Exposed Infant Community Collaborative. There is ongoing collaboration on initiatives focused on substance-exposed infants and pregnant and parenting individuals living with substance use disorder within and between all DHHS agencies. This collaboration also extends outside DHHS to other state agencies and community partners statewide. Again, I would love to hear from you if you have thoughts or ideas that can inform our work. You'll find my email in the chat. It's now my great pleasure to introduce Mr. Gordon Smith, Maine's Director of Opioid Response. Governor Janet Mills appointed Gordon to this position in January 2019. He is responsible for coordinating and directing Maine's response to the opioid crisis, including prescriber education and reduction of opioid prescribing, prevention and treatment of substance use disorder, and harm reduction strategies. He stepped down as the Executive Vice President of the Maine Medical Association in January 2019, where he had served as its Executive Vice President since September 1993, and where he began as General Counsel in 1981. Welcome, Gordon.
Well, thank you, Dara, and thank you to all the attendees and for the tremendous work that you do. It's been an excellent conference. I've been really proud to be a part of the conference in 2019 and 2020 and today. I have the very I have the pleasure today of being able to introduce our keynote speaker this morning, Dr. Stephen Patrick, one of the nation's leading experts on opioid use in children, opioid-exposed infants, and women with opioid use disorder. He's also got a deep interest in state drug policies and federal drug policies. Currently, Dr. Patrick is the director of the Vanderbilt Center for Child Health Policy, an associate professor of pediatrics and health policy at Vanderbilt University School of Medicine, and an attending neonatologist at Monroe Carroll Children's Hospital at Vanderbilt. He currently serves as an adjunct physician policy researcher at RAND Corporation and is a guest researcher at the Center for Disease Control and Prevention. He's a graduate of the University of Florida, Florida State University College of Medicine, and Harvard School of Public Health. He completed his training in pediatrics, neonatology, and health services research as a Robert Wood Johnson Foundation clinical scholar at the University of Michigan. His research, funded by NIDA, focuses on improving outcomes for opioid-exposed infants and women with opioid use disorder and evaluating state and federal drug policies. He previously served as Senior Science Policy Advisor to the White House Office of National Drug Control Policy, affectionately known to all of us as ONDCP. He has received many awards. He's on many advisory panels. And in the interest of time, so that you hear from him and not just me, I'm going to turn this over to Dr. Patrick. Welcome to Maine virtually, Dr. Patrick, and we look forward to your talk. The only remaining thing for me to say is that questions should be put in the chat room, and at the conclusion of Dr. Patrick's talk, I will toss those questions to him, and we'll have as much as a 15 or 20-minute discussion following his lecture. Thank you for being with us today.
It's an honor to be here with you, and I do wish it was in person, especially this time of year. I can't imagine how beautiful it is in Maine as the weather's getting slightly cooler and the leaves are changing. So here's hoping once we've settled this pandemic thing, we can visit in person and talk. It's really an honor to be here, to be a part of this pretty amazing agenda and talk a little bit about this issue that I think we all care so much about, and talk about some of our work as well. First, I have no conflicts of interest to disclose. I want to talk about a baby I saw a couple of years ago, caring for in the neonatal intensive care unit. This was an infant born at term, and he, about 48 hours of life, started having some clinical signs that seemed pretty consistent with withdrawal. He was irritable, He was sometimes unconsolably crying. He had pretty rapid weight loss, about 10% by about 2 days of life, and was in the newborn nursery, and I work in the neonatal intensive care unit. So he, the folks there talked to his mom about substance use, because it seemed like, there may be some substance exposure, and she denied any substance use. Fast forward a little bit of time, this baby was transferred to our intensive care unit where I took care of him, and we were able to manage his clinical signs without using any medicines. But I remember pretty distinctly a couple days after the baby transferred up and the drug screen came back positive from the umbilical cord for buprenorphine. And I remember walking into that room, and I got down on one knee, as I sometimes do when I break news that I think is going to be hard for parents. And I talked to the mom about the drug test. And the first thing she said to me was, "Am I going to lose my baby?" And the truth is that we push people away from care. Too many stories that we hear from women. So why would a woman be using buprenorphine and then not be forthcoming about that use? Often what I hear, or they can't get into treatment, or there are barriers to getting into treatment. There's intense stigma about treatment, and there's fear of talking to folks like me, fear of going to an obstetrician, and those barriers make things harder for both pregnant women and infants. And that's a little bit of what I'm going to talk about today. You have to have healthy babies. You have to have healthy moms too. It really is about taking care of moms and babies collectively. So that's where I'm going to begin our talk today. So first, I'm going to talk about substance use and pregnancy overall, and then a little bit about treatment. We'll talk about neonatal opioid withdrawal syndrome, also known as neonatal abstinence syndrome. I'm going to dive into communities and trauma, and we'll talk a little bit about some of our team's research. Some changing child welfare policies. I really think there's a lot of potential in the way that the child welfare system is potentially evolving. And then Firefly, which is our Tennessee mom model. We'll talk a little bit about that we have here at Vanderbilt. So first, beginning during pregnancy. I'd like to begin overall. Look, we are very focused on the opioid crisis, and we should be focused on the opioid crisis. We've seen, again, another year of record-setting overdose deaths. But oftentimes we fail to look broadly. We know that substance use in pregnancy is not that uncommon. Around 8.5% of pregnant women use some illicit substances. And then importantly, about a quarter use legal substances. And these legal substances we oftentimes forget about. Tobacco is very common. I mean, you just ride the elevator in my children's hospital and you can smell the smell of tobacco riding up the elevator. Alcohol is very common. About 1 in 10 pregnant women still use alcohol. And we know that alcohol is the #1 preventable cause of developmental delay in children. One thing that's also important is that use in pregnant women is still far less than women of reproductive age of the exact same age. And this is because pregnancy is a time when women are seeking treatment. And that's one of the reasons why it's important for us to make it available for them. I think it's important that we have a broad view, because here's hoping, I'm a pediatrician, so I'm an optimist, that we're soon going to get control of the opioid crisis. But how are we going to respond to the next crisis, the next substance use? We have to have a broad view of substance use in pregnancy if we're really going to serve families well. It's important to note too that younger women have higher rates of use, higher rates of substance use. This is true of pregnant or non-pregnant, including tobacco and alcohol. But of course, we're here to talk about the opioid crisis, and this is a graph that's probably pretty familiar to everyone here today. The opioid crisis has had 3 waves. I've heard some folks talk about it like a 3-layered cake, where we first began with prescription opioids, then the rise of heroin, and then the rise of synthetic opioids like fentanyl. And then, of course, in many communities, we're seeing this combination of stimulants with opioids. And this has been variable around the United States. I mean, notably, the Northeast has been talking about fentanyl far before communities like in Nashville. But Nashville, like many other communities now, fentanyl really is the leading cause of death. Far more available, far cheaper. The treatment does work. And, I find myself oftentimes in conversations with folks talking about treatment. And in my community, one of the things that I hear really commonly is that we should be tapering women off of medications for opioid use disorder to prevent drug withdrawal. And I think that's problematic for a bunch of reasons that we'll talk about. But one of it just misses the forest for the trees a little bit. You have to step back and think about, why are we treating pregnant women with medications for opioid use disorder? The literature is pretty clear on this. Buprenorphine and methadone, those are the two most common studied drugs for medications for opioid use disorder for use in pregnancy. Here's what we know. We know that they decrease risk of overdose death in pregnant women, relapse, hepatitis C, and HIV. Infants whose moms use medications for opioid use disorder are more likely to go to term, have higher birth weights, but that does come with some risk of drug withdrawal. The way that I think about it is this: if you are a pregnant woman and you are injecting heroin, you're going through these rapid cycles of intoxication and withdrawal, intoxication and withdrawal. That increases your risk of overdose death, and for your infant, that's very stressful. So what these medications do is they level that off, and they allow moms to get into recovery, and they make it more likely that the infant is going to go to term. One of the things that's really important here is that babies that are very preterm really don't exhibit signs of drug withdrawal. So we focus often on this portion of babies that are healthy enough to be born at term that have drug withdrawal. And we forget about the portion of babies that are born very preterm because their moms didn't get into treatment. So seeing infants exposed to heroin at 25 weeks, for example, born several months too early, we may see those infants if we don't get moms into treatment. And we fail to capture those infants in our state surveillance systems and our hospital billing data because they don't develop signs of withdrawal. So what we're doing when we treat moms, we're making it decreasing her risk of overdose death, and we are trading those very vulnerable, very preterm infants for bigger infants who have drug withdrawal, and that's a pretty good trade. So we know this works well, and so how are we doing with getting folks connected into treatment? Here's an email I got a couple of years ago from a community pediatrician that said, "Hey, this mom just delivered, and she was on Suboxone during pregnancy, but now she's having difficulty getting those resources, getting treatments, and wanted to know if I had any connections to try to connect her." What's an interesting question, because some organization paid for the delivery, whether it was private insurance or public insurance, but this woman couldn't get treatment. And why is that? So it's part of these stories for women that we wanted to understand what were real world barriers into getting into treatment. So along with my colleagues here at Vanderbilt and Rand and elsewhere, we did a randomized field experiment. We essentially had secret shoppers. These were actors attempting to get into treatment. Half were pregnant, half were non-pregnant, and then among them, they were randomly assigned to either have private insurance or public insurance, Medicaid. And if their insurance was refused, then they offered to pay cash. To get the lists of who you should go to for treatment, we used SAMHSA's buprenorphine locator. This is a slightly different version. Today, it's at findtreatment.gov. This is a publicly available list of treatment access, and it's where HHS often says, go here if you want to find treatment. So all in all, we had around, and we called 10 different states. We had 10,000 secret shoppers, and these are obviously these are attempts to call, and about 30,000 attempted calls. Here's what's striking. If you just start at the very top of this, it was really hard to get someone on the phone. Using that list, we had about 25% where we called 5 times or more and weren't able to reach someone on the phone. About 20% of the time, they were able to reach a medical office that didn't provide addiction treatment. So what does this suggest? It suggests that someone got the training to be waivered to prescribe buprenorphine, but they have decided not to prescribe. And then a couple other reasons why we didn't get through, like disconnected or invalid numbers. Interestingly, when we called on this list, sometimes we would get a provider's cell phone. I think we got a lawn service company at one point. So the list does have some issues. But if you look at completed calls, around 3,400 were completed. And then you can see our randomization here. Randomization was pretty good. So we're pretty balanced between pregnant and non-pregnant and by insurance. So here's what we found. We first found out that it's hard to get into treatment, but it's harder if you're pregnant. If you look at buprenorphine prescribers, for example, here you see overall that pregnant women in blue compared to the orange color are about 17 percentage points less likely to be accepted for treatment than non-pregnant women. And then we looked at a combination of states, and these states were selected based upon variations in opioid population, opioid deaths, as well as policies. And you see some difference in some states between pregnant women and non-pregnant women. So for example, in Florida, you see a pretty reasonable difference in getting in compared to Virginia, where you don't. The other important piece is that we called opioid treatment programs too. These are methadone clinics. And we found essentially no difference in opioid treatment programs and ability to get into treatment. But here's one of the striking things that we found. We found it was slightly harder to get into treatment if you paid with Medicaid, or if you were insured by Medicaid. But that wasn't the big difference. The big difference was that many providers didn't accept any insurance whatsoever. So among callers that were buprenorphine, that were calling buprenorphine providers, only about 40% were able to get into the appointment, regardless of insurance type, regardless of pregnancy status, with their insurance. Overall, about 25% had to pay cash. And again, you see a lot of variability with a lot of cash pay in Florida and Tennessee, my home state. Opioid treatment programs are very similar. We only asked about Medicaid, and patients only presented with Medicaid just because of small numbers. And you see again, Missouri and Tennessee with high likelihood of just accepting cash pay only. And what's important about this is that first appointment for buprenorphine prescribers, for example, the median cost that was cited to secret shoppers was $240 for that first visit. That far exceeds what many of our patients can afford. But partway through, what we were struck by were the experiences that many callers were having. And so we did some work to understand what was going on. So when our callers called to try to make an appointment, they basically free texted about their experiences afterwards. We used that free text to try to understand what experiences they were having. We were having team meetings. Some of their experiences were pretty striking. Here's a couple quotes from providers to secret shoppers. People don't usually show up to their appointments because they decide they want to have one last hurrah on dope before coming. This again is someone who was able to get through the layers of not receiving it and no one answering the phone, finally gets through, and this is what they get on the other end on the first call. Someone heard, "Absolutely not. I would not treat you. This is a pregnant woman." Another one, "Whoa, we don't do that here. I won't get into that mess again." Another pregnant woman. "I was also told that if I didn't follow this protocol, I would go into convulsions and possibly kill the baby." Pregnant woman. Again, on the first call. So some important implications, I think, from some of this work. Accessing outpatient buprenorphine providers is difficult for all women. It just happens to be even harder if you're pregnant. We need to explore policies that enhance access, and perhaps that's reimbursement, training, but we have a ways to go here. The government lists of providers are not accurate and really should be audited. Cash payment and lack of insurance acceptance is pretty pervasive. We really are treating our substance use treatment facilities really separate from the rest of medical care, and that's problematic. There are some state policies that prioritize acceptance of insurance. West Virginia is one state that has such a policy that basically if someone has insurance, you have to take it. And we need to know if those policies are effective, and our group is doing some work to try to understand that. Okay, so I want to talk a little bit about neonatal opioid withdrawal syndrome, and these are the infants that I care for at the Children's Hospital. The first is a little bit of a terminology point. In some places, you'll hear folks talk about neonatal abstinence syndrome, others neonatal opioid withdrawal syndrome. We've started using neonatal opioid withdrawal syndrome in part because we just think it's clear. That's what we used in the American Academy of Pediatrics policy statement published late last year, about a year ago now, on neonatal opioid withdrawal. Several federal agencies like FDA and SAMHSA are also using this term. And in general, I personally think it's a little bit clearer. We're in this transition point, and so what you'll see here in a little bit is that I'm going to go back and forth based upon the study or what we're talking about, because we're in a little bit in flux. So neonatal opioid withdrawal syndrome is a postnatal withdrawal syndrome experienced by some opioid-exposed infants, not all. Prenatal factors are associated with either the development or severity of withdrawal. So for example, additional exposures. We know that if a woman is using an opioid or is even in treatment with buprenorphine and is smoking cigarettes, is taking benzodiazepines or gabapentin, that's more likely to increase the risk of drug withdrawal in the infant or make it more severe. Lack of access to treatment. When women aren't in treatment, it appears that things are more severe in terms of withdrawal for the infant. postnatal factors. We oftentimes miss these postnatal factors that also makes withdrawal more severe. Lack of standardization. This may sound silly, but it's completely true. Just doing the same thing in the hospital improves outcomes for infants. It makes it less likely that infant's going to need treatment for withdrawal, for example. Exclusion of the mother, including moms in treatment is important. We'll talk about that a little bit as well. But rooming in, there's good evidence to say if you keep moms and babies together, both mom and baby do better. Not allowing breastfeeding. If moms are not allowed to breastfeed, and there are some guidelines for when to breastfeed, that can also make withdrawal severe. So you understand here that this is a little bit of a mishmash of things that can make things worse or better prenatally and postnatally. So what does withdrawal look like? I think about it as where the opioid receptors live. So common GI signs are poor feeding, like the baby I mentioned earlier at the beginning of our talk, vomiting and loose stools that can lead to dehydration and poor weight gain. Some common CNS signs are tremors, shaking, hypertonia or increased muscle tone, irritability and decreased sleep. As a parent, I think we've all experienced some of this. So I usually describe babies that have withdrawal as a colicky baby times 5. Exaggerated reflexes. The very acute Moro startle reflex that babies do can be exaggerated. Less commonly, seizures can occur too in the literature, though clinically it's a pretty rare thing. Some autonomic signs like tachypnea or breathing fast, yawning, and dilated pupils. So what has happened in terms of neonatal abstinence syndrome and maternal opioid-related diagnoses in the United States recently? This is a paper that we published with some colleagues from HHS just a little bit earlier this year, looking at the national rates of drug withdrawal. So here's what we've seen, and no surprise to anybody in this conference, there's been a big increase in both. They've risen in parallel with essentially every other opioid-related complication. And you can take this graph all the way down to 2010 to see how much it's gone up. We've seen about a 7-fold increase in babies being diagnosed with drug withdrawal, for example. And about 1 baby is born every 15 minutes on average in the US with drug withdrawal. And a pretty similar increase in maternal opioid-related diagnoses at the time of birth. One important thing we see here is the ICD-9 to ICD-10 transition. It appears that we're detecting more moms in that after that billing code change. So here's what we see in terms of incidence of neonatal abstinence syndrome in 2017. You can see our area of the country, your area of the country has a high rate of neonatal abstinence syndrome. My birth state, West Virginia, where my family is from, where I spent the first part of my life, has the highest rate of neonatal abstinence syndrome. About 5% of infants in 2017 born in the state were diagnosed with drug withdrawal, which is a really striking amount. What about the change? This is the change between 2010 and 2017. So you can see here that there are some states like Oklahoma that have low rates, relatively low rates of neonatal abstinence syndrome, but saw some big increases. And in some cases, it's that shock, it's that big increase the community see that can be surprising. It can take hospitals off guard. I know it did for us early in the epidemic. So I want to talk a little bit about evaluating definitions. I sort of alluded to this earlier, and it is that we sort of struggle with really defining what we're talking about. And this was a paper done by one of our residents here recently. We have no standard clinical definition for neonatal abstinence syndrome, even though there have been some recently released standard surveillance definitions, but they really rely upon billing codes in many cases. We used a known cohort of opioid-exposed infants that we've cared for here at Vanderbilt and applied different definitions to them to try to understand, does it change your ability to detect opioid-exposed infants and infants that have drug withdrawal based upon how you define them? So the common clinical definitions we used were any opioid exposure, the Finnegan score. This is the most commonly used score for diagnosing drug withdrawal in the US right now. Treatment with morphine, did you require treatment with morphine? A clinical diagnosis, so a pediatrician said, yep, you've got neonatal opioid withdrawal syndrome. And then common surveillance definitions, like Tennessee surveillance definitions and the CTSE, this is the state and territorial epidemiologists, their definitions for drug withdrawal too. So here's what we found. Identification of infants, again, with a known cohort of opioid-exposed infants, ranged from 17% if you used morphine as your definition, which some institutions do, to 53% if you use the diagnostic code for opioid withdrawal. Regardless of how you cut this, it doesn't matter how you combine things, you're missing a lot of infants if you just focus in on drug withdrawal and depending upon your definition. Notably, we only diagnose about 21% of a known cohort of opioid-exposed infants with drug withdrawal. If we extrapolate this nationally, including the data that I just presented about national estimates, we may overestimate neonatal abstinence syndrome and underestimate opioid-exposed infants nationally. We really don't have a good system to capture opioid-exposed infants that don't develop drug withdrawal. And some literature suggests that they may be even more at risk because they aren't identified, connected to services. But broadly, we have this need for a gold standard definition. It's really hard to have a good surveillance definitions. It's really hard to identify who you need to connect to public services if you don't have a good clinical definition. There is some work that's being done about that right now within HHS, but we still have a ways to go. Okay, for infants who are diagnosed with drug withdrawal or opioid-exposed infants more broadly, what's our goal for their care? It's to control the withdrawal. So our goal is to minimize complications like seizures, and that begins with non-pharmacologic interventions. So environmental controls like rooming in with moms and babies together and breastfeeding where it's possible. For severe withdrawal, this is withdrawal that doesn't respond to those initial interventions. We use morphine or methadone. And in some institutions, there's good evidence that buprenorphine can also be used too. But basically, you use an opioid to treat opioid withdrawal in newborns, and you slowly taper the dose over time. But even though I've said a lot of things about where we are and how we're lacking some standardization in our approach, there have been some important innovations. I'll mention Eat, Sleep, Console, and probably in units in Maine, you're seeing this now. Most centers use some modification of the original Finnegan score that was developed in the 1970s. More recently, we've seen a score that began with some colleagues at Yale, and in large part, many centers in the Northeast is where this really began. And it really just asks a simple question: can the baby eat? Can the baby sleep? Can she console? Then she's probably all right. What we see from centers who have done this, they have lower rates of treatment with morphine compared to the standard treatment using Finnegan. But the question is, we need to figure out what's the right amount of morphine, and we really need to rigorously study this. Most of the Eat, Sleep, Console literature is based upon the quality improvement literature. Notably, NIH has a trial right now, ongoing right now, to evaluate Eat, Sleep, Console, and that's important. Rooming in. While it seems like that should be a no-brainer, or maybe it seems to you that it shouldn't make a difference at all, it really does seem to make a difference. A nice meta-analysis found that rooming in, infants who roomed in with their moms were less likely to receive morphine for treatment and had shorter lengths of stay. I've seen this in my own clinical experience when we were still caring for infants that were opioid exposed in the NICU, which we don't any longer, and I'll talk about that in a minute. I was in part of our unit where moms and babies can't room in. It's just the way our unit's set up. And I had a baby who was about 4 weeks into treatment, was on morphine, phenobarbital, and clonidine, and still not terribly well controlled. I moved that infant over to a part of our unit where mom can room in. And I'll never forget, this mom was there pretty consistently, holding this baby, consoling this infant, and we pretty quickly started weaning off medications. And I think oftentimes what we're treating is mom withdrawal, not drug withdrawal. And so much of this is we've really kind of over medicalized something that I think that's an issue with how our approach has been, and it's starting to correct. There is some recent 2 randomized controlled trials suggesting that both methadone and buprenorphine may reduce length of treatment for neonatal abstinence syndrome compared to morphine. Standardization works. One of my favorite examples of this is the Ohio Perinatal Collaborative. This is now, the study's getting a little bit old, 2014. They set out to look at what makes things better in terms of infant treatment, morphine or methadone. They found no difference by the medication, but they found that hospitals that standardized what they did, they followed a protocol every time, had a length of treatment that was about half. So 17 days versus 32 days. Similarly, the Vermont-Oxford network, many hospitals we were involved in. This is 200 hospitals, mostly in the United States, but also in Canada, participated in a collaborative to improve care. Hospitals involved in that collaborative improved the standardized the care that they delivered. And in that group, there were decreases in length of treatment as well as length of stay in hospitals. Well, to summarize this part, neonatal opioid withdrawal syndrome has increased substantially over the last 2 decades, but it may be plateauing. I think the question is, what has happened during COVID? We have some lagging data, and I do think there's some worrisome trends that we've seen during COVID. There's really some urgent need to standardize clinical diagnoses and criteria for neonatal opioid withdrawal so that we can compare outcomes between states, between hospitals, for clinical trials, you name it. An exclusive focus on NALs may miss most opioid-exposed infants. If we did that within our own center, we would miss 80% of infants that we care for in our programs designed for opioid-exposed infants. And why this matters, I'll give you one example. Our early intervention system, which is IDA Part C, every state has one, every county has one. This is developmental services for at-risk infants. A qualifying diagnosis in our state was drug withdrawal in infants. And just because we were diagnosing drug withdrawal less in infants, we had a good population that wasn't getting that qualifying diagnosis and therefore wasn't getting services. So this is something that really needs to be looked at. Standardizing care, rooming in, improves outcomes. All right, let's talk a little bit about communities and how they matter. Oftentimes we really focus in on drugs, we focus in on the clinical piece, but you and I know that this is more complicated. This was just before the pandemic. This is my hometown in southern West Virginia, and this is on a Friday afternoon in the middle of the day. And what you can see is that downtown is pretty boarded up. Compared to 1960, my hometown has half the population that it did. My grandfather didn't have a high school education, but he had a stable job on the railroad. Many of those jobs are gone. The county where I'm from has an overdose rate of 3 times the national average, and somewhere between 3.5% to 5%, depending upon the numbers, of infants born here have drug withdrawal. So these factors all potentially play in to what we see in our communities. There's this broader question of how does the environment, how does the community long-term influence some of the things that we see showing up in our hospitals. Perhaps you've read the work of Case and Deaton. This is a group of economists. They have a book that just came out during the pandemic as well, called Deaths of Despair. And basically what they're looking at are how some adverse economic conditions, lack of economic opportunity, lack of community may have led to an increase in deaths due to overdose, deaths from suicide, or alcohol-related deaths. We also know that opioid-related complications have occurred disproportionately in impoverished and rural settings. And rural communities may be at risk, in particular for opioid-related complications due to poor access to healthcare. We've seen a record number of hospital closures in rural settings in Tennessee, lack of economic opportunity, and diminished social capital. So we wanted to understand what was going on in communities. You know, some of the work of Case and Deaton, were we seeing it in maternal child health too? So we looked at data from 580 US counties for about a 20-year period, including some economic data, to understand what factors were associated with drug withdrawal at the county level. In the lower left-hand corner of your screen, you'll see the states that we looked at. I'm going to highlight where I live right now because I think it's a good kind of continuous area to kind of show the impact of some of these factors. And first, just some maps. I'm going to walk through this. The darker the blue, the higher the rate of drug withdrawal in infants. And here's what you can see over the last several years. This is spreading just like you would see any other epidemic spread, but disproportionately, these communities are in Appalachia and there are rural communities as well that have been disproportionately affected in Kentucky, North Carolina, and Virginia. Virginia's actually not here. I feel like that was a test, like, you know, can you identify Virginia? Here, if we overlay long-term unemployment, and here's how we define long-term unemployment. We defined it as a 10-year moving average of unemployment at the county level. So this gives you a picture of what's happening now and what's been happening in the last decade in this community. The darker purple here you see in the bottom right of the key are counties that have both high rates of unemployment, high rates of neonatal abstinence syndrome. And you can see that these tend to be in some of the rural communities here. What you can also see is that there are some communities that have high rates of unemployment, but still low rates of neonatal abstinence syndrome, suggesting some community resilience. And so while we oftentimes focus on the negative, I think there are many positive things to learn too. So if we put these things together, first, this was during the period of the Great Recession. We saw an increase in a 10-year unemployment in the counties that we looked at from 6.5% to 8.2%. Accounting for other factors, we found that a 2 percentage point increase in long-term unemployment was associated with 34% higher rate of neonatal abstinence syndrome in remote rural counties in particular. When we looked at counties that had a mental health shortage, they were designated by HRSA as being a mental health shortage area. They also had higher rates of neonatal abstinence syndrome, though notably most counties that we looked at were mental health shortage areas. I just want to call out, you can look at our website, which is childpolicy.org/NAS to look at data from this study. You can look at county rates of NAS. You can also play with the data. You can change the unemployment rate. And I'll just we have a couple studies also that are coming out soon looking at the county environment associated with foster placement, as well as hepatitis C rates that for time I'm not going to talk about, but will be out soon. Okay, moving to the period after delivery. And, look, I think we oftentimes talk about long-term outcomes. And we talk about long-term outcomes as if they occur in isolation. And they don't. And I think it's important that we frame our understanding of what's associated with maternal drug use. Maternal drug use doesn't occur in isolation. It's oftentimes associated with poor health, poor nutrition, like food insecurity, poor prenatal care, social stress, and violence as well. We know that each of these things is associated with poor obstetric outcomes, and each of those things can affect long-term outcomes. When you look at the long-term outcome literature in this space, oftentimes it's confounded by alcohol, and oftentimes it's confounded by the environment. If we take a high-risk group of infants and families and we follow them out 20 years, they may look different than everyone else. But we have to account for that difference in the social construct. We can't, a lot of times I see in the literature, we say NAS is associated with worse outcomes, but we haven't taken all of these complicating factors into account. What about the role of trauma and toxic stress? Trauma is common among women in treatment. 73% in one study reported sexual abuse, a similar amount emotional abuse, and about half physical abuse. Adverse childhood experiences are also really common. Adults that report greater than 5 adverse childhood experiences compared to 0 are 8 times as likely to have lifetime substance dependence and 10 times as likely to have ever injected drugs. These factors also matter. Okay, so it's not just about the drug, it's about the community, it's about the context. And as we think about tackling the crisis, it's going to take more than just standardizing clinical delivery protocols. It's going to take interventions within our communities as well. I want to talk briefly about child welfare policy changes in the U.S. And as they're trickling across our communities. And first is that we've seen an increase in infants in the foster care system. Here again, the darker the orange yellowish color, the higher the rate of foster placement. You can see a similar pattern. States with the highest rate of foster placement are also states that tend to have the highest rates of drug withdrawal. In West Virginia, for example, more than 4% of infants in 2017 were in the foster care system. Collectively, when you compare 2011 to 2017, there were 10,000 more each year infants put into the foster care system. It's about 50,000 infants in 2017 that were in the foster system. This big increase, the increase in drug withdrawal, has been one of the reasons why we've seen some of the changes to the child welfare system that Congress has put in place. And this really began with the Comprehensive Addiction and Recovery Act of 2016 that in part modified the Child Abuse Prevention and Treatment Act. That is the foundational legislation that sets up our child welfare system passed in the 1970s. And it said that it was aiming to address the needs of infants affected by substance use. So we could talk about that language and why it may be a little problematic for some states. CARA also added requirements for states to address the health and substance use disorder treatment of the needs of the infant and the family or caregiver. This is important. So it sort of had a nod towards how do we connect folks to treatment, caregivers, moms to treatment. And it asked states to create monitoring plans to see if these were effective. So as we move forward, there's been other legislation, and I've seen it. I know it's on your agenda. I see it there tomorrow. Family first. I should correct this. It's family first. Was passed in 2018 and allows states to use child welfare dollars for prevention, including connection to treatment. We saw some increased funding for plans of safe care. This was in an almost government shutdown in 2018, where we saw a budget passed and some enhanced funding for child welfare there. And then the Support Act, which had greater specificity to what a plan of safe care should be. Unfortunately, it didn't come with money to really enable states to do this. So what does this look like? I'm going to break this out into a figure. So a plan of safe care should engage all of these things. And I got to tell you, like, as a provider, discharging an infant home, there's a big question of like, how are we supposed to do this? What does this look like? How do we engage to actually create a plan of safe care? How many of these things serve families? How many are duplicative? How are families going to respond to these things? But it should involve and be in partnership with the Child Welfare Agency, substance use disorder treatment, early care and education, things like early Head Start, state Medicaid, public health, residential treatment, the judicial system, home nurse visitation, MCV, Title V, and IDA Part C. A lot of services. And I think for many families, this is overwhelming. And what we've seen from some government audits, there's a Government Accountability Office report from 2018 that shows the states are really struggling with this. And I don't know what it's like in Maine, but many states are really struggling with what is a plan of safe care, how do we enact it, and how do we do it in a way that is public health based. I think one of the challenges is that we're taking a system that is built upon protection of children from physical and sexual abuse, and we're plugging in substance exposure. And these infants and these families are just different. And in many ways, just like the woman that I talked about at the very beginning, the child welfare system involvement from the beginning is one of the reasons why families will avoid care to begin with. CAPTA, this sort of landmark legislation that we talked about from the 1970s, is currently up for reauthorization. And there's a lot of things to like in the Senate bill that's floating around right now. First off, they changed plan of safe care to a family care plan. That may seem like a simple change, but it's an important way to engage families. If you say to a family, here's your plan of safe care, the natural response that I would have as a parent is, are you saying that I'm not safe? So it changes a little bit of that. It changes the term affected by to be a little bit more specific. Affected by doesn't have any clinical meaning. So if I say affected by drug withdrawal, affected by, that is a really hard thing. And that's actually been a stopper in some states. It's been challenging in Tennessee to define that. It now, instead of highlights FASD and drug withdrawal, it says affected by substance use disorder, including alcohol use disorder. So it's kind of getting at the crux of the population we're trying to identify. Families affected by substance use disorder, not specific to drug withdrawal. I mean, drug withdrawal just occurs in one specific subset. It allows for an agency. It allows for an agency aside from child welfare to be involved. So what if we had family care plans created in Title V and we engaged the child welfare system when needed, but that family care plan more public health focused, so it allows states to explore and experiment a little bit too. Okay, lastly, I'm going to close here with talking about Firefly. This is our mom model. And the Firefly logo was created by our team with input from our families. This is our external advisory committee that has moms with lived experience to helped us develop this. So this is our team. This was that brief period in the middle of the summer where we could not wear masks. And then, of course, now we're all wearing masks again in groups. But this is our team that launched. And so this team includes obstetricians, addiction, psychiatry, pediatrics, peer recovery specialists, lactation specialists, and social work. So our mom model dives deep within our system to develop an optimal model of care. And we are working here in Davidson County and to affect the surrounding counties, 26 surrounding counties. And this is a partnership with all 3 Medicaid managed care organizations within our state. our model is to basically break down silos that occur in medical care as people go through the system, but also to connect to many of those confusing services that we're talking about in plans of safe care. We're going to create evidence-based mental health, infectious disease, and addiction treatment for women in one place during pregnancy, and have pediatric, have more comprehensive care. So we're building out an intensive outpatient program, for example, that will launch in the next couple of months. In the hospital, allowing rooming in with mom and baby, consultation with addiction medicine. In the hospital, we're going to talk about this as we close, minimizing morphine, risk-appropriate care. And as after discharge, that 1 year postpartum, focused on relapse prevention, connecting to treatment, hepatitis C follow-up. But one of the important pieces here is what's at the very bottom. We are built upon peer recovery specialists that are not only supports for families, but they're also navigators for families. And so we have 5 on staff right now that are supporting families, and just being around them and just being around those with lived experiences is inspiring to me. We are building a family care plan. We're basically working to equip moms and to help prevent, where we can, false replacement by getting moms into treatment, by having positive interactions with child welfare and the courts, both of whom are on our external advisory committee. This is from our Friday finish line from our newsletter put out by the clinic on the 24th. We have, as of right now, 74 moms enrolled in the program. About half were already engaged at Vanderbilt in one way or the other before. Half are new to us. Importantly, one of the things that we've built in are learning from our research. So, one of the things that we found was that first call was oftentimes stigmatizing. And when you call a large medical center like ours, oftentimes you end up routed multiple different places. So we have one phone number with an actual human being who answers it that's embedded within our treatment program. Our shifting models of care, this is something that we've implemented here at Vanderbilt for caring for opioid-exposed infants. And, really commonly, we usually transfer babies to a tertiary care facility. We over-medicalize the treatment. We keep treatment separate from mom. We have really long lengths of stay. Newer, and what we're doing at Vanderbilt, and I know many places in the Northeast that also do this, you don't necessarily need to transfer a tertiary care facility. We treat all of our opioid-exposed infants outside of the NICU unless they have a clinical reason to come to the NICU aside from being opioid-exposed. So if they're sick, if they have respiratory distress. We engage moms in treatment, including in breastfeeding, and we standardize what we do. I'll just mention that our mom model was in part built upon Team Hope. It was a program that we built for basically caring for infants outside of the NICU that had about 350 opioid-exposed infants in a 3-year period, including a multidisciplinary team. And it's been focused on improving in-hospital care measures, so making sure that we had moms and babies rooming in, and breastfeeding if they were eligible, and connecting to post-discharge services. Our total length of stay, our median length of stay is about 5 days for all comers, 11 days if you get 1 dose of morphine. This is about half of where we were before. I want to leave time for us to chat, and I know even for, especially for somebody from the South, I'm a pretty fast talker and I'm pretty well caffeinated at this point. But to conclude, pregnant women and infants have been substantially affected by the opioid crisis, and our approaches need to be tailored. I mean, I think we see time and time again that we miss pregnant women and infants. We talk about the broader population affected by the opioid crisis, but we miss this population. Improving outcomes begins before birth, and I think if we picked one thing, connecting moms to treatment. We know treatment fixes a lot in terms of birth outcomes. And it may reduce foster care placement. It may do other things like that too. This isn't just about drug use, it's about the community, economic opportunity, social network, and trauma. I'm an optimist. I think that the opioid crisis may be a vehicle to improve maternal child health. Maternal child health across the U.S. is a mismatch of grant programs, entitlements that are at various stages at the state, federal, and local levels. But I see the opioid crisis as a way that's bringing programs together, helping coordination and breaking down silos. So I hope that will continue moving forward for other crises that we face. A lot of collaborators to thank and our funders, including the National Institute on Drug Abuse. Here's my email address if anybody has questions after the Q&A. feel free to check out our website, childpolicy.org, or Firefly, which is fireflytn.org. Great to be here today with you all.
Thank you. Thank you, Dr. Patrick. I'm a pretty prolific note taker, and as a lawyer, and even I had trouble keeping up. And I believe that this is going to be recorded, so people will be able to go and watch it again for the really critical pieces that that we might not have caught all of. I want to make sure that we answer the questions that were left in the chat room, and then I have some of my own. So let's make sure, let me take care of those 2 or 3 questions first. Our friend Rob Rogers asked that whether you know, whether the percentage of women who use marijuana is affected by whether the state that they're in has legalized recreational medical use of marijuana. I think we could almost surmise, but do you have any information on that?
I would guess that it's higher, but I honestly don't have data to drive that.
Has Tennessee legalized marijuana?
It has not.
Next, Maine has, not something that I, as the state's director, is very excited about, but it was voted, and it's been implemented over about a 3-year period.
I think there's reason to be concerned. I'll just quickly, for pregnant women, for pregnancy outcomes, marijuana use in pregnancy is not a good thing, and so there's good evidence for that. And I think the other population that I worry about are adolescents. I think there's good reason to be worried about what the effects of marijuana are on a developing adolescent brain as well. And so I think those are the 2 populations that I worry a lot about.
And we do have campaigns aimed at that adolescent use. That obviously the law is only 21 and older, but so is alcohol. And,
exactly right.
We know the results of that. Astrid Redmond asks, she's interested to know if the states, this is an interesting question, whether the states with low rates of NOW have a higher percentage of home birth, where in fact NOW, where may not have been reported.
It's an interesting question, in part because it's one of the things, are people basically avoiding care to avoid the diagnosis? There isn't good evidence that happens statewide, though we have seen that occur when states have punitive policies towards pregnant women. I have a little bit of anecdotal evidence to that. In Tennessee, we had a law in the books between 2014 and 2016 that if a pregnant woman used an illicit substance in pregnancy and the infant was harmed, and that included drug withdrawal, a woman could be charged with a misdemeanor for that and spend up to a year in prison. So we had women driving out of state. We had women delivering in cars. Some testified between our state house because they were trying to avoid care and avoid being arrested. So that does occur. There are some analyses done by various groups looking at punitive policies at the state level that have found that states that have more punitive policies have higher rates of drug withdrawal, for example, in infants. So those punitive policies really do appear to make things worse.
There's a question from Shelby Briggs that I will broaden a bit. It really goes to the issue of the reporting of the various substances. And in my opinion, under the federal law, you really got 3 things to think about. One is the moms that are on medication-assisted treatment that buprenorphine or methadone. Then we've got those who are using other substances, illegal substances, street drugs, so to speak. And then we got those who are on other legal substances that may affect the infant, but in fact are not MAT, lots of medical things. And as I understand the federal law, they expect you to report both legal and illegal drugs. So Shelby's question was whether of those cases, how many are, if we had 100 cases of reports, how many that contain substance use, how much of that was MAT versus other illegal substances? She doesn't really asked the question about legal substance.
I think we don't have a good answer to that. We don't have great data systems to really understand. And that's true within state surveillance, it's true within billing data, and it's true within child welfare data too. So, drug withdrawal happens, like babies having drug withdrawal, they're going to have drug withdrawal regardless of the opioid. They can't tell if it's, from buprenorphine or if it's Vicodin. So they can have drug withdrawal. So if you see a diagnosis of drug withdrawal in a community, some of that drug withdrawal might be a good thing because it's a mom who got into treatment, but some of it may be heroin, and we don't know the answer to that. Our current data systems for the child welfare system, the way that they define, these are the two for both reports to the child welfare system as well as foster care placement. They have these broad, weird definitions for addiction within 1 year. And so what we know from that is that there are some states that have really high rates of neonatal abstinence syndrome, have high rates of foster care placement. But if you look in their foster care data, you look in the reporting data, it looks low. So I think meaning it looks low, that they say a lot of these reports weren't necessarily due to substance use. So those data systems really do need to be bolstered. But honestly, we've kind of systematically as a country underinvested in the child welfare system. So it probably shouldn't be much of a surprise that the data systems are lacking.
I want to take that a step further. In Maine, we have been struggling for well over a year now with the need to either revise our reporting law or do a better job of educating our 23, I think, birthing hospitals to try to achieve a uniformity with respect to reporting. One of the great variations, and we've looked at New Hampshire and Vermont on this as well, one of the great variations is that some hospitals report marijuana use by the mom, others do not. That to us really skews the data to the point where we now don't put it on that data on our drug data hub because we don't consider it reliable until we get underneath that issue. It really seems I'm not a clinical person, obviously, I'm a lawyer, but it seems to me that there is a significant difference. If I've got a hospital that is reporting a single use of marijuana by a mom when it's legal in the state of Maine, that is really different than, and that's counted as one substance exposed infant. That's really different, seems to me, than a mom who comes in with a serious addiction and we put her on medication assisted treatment. Do you find in other states that they're all, you talked about the necessity of standardization of definitions. It seems to me until we reach that point that the data is really flawed.
I mean, I agree. I think the other bigger question is, what are we hoping to achieve with those data? What we know is that, the SAMHSA estimates there are around 400,000 substance exposed infants born every year, and we identify about 5% at the time of birth. We have, there are so many reasons why we under-identify, stigma, the way we standardize what we do. But I think the bigger question is, do we want those, are the data systems that we have, the reasons we're collecting from child welfare, are they supposed to be surveillance systems for marijuana? Or are they supposed to be a way to connect families to resources and treatment? And I think we sort of have this mix up of like, how are we trying to use the data to connect to services? And I think that, so CAPTA, the changes to it are written in a way that's vague enough. And I think we haven't seen a lot of really clear guidance either to states. So states are confused. There's good evidence of that from GAO. Hospitals are confused, and there is no standardization. Those populations are really different. One of the other populations, you mentioned it earlier, we in our state had one interpretation of CAPTA was if we had a mom in treatment with buprenorphine and her infant didn't have drug withdrawal, she didn't need to be reported. If the exact same woman, that infant had drug withdrawal, that woman needed to be reported because the infant had drug withdrawal. That's how they interpreted CAPTA. That doesn't make any clinical sense whatsoever. And so that has changed. But I think this gets back to the point of we are sort of leaving it to states right now to guess. And it's really confusing. And I think we do need more clear guidance to states. And I think we need to step back as a country and as a community. What are we trying to achieve out of these data sets? If we're really kind of trying to achieve, we shouldn't be trying to achieve surveillance of substance use and pregnancy, because if that's the goal, then we're not going to do a very good job with collecting data from hospitals at the time of birth. That was kind of a long-winded answer. So I get to the
as a policy, yeah, seemingly the goal is to have fewer women of childbearing age becoming pregnant while they're actively using illegal opioids or other illegal substances. I mean, that's the goal, to have fewer babies that would be affected. But we have a really hard time in Maine knowing whether our rate goes up or down, but while we've got all this unstandardized reporting. Moving on, Tennessee and Maine both have the federal mom grant. As of yesterday, I spent time yesterday with staff for that program here, and it's just beginning. But we had 26 moms in the program, at least 26. We think between 26 and 40 because we were waiting for one more report. And so we're pretty excited about where we are. Been a tremendous amount of work done by the staff. How is it going in Tennessee?
It's going pretty well. So we have around 75 women enrolled right now. Ours is localized though, right? So we are in one community right now here around Nashville, with plans to expand outwardly to a rural setting later on. It's like anything. I mean, we're kind of building a lot of data systems. We're thinking about the structure of care. We're working towards like, how do we sustain this? So it's going pretty well. I do think like one of the big goals that we hope to achieve from this, from all of our states, is to develop a better way to do this as a nation, where the goal of Mom is to do a better job of caring for moms and babies in a more efficient way. So I'm really hopeful that we've made the positive steps as we start to enroll folks in Tennessee and Maine and other states towards achieving that goal. But you're right, we're kind of on the front end. And I know that different states have struggled a little bit more than it sounds like Maine and Tennessee have.
I want to talk about stigma for a minute. You have data that showed that it's difficult to get treatment, period. It's even more difficult if you're pregnant. And I suspect it's more difficult based upon race as well.
It is.
We find that stigma in every part of Maine, unfortunately, whether it's law enforcement, corrections, but a lot of it is in healthcare. And that's where we're in the best position, one would think, to positively affect that. But have you found strategies among your colleagues to overcome the stigma so that as we educate the public that substance use disorders are a chronic illness, we don't expect them 25 years after the Americans with Disabilities Act and after mental health parity, we do not expect people to be treated differently because of this diagnosis than they are if they have cancer or a broken arm. What are you doing in Tennessee to help on that issue? Because to us, it's almost like winning one person at a time, and it's really hard.
Let me first address the issue of race. And so, yes, we know it's harder by race. We published a paper that was similar actually to a paper that was published out of Massachusetts. In Tennessee, if you look at the population of pregnant women diagnosed with opioid use disorder, who got medications for opioid use disorder, white urban women were more likely to get treatment compared to rural women, non-Hispanic Black women, Hispanic women, and non-English speaking women in our state. And that's not unique to Tennessee, that's nationwide. And we see, if you sort of peel back, even though there's been so much focus on white populations as it relates to the opioid crisis, Black populations, Native American, Alaska Native populations have a harder time getting into treatment. And in particular, among American Indian and Alaska Natives, they have higher rates of opioid use disorder, high rates of neonatal opioid withdrawal syndrome, high rates of hepatitis C. And that's where we need to be spending a lot of our attention. With regard to stigma, part of what we've done has been to try and highlight the work we're doing as a vehicle to drive positive stories of recovery. We had there's a local news story about Firefly last night that was in one of our local TV stations. Within our medical center, we've done some panel discussions about substance use. We have programs for our medical students too. I mean, the stigma, this is different, begins in medical training, allied health training kind of early. And so beginning to change the way we do that early in hospitals is important, and having those conversations. We've also done some work around trauma-informed care. It was driven by some of our nursing colleagues that created a curriculum around trauma-informed care that happened in places and gave that curriculum to places where moms and babies are in our hospital. But it's still pervasive. And I would say, it's better than it was 5-10 years ago. It's still pervasive. We still have a long way to go. We still see language that's used. We still treat this as other. I think one of the things I oftentimes will talk about are, we treat this different than diabetes, but diabetes is also a chronic relapsing medical condition. So one of diabetes, like we looked in my NICU, I treat more complications from uncontrolled diabetes than I do from uncontrolled opioid use disorder. But we view them really differently. We sort of talk about this big baby that's 15 pounds from uncontrolled diabetes as a miracle. And then we have the baby who has drug withdrawal. And we talk about this poor baby born addicted. And I think the more we talk about it, the more we shed daylight on it, the more we sort of engage our communities with positive stories of recovery, the better.
So in our moms program, there is an advisory committee of moms in recovery. Recently, in a meeting of that really dynamic group of between 5 and 15 women, in their discussion of things that we need to do, they brought to our attention the amount of stigma that is associated, that is found right within state government, right within our own 12,000 employee workforce. I'm not asking you to, I want to bring that to the attention of our attendees, because it's not pointing a finger at a particular office or an individual, but if this is what the people that we are expected to serve are coming back to telling us after the fact that they were stigmatized even when they went in to a state office that's even dedicated to serving their needs, then that's something we need to work on as well. Pivoting to another entirely different issue, how has your work been affected by COVID?
So I think they're both negatively and positively. I mean, first off, and we've done some work on how families have been affected by COVID, the economic instability, whether that's loss of insurance. We know there's been increases, just thinking about Tennessee, increases for the first time in uninsured kids, increases in food insecurity, more anxiety among kids. That's true broadly for families too. That economic instability, I think, has made a lot of things more complicated. Locally, we've seen what appears to be fewer moms in treatment, and that's had some more complicated cases of drug withdrawal. And I think that's worrisome. We're just beginning to get data in that, I think the combination of economic instability, harder to get into treatment kind of early on, led to adverse outcomes, less treatment. But there were some positive things too. Telehealth being one, and telegroup. In some cases, for folks that were able to engage, we were able to engage in ways that were unique, that we still use, where we can engage families where they are. even within our own, like looking at our external advisory committee, we have families who are engaged in that may live 2 hours away, where travel would have been a barrier before. So I think we've done some innovations during COVID that may be beneficial from here on out. But I think the overall issue, particularly the economic instability, was a detriment to many of our families in ways that we're just beginning to understand. And even though we know there's, the things that were the CARES Act, other things that help support families, prevented some bad things, we still saw big increases and some problems for families.
Yeah, I would say likewise in Maine that there are some positives, the advancement of more telehealth. Transportation always would be a huge issue for people. So the extent now that they can participate in even maybe a 12-step support group meeting from home, not have to deal with childcare, that's positive. But there's many negatives as well. Particularly what I describe as the difficulty of state government responding to two really significant public health crises at the same time. If COVID had never arrived, in my opinion, this issue of the increase in mortality and overdose deaths and then what appears to be an increase in substance use disorder across this country would be all anybody would talk about. It would be on the front pages every day. And because it's been kind of pushed aside by COVID, and that affects our ability to engage our communities, engage legislators, etc. Couple other, going to the chat room, couple interesting things. One, Andrea Colgan makes a terrific point, I think, that there's stigma associated with any medical diagnosis that has a behavioral component. Diabetes, obesity, I think she's right. I mean, we know how, I have to deal every day with the fact that there is some differentiation in state government and federal policy about mental health and substance use. And yet we know that there's a vast number of co-occurring situations. It's almost 100% to me. There's a reason that people used drugs in the first place. So I think that's a great observation. And then there's a question about, are we going to be, and I think I know the answer, but are we going to be covering treatment ideas for children who have backgrounds of families, intergenerational, multi-generational use, trauma, domestic violence in foster and adoptive homes? I mean, to me, that's you're in that space of infants, really. There are other talks associated with, treatment of adolescents and middle school students and things. But do you have any comment on that?
Yeah, I mean,
how we deal with older children?
Well, I think there's two prongs. One that I heard there. So I think first off, there isn't good evidence to say that if a child born with NAS is going to develop opioid use disorder later on or substance use disorder. One of the things that I hope we see is a bigger investment in early childhood education programs, early Head Start, coordinating that with EI, all the things that we should be doing to support childcare, that we should be doing to support families to optimize development. That actually is what, if you want to sort of optimize outcomes, that's where you should start to prevent that child in 6th grade using substances. Right now, we don't. And here's hoping. We've had a change in conversation around childcare and some early childhood education programs. But I mean, I think probably many people don't know that Early Head Start, for example, pregnant women can enroll in Early Head Start. It's a great program for pregnant women and infants to age 3. There are these programs are there, but they are, again, oftentimes not well coordinated, not well known in communities. So that's where you start. And back to adolescents. Yeah, adolescents struggle too into getting treatment for opioid use disorder. There's some good literature on that, and I think that's a different issue, but it's a challenging one too.
think our time is up, Dr. Patrick, and I think that's a good note to end on. We are putting a lot of resources into primary prevention, and we understand that there's no time from we need to go way upstream in the prenatal period, and from there till age 26, when their brains are formally developed, that there's no time that we shouldn't be worried and all over our kids, and we're trying to do that. But your talk was terrific. I want to thank you for your time to spend time with us virtually in Maine. Hopefully we'll be able to bring you back at a time when you can be physically with us. And I know on behalf of all the attendees, we really appreciate you sharing your time with us today. And I believe at this point, I probably throw it back to Dara to do another recovery story. And these recovery stories are so powerful. I want to thank the people that have put that together. Thank you. And Dara?
Thank you so much, Gordon. Thank you so much, Dr. Patrick. We are going to break for lunch now, and we will have another recovery story later on this afternoon, but look forward to seeing everybody to come back for the next session at 12:30. So enjoy your lunch, and we'll see you back here at 12:30. Thank you so much.
Welcome back, everyone, from your lunch. I hope you had a delicious lunch. Sorry, two things going at once here. I apologize for that. My name is Kelly Bowden, and I'm a nurse. I have, for the past 17 years, been coordinating a contract from the Maine CDC to provide education and consultation services to healthcare providers across the state on topics related to pregnancy, childbirth, and newborn care. And I'm here today to facilitate the session on fetal alcohol spectrum disorders. And I'm pleased to be able to introduce the first speaker for the session is Constance Mazelski. And Constance moved to Maine in 2012, and in 2019, she formed the FASD Maine in conjunction with her fellow advocates, Madonna and Shannon Corey. Some of you may have met Madonna at a prior conference. FASD Maine is an all-volunteer group of parents, foster parents, family members, and individuals affected by the #1 cause of intellectual disability and birth defects, which is fetal alcohol spectrum disorder. And I think this morning's talks have really given us a nice introduction of sorts and planted some seeds, some things for us to think about. Ms. Mazelski is responsible for outreach to the foster and adoptive community. She runs FASD Maine's popular book giveaway program that has distributed hundreds of titles to clinicians, professionals, and family members. And without further ado, I'm going to turn it over to Constance.
Thank you, Kelly. Good afternoon. I'm Constance Mazelski, and I'm excited to share my story with you today. All of you attending this conference can help me and my family and a great number of children and adults in Maine like us. In September 2019, Madonna Mooney, Shannon Corey, and I, our friends, co-founded FASD Maine. You can learn more about us on our new website, fasdmaine.org, and we welcome you to join our Facebook group, which is FASD Maine. We're a pretty lively, active group. The medical community in Maine seems to do a pretty fair job of diagnosing fetal alcohol syndrome. The doctors I've talked to say that they learned a bit about FAS in medical school and they enter their profession with some familiarity on that subject. However, the medical and social services community that we live in lacks important diagnostic and treatment protocols for fetal alcohol spectrum disorder, FASD, which is 10 times more common than fetal alcohol syndrome. My child and family suffered because of this lack of understanding. My husband and I adopted 2 wonderful children, and I would like to tell you about our exuberant, loving, smart little baby that we adopted in 2003. Our child had none of the classic signs or symptoms of fetal alcohol syndrome: facial features, short stature, low IQ. This was a very bright, happy child. But over time, our beloved child started to struggle in school, with friends, at home. And because this is a conference about maternal health and addiction, I will boil down these struggles into a set of severe issues in roughly the order that we started to figure them out: sensory processing, emotional regulation, impulsivity, social skills, adaptive functioning, executive functioning, gaps in memory, confabulation, which a lot of people took to be lying, and dysmaturity. Our child could not consistently behave as expected of children their chronological age. I'm talking about neurological symptoms rather than diagnoses because for a very long time, our family belonged to what author Derek Volk calls the Diagnosis of the Month Club. Believe me, this is not a club that you want to belong to. These neurological symptoms presented as behaviors that were alarming to us as parents and confusing to the professionals that we looked to for guidance. Some of these behaviors were odd things, like refusing to wear socks and underwear because they were too tight or not tight enough. And other behaviors were scary things, like ongoing meltdowns or my child losing it in the car when I was driving. The diagnoses were all over the map because our systems of care, our doctors, therapists, special educators, social workers, and psychiatrists were not and are not FASD informed. Each professional we saw looked through their own lens, but did not get the full picture. They were not looking through the lens of prenatal brain injury. Ultimately, our child got accurate diagnosis, but it came very late, at almost 15 years old. By then, there were a lot of secondary issues that our child, who is now 18 years old and a young adult, has not authorized me to talk about. You know how that is. Our child was one of the 2 to 5% of American school children, according to the definitive study by Dr. Philip May, with lifelong permanent issues caused by prenatal exposure to alcohol. And as we know, and as Dr. Stephen Patrick talked about this morning, most people who use other substances also use alcohol, whether it gets reported or not. Practically speaking, a decade of interventions that would have been helpful to our child didn't happen. And some of the interventions that we diligently pursued were counterproductive, to say the least, to a child with fetal alcohol spectrum disorder. Today, I'm very excited to see Dr. Christy Petrinko's short video, FASD Strong, which Dr. Douglas Waite will be sharing with us. Today's the first time it will be shown in Maine. It premieres later this week. The University of Rochester's Mount Hope Family Center offers the life-changing Families Moving Forward program to hundreds of FASD-affected families in their area. These families and young people are a beacon of hope and light to us in the FASD community. In Maine, by contrast, we do not have any FASD clinic. There is no community-based supports, and there's limited diagnostic capacity for FASD. Based on our experiences, I have become a parent advocate. I'm determined to help other families and to help prevent FASD. In the 2 years since we founded FASD Maine, Madonna Mooney, Shannon Corey, and I have been joined by more than 150 parents, foster parents, people with FASD, and countless allies. And I am pleased to say that many people attending this conference today have taken major steps to learning about the #1 cause of intellectual disability and birth defects worldwide, FASD. Thank you. Establishing FASD Maine was step 1. Our next goal is to get the FASD Respect Act passed in Congress. Last week, Senator Susan Collins stepped up to co-sponsor this life-changing legislation. Representative Shelley Pingree has signed on to co-sponsor the FASD Respect Act in the House. It's truly a bipartisan effort. And I want to thank them for the bottom of my heart for hearing us when we ask them for their support. And when the FASD Respect Act passes, There's sizable hurdles ahead. We need to get FASD written into Maine laws. This is where all of you come in. We will need your support in the medical community, DHHS, the psychologists and psychiatrists, the social workers, case managers, community health workers, counselors and educators, and parents. We need to change the laws in our state so that people with FASD, like our youngest, can get early, accurate diagnosis and community-based support. We need local resources in Maine because people on Maine Care, such as children in the foster system, cannot go to New York or Boston for diagnosis. They need it here. You can find out more about the hidden epidemic of FASD and the FASD Respect Act by listening to the Maine Calling podcast from last week, September 20th, available on mainepublic.com or on our website, fasdmaine.org. I'm an optimistic person, and my message is a message of optimism. With your help, fetal alcohol spectrum disorder can come out of the shadow of stigma. With your help, the tens of thousands of children and adults in Maine living with this lifelong hidden disability can get the help they need to become productive members of society. Thank you. And now it is my pleasure to introduce Dr. Douglas Waite, Chief of Developmental Pediatrics for Bronx Care Health System and Assistant Professor of Pediatrics at Mount Sinai Medical Center. I first met Dr. Waite when he came to Maine to present at his alma mater, Colby College, at a conference he organized in 2017, along with NOFAS and the Maine Developmental Disabilities Council. Hearing Dr. Waite and his fellow FASD experts changed my life. Dr. Waite?
Thanks, Constance. Can everybody hear me okay? I will presume you can. And, I don't think it gets much clearer and more from the heart than what Constance just shared with you. I'm going to try to give you a backdrop of some of the issues that we as pediatricians, but even more importantly, parents, teachers, educators, and you in maternal child health are going to see every day. And I hope as I go through this, it's going to resonate with kids that you've already seen so that we can begin picking these kids up and getting them services. I'm going to set this to share my screen and hopefully this will all work. And then slideshow. Can everybody see that? I guess, Constance, can you see that? You are screen sharing. Everyone sees? Okay. All right. So I'm going to go through part of this presentation is going to be history of how we came to learn the effects of alcohol on brain development and more importantly upon the developmental trajectory of children who've been exposed to alcohol before they're born. In addition, I want to cover why this disorder has not been diagnosed and treated. As we go through this, you're going to see how common this is, and that frequency of kids that have this and are not being identified begs the question why. And I'm going to hopefully get to some of those questions that Connie alluded to. I wanted to dedicate this presentation to Carl Bell, who came to Maine with us from Chicago, University of Chicago. He was a leader in the FASD community as a psychiatrist. Psychiatrists often do not know much about this. This is probably one of the most common things that come across their office every day. So in memory of Dr. Bell. So this is exactly what Connie was talking about, a parent saying that as an adoptive parent, and I would put as a biological parent or as a foster parent, the world's divided into those who know about this and those that don't. I'm hopeful that at the end of this presentation, you'll be those who know about it, even if you're not experts. You will find how quickly you can become an expert because these kids are out there and this is something that you've already seen. So I'm going to discuss our understanding of FASDs. I'm going to highlight a new category that's called neurodevelopmental disorder associated with prenatal alcohol. That's in the DSM-5. I'm going to talk about interventions that Connie addressed a little bit of and why this should be categorized as a disability. so that children who have this are treated and get and receive the same services that kids with autism and intellectual disability receive. And also how we can begin to coordinate a web of services that are already in the community, but are informed by knowledge of FASD. So 1972, Ken Jones, who was a geneticist at University of Washington Hospital, and David Smith described a constellation of facial features. So things they found on exam among children who subsequently had difficulties in gaining weight or gaining stature, who had difficulties with development, that began to fall into a pattern that they called fetal alcohol syndrome. Now, a syndrome is something that doctors identify on exam. It doesn't have a blood test or anything like that. Dr. Down described Down syndrome before we knew that this was caused from 3 chromosomes on chromosome 21, and it's trisomy 21. So it's a syndrome is something that's identified on exam. And they began describing this in 1972, 1973. And here we are 50 years forward. And again, as we talk about how common this is, I want you to think if any other disability would go this unrecognized among our children. So we will talk about the frequency of FASD, but this is a CDC study from 2019. They do surveys of pregnant women and through the phone, and 11.5% of pregnant women drank alcohol in the past 30 days. 3.9% of those binge drank in the last 30 days. And we know binge drinking are especially most harmful to brain development because alcohol is a neurotoxin that kills brain cells. We know that college-educated women are more likely to drink, and we know, most importantly, that among non-pregnant women of childbearing age, up to 50% of women drink and 18% binge drink. And this is important because most women don't discover they're pregnant until 1 to 2 months into their pregnancy. The time when the brain has developed is the first thing that develops in the body. So mirrored in that 11.5% of women who drink during pregnancy, we can begin to see how common FASD is. FASDs, fetal alcohol spectrum disorders, which is the greater neurological disability that results from prenatal alcohol exposure in the absence of facial features of FAS, which I'm going to go over shortly, is 2 to 5% in the general population. That means out of 100 kids that you would go into a first grade classroom, which is what Dr. May did in this study, 2 to 5% of those, depending on different regions of the country, they did 4 different states, had a fetal alcohol spectrum disorder. Almost all of them were not diagnosed. So FASDs are more common than autism, trisomy 21, Down syndrome, and cerebral palsy combined. And yet, if you think about how much you know about autism, how much our society knows about autism, how services are in place for autism, you can begin to realize the frustration of parents like Connie in just trying to get what their kids need. So FAS is about 1 in 1,000 in the general population. FASD is about 2 to 5 in 100 children. All right. Many of the kids with FASD, I would say the majority present with symptoms like ADHD. So many of these kids with ADHD that are listed here are, I'm certain, kids that have FASD that have not been diagnosed. Because as Connie mentioned, kids with FASDs typically gather a string of psychiatric diagnoses. So we know that this is even more common in foster care. And this is important for maternal child health services because you're more likely to get kids who are at higher risk, families that need more support. Alcoholism and substance use disorder is not a moral disease. This is a disease that we as doctors are not good at taking care of. No mother has ever drank alcohol because they want to hurt their baby. Most of us as parents want to bring our children into the world healthy and have them have a life course that was better than we had. Unfortunately, substance use and alcoholism takes away everything you love in life, your job, your place to live, and eventually your kids. So it's not surprising these kids are in foster care. This is how I came into learning about this. It certainly wasn't medical school, where I had maybe a 30-second slide of a kid with FAS. and knew nothing about the bigger picture of FASDs. So this is important because if you think about the University of Washington, which was one of the major diagnostic clinics, like Connie was saying they have in Rochester, looked at the first 1,400 kids that they diagnosed with an FASD, and 70% of those kids were no longer in the care of their birth parents. And these are often kids that have multiple out-of-home placements. They're very difficult to care for, and they bounce home to home to home, often entering into residential treatment, which is where I would often see them as well in our foster care clinics. There's often a comorbidity with physical and sexual abuse, including neglect. And again, I mentioned ADHD. But whenever you have a child born positive for opioids, cocaine, cannabis, you have to think about co-exposure to alcohol. Even though this is not seen on the urine toxicologies, this is where we have to step up and do screening, which I will go into. So, and yet, even though this is really common in foster care, Ira Chasnoff did a study in Chicago where 80% of the kids that were referred to him from a foster care center who were subsequently diagnosed with an FASD had never been diagnosed. So really, really common in foster care, the kids are not being picked up. Similarly, this happens in the juvenile justice system. And the reason we want to pick this up is because of the underlying brain damage, the developmental impairments that occur from alcohol exposure before birth that not only affect behavior, which is most common attribution that this is a behavioral diagnosis, but affect learning and ability to carry out day-to-day tasks, social interactions, bigger issues than just a simple psych diagnosis. So we're going to go through FAS, fetal alcohol syndrome, which are facial characteristics. Again, FAS is things found on exam. We'll talk about growth impairments below the 10th percentile in height or weight at any time during childhood, intellectual learning disabilities, attention problems, coordination, difficulty with judgment, reason, speech, language, auditory processing issue. Those are the core, though. This is not about the face anymore. We learned about what happens when you're exposed to alcohol before birth because of what Ken Jones described with fetal alcohol syndrome. But 1 in 10 kids that have an FASD, fetal alcohol spectrum disorder, do not have facial features. So even while I go over the face, I want you to forget about the face and think about the brain underneath it. Of all substances of abuse, cocaine, heroin, and weed, alcohol is the one that kills brain cells. We're learning these other drugs have some effects, but none affect the brain as much as alcohol exposure. So this is a child with FAS, both of these kids, and you can look at them and say, you know, they're adorable kids. And when you see a child with FAS or with FASDs, they're wonderful children that light up. You immediately feel attached to them. And part of the facial features that we talk about is a short or narrow palpebral fissure. So we measure from the inner part of the eye to the outer part of the eye, the little window frames that our eye looks out in the world. And when we say short or narrow, it's smaller in measurement. So one of the 3 features of FAS, fetal alcohol syndrome, is a short palpebral fissure. The other is a smooth philtrum, meaning that ridge between the nose and the lip becomes flattened out. And the last feature is a thin upper lip. Current diagnostic recommendations for fetal alcohol syndrome is 2 of those 3 features. I'm not expecting you to measure palpebral fissures or know these diagnostic criteria. I'm going over the face so you know about the face, and then we're going to forget it. Having said that, what doctor is going to go into the mother on that child on the right, who's a beautiful baby, and say, I'm sorry to inform you, your baby has fetal alcohol syndrome. She's low in birth weight. She's not gaining weight. She has facial features of FAS. You must have drank during pregnancy. That mom is going to look at you and say, what kind of mom you think I am? Are you saying I tried to hurt my baby? I want a different doctor. So part of this is beginning to tread on the ground that's very difficult for us as practitioners, getting into the moral stigma that's associated with alcoholism, especially alcoholism of women who are pregnant. So this is the kids that have FAS, 1 in 1,000, that you see things on the surface. But like the proverbial iceberg, underneath is the part that's the greater group of kids that Connie was talking about. So 9 in 10 kids who have FASDs do not have facial features. And this begins to tell us a little bit about how the brain is affected by alcohol. These are cells stained blue in a mouse embryo that was exposed to alcohol. And the blue cells are cells that have been killed by alcohol. This is the first thing that develops. The brain is the first thing that develops after the egg gets fertilized and it begins dividing and forming the body. So you can begin to appreciate how early this is happening. So way before you find out you're pregnant, if you're using alcohol, this can affect brain development. This is the basis of the CDC recommendation. If you're of childbearing age and you're drinking, you should be using contraception all the time. Otherwise, you should not drink. So this is showing the development that I just spoke about, the development from the fertilized egg to developing what is the beginning of the brain, and then moving forward. Now, I mentioned most women find out they were pregnant between 4 and 8 weeks, and you can see already how far along the brain's developed. Other things also develop, like the heart, but the brain is the big thing here. And so this trajectory here of development gives you an idea of one of the ways that I'm going to teach you how to screen for prenatal alcohol and substance exposure that fits right in with asking about pregnancy. The first part of which is establishing when a mother discovered she was pregnant. So these are different areas of the brain that are affected by alcohol. And probably one of the biggest areas is the frontal lobe. That's the seat of what we call executive function, the little guy that drives you around, tells you what to do next, how to do something, judgment, impulse control, all right, things that are essential to living in society. The other things also are affected go for emotions. A lot of children with FASDs have emotional ability, go up and down, react with frustration, with tantrums that are very difficult to de-escalate. Memory is a big issue. Often kids have speech delay, issues with learning and retention. So we've come to describe what is kind of called a neurobehavioral phenotype, a group of things that we tend to see in kids with FASDs. These are not specific to fetal alcohol spectrum disorders. You can see them in ADHD. You can see them in other psychiatric diagnoses. And this is why a lot of kids come to us with a string of psychiatric diagnoses: ADHD, ODD, chronic disorder, bipolar disorder, mood disorder, autism, a whole spectrum of things. But we talked about executive function. That's frontal cortex, inhibition of impulses. These are kids that have difficulty learning. When I taught nursery school, don't hit, use your words between age 2 and 3. These are kids who have difficulties with that. Not because they're mean-spirited, but because they have difficulties holding back, as well as difficulties in social interaction. Often aggressive, impulsive behavior is one of the first things that comes to our notice. So Connie was talking about difficulties in school interaction. So these kids can quickly become labeled bad kids you don't want in your classroom. Issues with attention, distractibility, almost always diagnosed as ADHD. Johnny could do better if only he paid attention, if only he tried harder. Auditory processing, hearing it and getting it. So these kids often need repetition so they can understand directions. And often, because we learn to speak by what we take in, they often have speech delay. And many of them are diagnosed with autism. So keep this in mind. Just because a kid gets diagnosed with autism doesn't mean they don't have an FASD. I see it all the time. I just saw somebody today that had this morning. And most kids have borderline to low average cognitive ability. So like Connie said, you can have a normal intellectual ability, but have difficulties turning that into achievement, where you turn the paper in and you got it. So these kids often get missed because there's a gap between their cognitive ability and their achievement. So the schools often look at this, well, he needs to try harder. And the missing a bigger part of this, which is adaptive function that we'll talk about later. So this is the category of NDPA, neurodevelopmental disorder associated with prenatal alcohol exposure in the DSM-5. To me, this is the gateway to getting kids diagnosed. One thing, there's nothing here about the face. 2, it's a checklist, just like we have for kids with autism. It's a checklist that pediatricians, psychiatrists, psychologists, professionals can begin putting this on their map, just like they have autism on their map. So we talked about intellectual ability, executive function, learning, memory, visual, spatial reasoning. If a kid has one of those things, that's a check, all right? If they have difficulty with self-regulation, they go up and down with their environment. So many kids with FASDs need a calm, quiet environment that's highly structured, consistent routines. If they don't have that, they go up and down, and they're hitting kids, they're running out of the classroom, they're hanging from the chandeliers. Attention issues, if they're diagnosed with ADHD, impulse control, we talked about. So a check there, right? And then the third part is adaptive function, we'll talk more about, but these are issues with communication like speech delay, difficulty using language and social communication interaction. So this is where this can look like autism, but it's really more of a social pragmatic communication issue, using language to carry on conversations. Conversations just tend to stop when you start trying to engage kids. Daily living skills. They need help getting ready for school. They're 13 and you still got to lay their clothes out. You got to tell them to brush their teeth. Basic things. So the mom will say, he's 13, but I got to treat him like a 6-year-old. I heard this just yesterday. This is the point. All right. Impairment in motor skills can also happen. So you need 2 checks in this box. All right. So if they had speech delay, check. They're getting speech therapy, check. If they have difficulties in social interactions, check. Or these other things, daily living skills, you can do an adaptive function scale. All of those things, if you get those criteria and you have a history of prenatal alcohol exposure, you need to get that history, you can make this diagnosis. So you can immediately begin to see that the major stumbling block here is getting the history of prenatal alcohol exposure. Fetal alcohol syndrome. If I see a kid who has fetal alcohol syndrome, growth delays, facial features, developmental impairments, I can make a diagnosis of fetal alcohol syndrome even if I've never talked to the mom and no one knows the prenatal history, because the syndrome is found on exam. This, you need to get the history. All right, so we'll talk about that. So how do you screen for prenatal alcohol exposure? I mentioned first asking, how far along in your pregnancy were you when you discovered you were pregnant? All right, this sets a timeline. Oh, I was 8 weeks, I was 2 months. Did you have any medical problems during your pregnancy? Were you prescribed any medications during your pregnancy? How much alcohol did you drink before you found out you were pregnant? How much did you drink after you found out you were pregnant? What about other drugs like weed, cocaine? Did you use any drugs before you were pregnant that were not prescribed? What about after? So you weave this in right into the narrative of just finding out birth history. How much did they weigh? Were they full term? What hospital? Were there any problems at birth? When did you find out your pregnancy? Did you have any medical problems? Any medications? How much alcohol did you use? It flows right together. And if you do it to everybody, it's non-stigmatizing, right? We should not be selecting who we do this for. So I work with the American Academy of Pediatrics. We're trying to get all pediatricians to screen all kids in their practice at least once during their care for the kids. All kids in foster care and all kids in juvenile justice system and all kids with psychiatric diagnoses should be screened for this as well. So in addition to this, you can get a history. Sometimes if a child's in foster care, grandma will say, oh God, I walked into her apartment and there were bottles all over the place. She would come to visit and she was drunk. You can sometimes get that. Sometimes you can get it in prenatal records, but my experience is that often the OB records lack this. The toxicology results don't include alcohol most of the time. So really you're falling back on this history. If you have other kids that have an FASD or history of substance exposure, this is high risk. Substance exposure disorder and alcoholism are progressive. So each sibling tends to be a little worse off as this progresses until the mother comes into recovery. And there are biomarkers like hair and meconium that we've looked at using. This is complicated, it's expensive. My hunch is in the future, we might be doing this with newborn screening, but this awaits to be seen. And then there's DNA methylation that they're looking at, but this is stuff that's totally research-based and nothing conclusive yet. Meconium and hair can find drugs and alcohol back 2 to 3 months. So it can be a very useful measure. The question then becomes, what do you do with that positive test? And they tried this in Toronto, and everybody was getting referred to child protection. It was a nightmare. Then they found out the lab had issues with its normals, and so it's complicated. We have to work on this. If you can't get a history, like I worked in foster care, many times the mom was not around. What are histories suggestive of this? One is early placement in foster care. We talked about how prevalent this is in foster care. The child is in the care with aunt or grandma, all right? The child was born with the toxicology to other drugs. Early childhood developmental and behavioral issues. This is the hallmark. Speech delay, early aggressive behavior, difficulties with social interactions, hyperactivity, running into the street, not recognizing danger, being inappropriately social, like going up to strangers and being too close to them, putting them at risk of being victimized. I have a child yesterday at 5 o'clock. I spoke to the mom who's got an FASD. The mom's in recovery, and she shared that she was using alcohol. This 13-year-old girl was found in the bathroom masturbating in front of her laptop, and the guy on the other end was an older man who was masturbating with her, and she had told the guy where she lives. So these are the kinds of things that you get into as you move forward. If we give interventions early, we can help prevent some of this. 2 or more past psych diagnoses, you've got to ask about prenatal alcohol exposure, especially if a kid's been hospitalized, if a sibling has an FASD, all right? So this is the most important slide. So let's take this child who's now 18. He speaks like he's 20, but this is pseudo language. It sounds better than it is. They maybe like to write rhymes. They can use words. They use fancy words. So you think, oh, they're able to talk like they're 20 years old. But if you look here, their comprehension is 6 years. So they might speak well, and you think they're talking like they're 18, but they're back 6 years, which is a first grader. Money time concept, 8 years, that's a third grader. Emotional maturity, 6 years, first grader. Social skills, 7 years, second grader. So you take this 18-year-old kid, he just graduated out of high school, you got him a job, you got him a place to live that's subsidized. He's got to get to work at 8. He's got an hour for lunch. If his boss yells at him, he can't smack him. At the end of the week, he gets a paycheck. He uses this for food, this for rent, the rest of it he can play with. You can quickly see how this falls apart, right? So day-to-day basic things, what your mom used to call common sense, is out the window. Common sense is things that we learn as we go through life. What were you thinking? I don't know, right? So doing crazy things. Another child, a 12-year-old with an FASD, was watching things on YouTube, how to steal. So he went into Walmart and he stole Pokemon cards. What else would a 12-year-old want? So they often appear younger than they are, right? 12-year-olds aren't really into Pokemon anymore. The next thing he did is the break-in. And so he broke into a neighbor's apartment after seeing this on YouTube. The guy woke up at 2 in the morning and found the kid in his basement. And it's like, what are you doing here, David? And David looked at him and said, did you see the Yankees game last night? So totally like, what is going on here, right? So this is the main area that we're working in. And this is where kids often get missed in school because it's other areas that are easily flying under the radar. So we talked about adaptive function. And this is where we get into this being a disability, where this is issues with day-to-day living skills, social interactions, that when kids that can have a normal IQ but have adaptive function that's below 70. That what Billy Edwards and Steve Greenspan, who wrote this article, Intellectual Disability Equivalence, describes this as an intellectual disability equivalent. So even though they have normal IQs, they function at the ability of a person with intellectual disability. So I've seen a guy who's 30 who has an IQ of 140. His adaptive function was 65, and he struggled through the Upper East Side, New York City private school system. He would say his friends would talk to him and he'd be, he'd have no idea what they're saying. So same thing in school. So difficulties just basically getting through the day. These are the secondary disabilities. You can begin to get an idea of mental health issues. If you are going to school every day and the teacher's telling you what's wrong with you, eventually stop going to school, right? Being locked up, if you're not going to school, you might be getting into an inappropriate peer crowd. I mentioned sexually inappropriate behavior. It's not uncommon because alcohol and substance use disorder run in families that this becomes an issue. Dependent living, problems with employment, and I would add suicide. So protective factors. We want to get these kids diagnosed. This is where you can help. Ironically, having facial features makes you get diagnosed earlier because people, like Connie said, doctors somewhat know about this. Doctors have not been taught about FASDs. I am teaching residents, pediatric residents. I've done these things across the country. Doctors do not know about fetal alcohol spectrum disorders. After this presentation, you know more than your pediatrician does. Staying in a stable home. This is the biggest thing, you know, giving a kid a base, and especially when you have a fierce advocate like Connie. You know, you guys are blessed with having FASD Maine that's been really grown roots into your state that has led to these things happening with legislation with Susan Collins and the Congresswoman. So, you know, should be a jumping point. We can do this in Maine, and you guys can lead this country. The only other state that's doing this now is Alaska and Minnesota, maybe Washington. But you guys can do this. It's a small state, a large state with a population that's manageable. All right. So one of the biggest things I think about making a diagnosis is educating the parents. So beginning to see things that kids do, not as that they won't do it. It's not because they're being defiant, oppositional defiant disorder. I hate that diagnosis. It's really because they can't do it. It's a disability. So I want to begin to change it's a brain disorder, a neurological brain damage disorder, what we call a static encephalopathy, that presents with behavioral features. So it gets diagnosed with psychiatric issues, but it's a neurological condition, right? You can do a CT and MRI. In most cases, you don't see anything, all right? There are studies that look at MRI, but I'm not going to get into that. It's more complicated. So this is not willful disobedience. This is difficulties. Shifting your expectations of a child, knowing their developmental age in certain areas of the behavior. While they might be high in one area, they can be low in another. So educating the parent, educating teachers. And this is beginning to talk about what we can do, all right? We talked about education of parents, foster parents, teachers. But one of the things I like is zone of proximal development. And this is important because we talked about how kids can be missed in the schools. The middle circle, the kid can do it, right? But let's say you've got a kid in 5th grade and he's reading at a 1st grade level. All right. Maybe he can do math at a 4th grade level, but he can kind of get through in math at school if you give him a little help and support, right? So he can move the next stage out. He can do with guidance and support. But the outer rim, if he's reading at a 1st grade, he's not going to read at a 5th grade level. You got to come down to where the kid is. And this is not just learning. This is across the activities of daily living, social interactions, every bit of the things that kind of, like I said, common sense, day-to-day stuff. Connie mentioned families first and interventions that we can do, families moving forward to give interventions to parents. And, you know, we've even talked about maybe in Maine, we can get this set up. Realistic expectations for certain areas where they have the child has difficulties, putting in place supports before the child fails. Because the schools wait till a child fails before they give services. We want to be ahead of that curve. And evidence-based interventions. We have studies that show what works. So we're doing this training because we want you to know about this, all right? Parent support services. So FASD Maine can begin to establish parent support services because this is really hard work. Raising a kid with autism and intellectual disabilities, hard work. This is really, kids with FASDs are some of the hardest kids to care for. Screen all kids in child welfare and juvenile justice system. This should become a qualifying diagnosis for intellectual disability services. So most states only allow FAS. They don't allow FASDs into this disability eligibility. So we need to work on that. This is the dream web of services where each of these people know what the heck what FASD is. and we can work together to ensure the kid reaches optimal development. All right. Again, realistic expectations from very early on, in focusing on strengths, as we're going to get into next. Because of the persistent nature of this disorder, it's brain-based, it's a static encephalopathy, it doesn't change with time, it doesn't get better with time, we cannot fix a brain that's damaged. We need interventions that go across the lifespan into adulthood, and these are severely lacking. So I argue this is a disability, we need to get services for this. A disorder implies you have a problem, good luck. Disability means you have impairments that we need to give you support services for. We're obligated under law to give support services. So this is kind of where I'd like to go, is beginning to look at this as a disability. I like thinking of this as prenatal neurodevelopmental disorder, neurodevelopmental disability associated with prenatal exposures. Leave the alcohol out. We can know what it means. We can know that the kid was exposed to opioids, but this opens a door to us getting services for these kids. So that's what I wish, but I think there's a strong academic force pushing against me. So this kind of stuff we've talked about, we talked about the FASD Respect Act. So we really need advocacy for this, and parents are the best advocates. NOFAS, National Organization for Fetal Alcohol Syndrome, soon to be FASD United. It's being rebranded. You can go to their website and get information. American Academy of Pediatrics and CDC has information as well. So this is the FASD Respect Act. It builds state-based services. So Maine, if this passes, could get funding to build systems of services that are FASD informed, help with transition, help identify these kids and give interventions. And it begins to also give further funding for research. All right. And this is the last thing. I want to show you the film clip that Connie mentioned.
I say it's an invisible disability. I think teachers and people that work with our kids, they need to know what they're dealing with. Parents, guardians, foster parents, look for their strengths. Christian is just, they said, him fantastic in art, music, gym. Oh my gosh. He did an art project where the teacher put a cake and a piece of it had been eaten and it had a candle flickering. It's like the teacher said, it was like he could reach in and piece out a piece of the cake and eat it. He could see the inside of the cake. And he said he is the only, everyone else couldn't do it. And this is something they do at the middle school and high school level, this type of drawing. So he was just blown away. And the other art teacher said, he's gifted in it. Reading, math, those are struggles for him. He's behind. Christian sings to himself all the time. He'll sing, he did his multiplication tables by singing to himself. He put it to a beat and he made a rap song about it. And when it came test time, he aced it. He made 100%. And I told this to his aide. If you could teach him to read by music and set it to some music and have some words like to music and stuff, you'd do really well. So she got with the music teacher, and when they were reading the story, she put it to a beat because she likes that type of stuff. And so Christian's level in reading shut up like, woo. Wow. So you have to think outside the box with him.
I was diagnosed in 8th grade. So pretty much all my life I've been living with it. And then I go to the doctors or a specialist and she takes one look at me and she says, you got FASD and you're on the high functioning autism spectrum. I was like, all right, I guess that, answers a whole bunch of questions of why I've been acting the way I act. But it was nothing new when I heard that. I was just living.
I think it's important for people to see the reality of FASD, but I don't want people to get the impression that because of his disabilities that we should be controlling it more and that we are in control of him. And what they don't realize is they don't get the complexities, they don't get the inconsistencies. Like Josh is consistently inconsistent. Like you don't know what you're going to get from one moment to the next.
I remember the first day I lost my other job. And I came home, my sister looked at me funny, and I lost it. I ended up taking her to the ground, and my mom was on me. And I think they kicked me out the house for the one night.
As a young kid, you don't really understand it. Like, I was told that he had these things, but I didn't really understand how that impacted the way he behaves or like the way he works at school or at like a job.
When I was younger, I've had thoughts of like ending it or ending life. And I said to myself, the only reason why I'm still here is because of my sister. And my sister's going to need me.
He sees that things are easier for me than they were for him, and he wants me to take that and run with it. And I think it's really motivational.
Ever since I moved out, like my sister wanted to spend my birthday with me. And like in hindsight, it didn't mean much, but as I think about it and all the obstacles we've overcome, and what I just did to her, that meant a lot. Just take one day at a time. I mean, like I said, it's easier said than done. But my parents have gone through so much with me. Like speeding tickets and having to call them up and say, "Oh yeah, just got arrested," and having them be disappointed in me. But those are called bumps in the road, and we get over them and we move on to the next day, and just don't ever give up.
I grew up at the intersections of two identities. First, as a gay transgender man, and second, as someone who lives with an invisible disability called fetal alcohol syndrome. Because my birth mother drank while she was pregnant with me, it caused my brain to develop differently. When I was adopted as an infant, the doctors told my parents they didn't think I would walk or talk. Boy, did I prove them wrong.
One of the biggest things about FAS is it's an invisible disability, and that not only there are physical characteristics, but when people look at me, they don't go, "Oh, he's obviously disabled."
I was given this gift of being raising Sam, and what a unique experience that was. And who gets to say as a sibling that they got to be a part of that?
When he has a decision to make, there's certainly the decision I would like him to make as an adult, but I have to be really careful to not influence that and really let it be his. Let's examine everything equally. It would be a hell of a lot easier in my life if I just told him what to do and he would do it.
Agreed.
But then you wouldn't learn for your future.
It's true. I've come into her room multiple times and I just say, "Mom, something happened. I need you to tell me what to do." She's like, "I'll give you advice. I'm not going to tell you what to do." I'm like, "Can't you just do it this one time?"
I got a very unique upbringing. I am a nanny now, and I have been for 10 years. And I always say in all my interviews, I was born a mommy, but it totally escalated when Sam came, into the family. And that's where I always say my love for children and childcare started. The doctors told us he wasn't going to walk or talk. He's a 3rd-degree black belt. He's come crazy far. And I'm just so proud of him and us and everybody that had a part in it. I didn't do it. My mom didn't do it. He did it, right? But and the the therapists and the speech therapists and the food therapists and the physical therapist and we all did it, right? Like it was this huge group of people that got him to where he is.
There are people who look in and call me things like protective, helicopter parent, all of those things. But look, this child is not suffering because of how involved I have been in his world. He is thriving because of how involved I have been in his world.
A few years ago, I heard some folks talking about FAS saying it was a trash can diagnosis because there are so many different things that get thrown into it and it affects everyone so differently. Well, I'm here to say that I'm not a trash can. If anything, I'm a recycling bin. Because I'm going to take these hardships I've faced with this invisible disability and turn it into something good for this world.
My goal, as long as I live and breathe, is to make people more aware of this. That they're born with a disability, but don't let that disability hinder them from being who they can potentially become.
We had no idea when he was 3 where we would be when he was 20. God, he's 20. That's the craziest thing, Like we had no idea where he would be at.
I know there's people that look at my kid and they just think he's bad, like rotten to the core, and he's not. He's got a really good soul.
For someone to understand it, I think they will have to have a day with the person.
I want people to know him for who he is and not for what he has, because I feel like any person really should be known for who they are, not what they have.
So I wanted to thank Constance and her husband for providing support to do that. I hope you could hear what they were saying in the conference room. And I think the value of the film is it really begins to give you an idea of the struggles, but also the incredible supportive people around these kids that help them through it. And the more you work with kids with FASDs, you see how important that is to their ability to function and to be successful, but most importantly, to feel like there's a place for them in the world. Because I think many people with FASDs feel like there's no place for them. All right, I know we're out of time, so I wanted to go back to Kelly, I guess, and Dara.
Great, thanks, Dr. Waite. And I think the audio on the video was a little choppy in places, and so several people have asked, will the video be available? Well, so
yeah,
excellent. So it definitely was one that I think you could watch multiple times and get more information out of it each time that you watch it. I wanted to start we do have time for a question and answer period. And I did want to start that with during the pregnancy. And I keep saying that the opiates have really stolen the show in Maine, and that we need to keep a focus on alcohol. And so we've been using the 4 Ps. Many of the obstetric care providers have been using the 4 Ps, a communication tool to screen for substance use. Do you have, when you talk to OB providers, do you have a communication tool that you recommend for screening?
I would have to dig that up. I think the one I presented that we did with the AEP is the most effective one. Now, in terms of OB screening, there are, I'm blanking on the name of them. I'm blanking on the name. There's 2 screens that people can use. And by the way, ACOG, the American College of Obstetricians and Gynecologists, one say that you shouldn't drink during pregnancy, but also that people should be screened during their pregnancy for alcohol. I can email you those scales. I think one's the TIP and the other,
TACE maybe?
Yeah, that's one of them. Yeah. And there's another one I think that's called the TIP, but TACE is one of them. Yes.
And along those lines, there are some hospitals in Maine that are using umbilical cord once the baby's born, sending a segment of umbilical cord to test for substance use. And I believe there's some research on that for alcohol as well. Is that anything that you're seeing in your area?
No, I think meconium is the big one because it's easy to use. And if you miss it in the OR, you can always get it on the other end. But I wonder if when they're screening for substances, if alcohol is included. I would bet it's not. But there's a way to screen for fatty ethyl esters, and that's what is a metabolite of alcoholism that you can gain going back. Now, I don't know how far umbilical cord testing goes back, assuming this is not just the blood. You're talking about a piece of the umbilical cord. So find out for me, if you can, whether it includes alcohol. I'll bet it doesn't. I think you're going to have to do this footwork on your own. I don't think you can rely on anybody to do this. My experience has been get in the trenches and work with this.
Yeah, and I think we also have some practices, some OB practices where they might screen mom's urine for, I think it's ethyl glucuronidase, but that's inconsistent, only based on, when people think people are at risk. I think one other question that came up was, what about the male partner, the father of the baby? If the male is an alcoholic or a binge drinker, can that contribute to FASD in the baby?
The primary way we understand this now is it's a direct neurotoxic exposure. There is some evidence that alcoholism can affect male chromosomes and genetic materials, and this is very early on. But the main thing is this is an incubative disease, prenatal exposure during pregnancy. Having said that, if a dad is drinking and binge drinking, usually people want to live with people who say, yeah, sure, let's party. They don't want to be with someone who says, you need to stop drinking. Right? So I think that is often a sign that there might be issues in the house, as well as domestic violence.
And someone brought up that, again, and this goes back to the conversations with obstetric care providers, the telling patients that a little wine won't hurt.
Well, I can forward you the ACOG statement. It's clear as day. And those people might be old timers, but a lot of people, you said, oh, it calms the uterus, it's good for your stress level. But we don't know a safe amount of alcohol. Let's put it this way. If you were pregnant and I gave you a bottle of lead, would you drink it? So this is what alcohol is. It's a neurotoxin, just like lead. So why risk it? And if you do risk it, why are you risking it? My hunch is if you need to drink, it's because you have a problem with alcohol.
And I did hear one maternal fetal medicine physician, a high-risk OB, who talked about the question that he asks every pregnant woman. And his question was, when you found out you were pregnant, did you have a hard time stopping drinking alcohol? And most women will, or many women will say no, because, that first trimester, your stomach's off, your taste buds are off, everything's off, and you don't want to drink coffee or alcohol or anything else. And he talked about this woman that was referred to him because her baby was severely growth restricted in utero. And he started doing her ultrasound and he asked the question and she burst into tears. And it was that she wanted to tell a provider, but nobody had asked her. And he was the first person. She was, I think, about 8 months into her pregnancy, and he was the first person to ask her about alcohol use. And so I thought that's a good subtle question to ask people, because your taste buds do change immediately.
Yeah, and I think that God bless him for asking that. And, you know, I think even if you don't get a positive response, you're opening the door to a conversation. And especially OBs, this can be something that you screen everybody. It shouldn't just be at-risk people, because I don't know what at-risk people are. Alcoholism is non-discriminatory. And so everybody should be screened with this. You know, oh, you found out you're pregnant 6 months. How much did you drink before you found out you're pregnant? That's not a, like, oh my God, why is he asking me that? I ask all my patients that, right? So I don't think this is an outlandish question that takes about 10 seconds to ask and get a response.
Right. And we did have somebody chat in, thanks Katie, that ethyl glucuronide tests for alcohol metabolite in umbilical cords. So if you send that Wharton's jelly, they are able to test for it. You have to ask for it. Another question was, if a child has a diagnosis of FAS or FASD, do they automatically qualify for a 504 or an IEP?
You can use this to get accommodations, a 504. And oftentimes it'll come under like the same thing we do for kids with ADHD. But one of my arguments is this is beyond a 504. This is a pervasive issue that really does often need an IEP, because the services need to be individualized to the child. And one of the issues with getting an IEP is the schools want to put kids in the least restrictive environment, which means you wait till they don't do well until you consider testing or giving them support services. So this is where I think I try to get my parents to be ahead of the wave and push for getting their child evaluated with that diagnosis, but most people don't know about it. So often I have to get on the horn and push. It's not easy.
Yeah, and so there's actually a couple of questions about if someone is diagnosed with an alcohol use disorder during pregnancy, is there any sort of medication-assisted treatment, or how can we help pregnant women who have an alcohol use disorder?
Well, I think oftentimes alcoholism is associated with underlying issues. Probably the most common one is anxiety, and people are self-medicating. But alcoholism itself is a notoriously difficult thing to treat. So we will sometimes use naltrexone, which is one thing that's been used. I don't take care of people on that side. I take care of them after birth and the developmental issues. So I, by no means am an expert on this, but in general, for alcoholism, naltrexone has been used. I don't know that a pregnancy safety rating on that. I think it's okay. And then things like bupropion, but again, and SSRIs, but you have to weigh the risk benefits there. Look, this is a tough disease to treat, and we as doctors are not good at treating it. It's just, we don't know what's going on, you know, and so trying to get somebody to stop drinking is a difficult thing.
Yeah, and people have chatted in a couple of different medications, but again, to your point, there aren't a lot of medications that are approved for use in pregnancy. And so it becomes that, I think, that balancing act of, well, if alcohol's not approved for use in pregnancy either. And so from the harm reduction perspective, how do we support this woman and provide treatment and keep her and the baby as safe as possible?
Without criminalizing her alcoholism is one thing, because I think that's a big issue. I think it's a good question. And this is why I think there's always going to be FASDs. I do not think this is 100% preventable, because alcoholism is not 100% preventable. But what I want you to come away from after this talk is to know what this looks like after a child's born with that. Because I think you're going to be seeing these even when we have effective treatment for alcoholism. I think it's going to be a very difficult thing to treat. So yes, I want screening in OB and I want to do prevention. But I also am realistic about how difficult it is to treat alcoholism and substance use disorder.
So there's a question about, say, if you're a mental health provider and you have a patient who's been diagnosed with autism, but you suspect that there's fetal alcohol effects, how do you have that conversation with the family to raise this alternate diagnosis with the family?
What I would do is, I mean, a lot of times it depends on the age. And a lot of times these kids are diagnosed with autism with speech delay because of their speech delay, and they so-called outgrow autism. So they're not necessarily having a lot of the behavioral features that kids with autism do. And their behavior, their issue primarily becomes behaviors in school. So to me, you can have both diagnoses. I do it all the time, right? But I think getting the history is part of this. And if you didn't get the history when the child first came to you, you can go back and say, listen, I want to try and put together and just rethink this because some of the things aren't making sense. And I think that they're not making sense to you because you're being frustrated with what's going on. So let me just go back to you know, when he was born and before he was born and revisit that. And I think that if you get a positive history of alcohol use before pregnancy recognition at, say, 6 months plus, or, you know, I have people that drink substantially before 4 to 6 weeks, and I would consider that prenatal alcohol exposure and put that in. If you have a history of prenatal alcohol exposure in a child with autism, I think that child has an FASD. Now, how you begin to approach the diagnosis of FASD with a parent is a process. Recognizing that parents are often ashamed of their past use, mothers especially, because they feel they might have damaged their child. But also you mentioned the woman who was relieved. And relief is one of the biggest things I've heard. Because people are always wondering, did that maybe make this happen? So, you know, I would probably begin to address it by saying, look, you know, I'm not saying this is necessarily what caused this, but we know children who were exposed to alcohol before they were born, often before moms knew they were pregnant, often have the same kind of difficulties that Johnny's having now, and begin to tread on that level. We could keep the diagnosis of autism to keep things running, but there's a point where autism services become inappropriate, where kids have social ability beyond autism, but still have struggles with conversation and interactions and behavior.
And so that leads very nicely into another question, which is, where is the best place to have a well-rounded evaluation?
Constance, I'll let you take that. I mean, I think in Maine, I mean, this is tough in Maine right now. Yeah. But I have done trainings for the AAP in Maine for the adoption foster care people, so they know something about it. And we did the Colby presentation that Constance mentioned in 2017. And I think this is a work in progress. The American Academy of Pediatrics, we're training residents on this. We have programs to teach residents. So one thing that if you have a medical school near you, that medical school, that residency program can sign up for this course. It's still open for registration, but they need to hurry. And that trains your residents on how to recognize this. We need to get a diagnostic center in Maine, right? And I do this, and I'm flooded with referrals from across the country sometimes. There's not that many, there's no funding for them now. So Rochester is far. There's a guy in Vermont, in Burlington, Joe Hagan, who could do this. You know, and there's people in Boston that can do it too, at Boston Children's in the Developmental Behavioral Clinic. But, you know, I'm happy to try to steer people. I don't want to like jump out the window because I'm already totally overwhelmed, but I'm happy to try to do what I can from afar.
So that's great. And Constance, would you unmute and jump in? And if you are okay, can you share a little bit about your experience of trying to get a well-rounded evaluation?
She's still mute. You're still muted. Do you have to unmute her, Kelly?
I don't think, let's see. I don't know if I have that ability. Lorena, can you unmute Constance, please? There we go.
You can hear me now?
Yes.
Okay. So what was the question?
So the question was, would you be able to share a little bit about your story about finding a place where you could get an evaluation for your child?
I'd be happy to talk about that. One of the things that delayed our diagnosis was that we did move a couple times when our child was little, but in none of the communities we lived in could we really find easy diagnostic resources. And it was baffling because I would talk to, unlike a lot of adoptive and foster parents or birth parents, I had been aware of fetal alcohol syndrome even before we adopted. I wasn't aware of fetal alcohol spectrum disorder, but I started, hearing about it. And so I started asking about it, and the doctors or other professionals we would go to would say, they obviously were thinking about the diagnostic criteria of fetal alcohol syndrome. And so they would say, I just don't see it in your child, so I'm not going to make a referral. And finally, we looked on a list of resources on the NoFast website. And I thought, I really, it really seems like this might be it. So it would be good to go to an expert. And we found somebody at Mass General Hospital who was on the list, and she's now semi-retired. But it was, it took 6 months to get the initial appointment, and it took 6 months to get the follow-on neuropsych evaluation. So, that's, the waiting was very frustrating and all that time being lost. But we did get a definitive diagnosis of fetal alcohol spectrum disorder, one of the diagnoses under that umbrella. And one of the things that was very important, as Dr. Waite talks about, is that we needed to make sure that the educational testing or the neuropsych testing included a test for adaptive functioning. And I think the leading one in this field is called the Vineland, but there's another one that was used, and it was very, very clear. It was indisputable that our child had, a fetal alcohol spectrum disorder. So that's why, when I talk about this, I do say that it's vitally important that we get diagnostic resources in Maine. It's hard for people to believe that with so many resources for autism, so much awareness for ADHD, that there aren't people that are familiar with diagnosing this in Maine. But we have not really found people that are, really familiar with FASD. And on the other hand, fetal alcohol syndrome, there's a couple of geneticists that, that people get referred to. And, one's at Eastern Maine Medical Center. But geneticists, again, they're not trained in ADHD. They are trained in the physical features. And Dr. Waite can talk a little bit more about that.
Yeah, I think that this difficulty is nationwide. There are pockets of diagnostic centers that were funded previously under SAMHSA that have gone away. The FASD Respect Act would put some funds there. But I think the way these kids ride under the radar makes it very difficult. Just think of the kid that was at the end, I forget his name, Sam, who was 20, who spoke so eloquently, But when you look at him next to his mom, he's wearing a goofy t-shirt, right? He has a quality in his interactions of a 12-year-old kid, even though he's 20. So this begins to hint at some of the issues. He can't do a lot of things, and he asks his mom to tell him how to do it, right? So this is very often difficult to pick up, and you really do need somebody that knows about this. So I think we can do this in Maine. I think we could get people that are trained. I think that we could have an FASD diagnostic center with the monies provided by FASD Respect Act.
Thank you. Thank you for sharing, Constance. I think I grew up in the Bangor area, and I know that traveling to Boston is huge. And for people who have limited resources, it must be overwhelming. So again, having something here in Maine would reduce a lot of those barriers. And Dr. Wendy Smith, one of the geneticists in Maine, actually trained in Washington State and is familiar with the diagnostic criteria. She's also busy doing the regular genetics work. So it's all a juggling act.
And oftentimes the geneticists know the FASD diagnostic criteria, but they don't know what adaptive function is. They don't know what a lot of these other neurobehavioral issues are. So I think that's the risk, is you go and you hear, like what Connie said, I don't think he's got it, but it's 1 in 10 kids.
Yeah. And so, Constance, there's also a question about peer support groups related to FASD in Maine. Can you talk about the work that you and Madonna are doing and Shannon are doing, and any support groups that might be helpful?
Yes, well, FASD Maine got started just shortly before COVID. And so a lot of the types of support groups that would normally exist haven't really been happening. But there is a lot of support for people. Parents are finding each other. Parents are finding research online. And it's legitimate research. I mean, there's 50 years of research on fetal alcohol. So if you're looking for information, you can find it on FASDmaine.org. If you're looking for daily updates on what's going on in the FASD world, FASD Maine on Facebook has it. And, we also, people will also share, like, has anybody found, this resource or this, that school, but we're not primarily a support group. There are national support groups, and, a lot of them, I think really the best one is based on the book by Diane Malbin called Trying Differently Rather Than Harder. And it takes the neurodevelopmental approach to parenting and educating young people with FASD. And it explains how the brain differences present as behaviors and what to do about that, like how to accommodate that. So there's a group that helps parents talk about how to apply these concepts in the child's daily life and in your parenting and in the kid's education. And that's very, very helpful. That group is called Shifting the Paradigm.
So I just also want to get back to, as we talk about this, what other disability could affect kids, 2 to 5% of our children, and nobody knows about it, right? What's going on here, right? So we have to begin feeling comfortable treading on this ground. It's not, after you do this a couple times, it's not that hard. And like you mentioned, Kelly, people are often relieved, right? They know this isn't good.
Yeah, and that's one of the things that we try to address. And one of the reasons why my co-founders of FASD Maine and I are willing to talk about our family stories is that it does reduce stigma. I mean, we're not ashamed of our loved ones who have FASD. We're proud of them. And we want to talk about it as much as, they will allow us to with, their privacy limitations. We want people to know that these are valuable people. They have a lot to contribute to society, but they need help and they deserve help. And help is what they're not getting right now.
in the one last thing, I know we're running out of time, but you can go to the NoFast website. I was going to look and see yet if they've done, I don't think they've rebranded the website yet, but National Organization for Fetal Alcohol Syndrome. So nofast.org. And there are parent groups. There's one that Kathy Mitchell, who's the vice president, runs. And there are also, you can sign up for the newsletter that has research, events going on that people can attend, conferences, lots of information.
Yeah, there is so much going on in the world of FASD. It's a very exciting time to be learning about this and to be active. I mean, the FASD Respect Act is going to be a huge game changer. And having, 2 of Maine's members of Congress already signed on, and the prospect of 2 more, we could be the first state where all 4 of our members of Congress sign on to co-sponsor this bill. It'll take some reaching out on your part, but it can happen, and it would be huge.
Great. Well, I want to thank Dr. Waite for taking time out of his enormously busy schedule and in awe of what you are doing, and to be seeing patients and spreading the word is really impressive, and appreciate that. And to Constance for sharing your family story about the challenges and about some future directions. I think it's easy. It's not easy to name problems, but we can identify problems, and you've given us both the problem and some potential solutions. So for that, thank you very, very much. And any final thoughts or words?
Yeah, I just wanted to say, I want to commit that if we do get funding for this, that I am willing to come up and help you guys start up a clinic there.
Wow.
I think this is that important. So, I think if we can get this through, if we can begin to talk about this, even if the FASD Respect Act, sits on the desk in Congress, we need to move forward, because we can't wait for the legislators for this.
Yeah, I agree. Maine is one of the top 10 states in most studies for women drinking. So there are a lot of people affected by fetal alcohol, tens of thousands of people probably. And, so thank you, Dr. Waite. We can really use your help, and we appreciate all that you're doing already. And I also want to say that next up after the break, I believe, is Kathy Mitchell, who is the founder of NoFast. And I can't wait to hear her recovery story.
Great. And I think this is a great reminder for those people who are working with women during their pregnancy. Even if the focus is on a different substance use disorder, please do also keep alcohol in mind as you're having those discussions. So thanks, everyone. There's a lot of great comments in the chat box here. People really appreciating the presentation. So thanks, everyone. And I believe we have a bit of a break right now. So we'll see you after the break.
Good afternoon. My name is Kathy Mitchell, and I'm the Vice President and the spokesperson for the National Organization on Fetal Alcohol Syndrome. And I am just delighted to have half an hour to speak with you, not only about my recovery story, but about alcohol and substance exposed pregnancies. So hopefully some of you were able to attend the session right before mine, which was led by Dr. Doug Waite, who's a dear friend of mine and on our board of directors, actually. But for those that may have not been able to catch that one, just a quick overview is that when a fetus is exposed to alcohol, it can have lifelong implications. So fetal alcohol spectrum disorders are the leading cause of preventable intellectual disability and a leading cause of birth defects and learning and behavioral disorders. And alcohol affects the development and function more so than other drugs or teratogens. And the Institute of Medicine quote from 1996, when they had a roundtable meeting on this topic, of all substances of abuse, including cocaine, heroin, and marijuana, alcohol produces by far the most serious neurobehavioral effects in the fetus. And the same holds true today. So if you want to sit on the most dangerous seat in the Titanic when you're pregnant and using substances, it certainly is the one. Alcohol is the worst. So alcohol is certainly a legal drug, but can affect that child's life for the rest of their lives. So of course it can attribute to a whole range of growth defects and birth abnormalities. Another aspect to alcohol and alcohol use and pregnancy is the fact that it is a leading cause of both infant mortality and SIDS. So there has been long-term global research on this very topic. And I believe it's called the PASS, P-A-S-S, but if you Google it, you can certainly find it on our website, and I'll give you that URL at the end of this session, but it's nofast.org. We have over 300 videos available, and where we've interviewed various researchers and leaders in the field, as well as people living with FASDs and families. But Dr. Ken Warren, who was the acting director of NIAAA for years at NIH, is quoted as saying that alcohol use while pregnant is a leading causal factor in both fetal and infant death. And again, I don't know if Doug covered this or if you'll hear this in the next session, but you know, as a society, you know, we drink. Recent surveys from the CDC showed that more than half of all women of reproductive age that aren't pregnant drink, and 18% of women who do drink binge drink, and that would be 4 or more drinks at one time. And the scary part is 1 in 9 women, at the time they did the survey, reported any alcohol in the past month. And out of that 1 in 9, almost 4% were binge drinking. And any amount of alcohol can certainly affect the developing fetus, but we know that it's the binge drinking, or 4 drinks or more at one time, that is associated with visible effects. And I did a grand rounds presentation for the CDC back in August of 2019, and one of the other speakers was a world-renowned researcher on polysubstance use. But I really love this slide, and I wanted to include this slide. 2%, she found that 2% of reproductive age women who reported non-medical opioid use and was reporting on some of their patterns of use. So first of all, I think that one of the things that is very important to understand when we think about substance exposure and pregnancy is that women that are living with a substance use or an alcohol use disorder are typically using a lot of other substances. So polysubstance exposures are the norm, not the exception. So here she's reporting 56% of women that use non-medical opioid use. And right then and there, someone that uses opioids that has not been prescribed should, of course, be a red flag right there. More than half were using cigarettes, half reported binge drinking. And in this situation, in this research, they define binge as 5 or more alcohol drinks in one setting. 32% reporting marijuana use, 22% using tranquilizers, 7% using stimulants. And the importance of this is to understand is don't focus on one thing. So if you've got a client who might be smoking cigarettes, for instance, it doesn't mean that she has an alcohol or substance use disorder and using other drugs, but it means she could be. So factor those things in. So sometimes you have to kind of put everything together so that we're giving women all the information they need. And another study that I thought I wanted to include was the UNC study. I am a member of CFAS, the Collaborative Initiative on FASD, and that is the researchers that are funded through NIH, NIAAA. But Dr. Scott Parnell has been looking at marijuana and how that may affect developing fetus. So in animal models, he found that early use of marijuana could cause malformations in the developing embryo. But they also found, and this piece I think is really, really important, because in most of our country, alcohol and marijuana are the most common substances that are being used right now, especially by our younger women. But when he found that when marijuana and alcohol were used together, the likelihood of birth defects more than doubled. So there's a lot we don't know about, but what we do know is, it seems that, I won't say it seems, we know that alcohol use during pregnancy can absolutely harm the developing embryo or fetus. When we start adding other substances, it seems to magnify the problem. When we add in poor nutrition, stress, and trauma, then, again, what we believe is when all of these variables come together, the risks just go up and up and up for having a child that may be permanently affected from being prenatally exposed. So, yes, I am going to get to the recovery story, and here I go. So that is a picture of me when I am 16 years of age. And when I was 16 years old, I didn't know I would become one of the great villains of our country. I've been part of a research team for the past 4 years, and research is very clear. We've done research looking into healthcare providers and their attitudes and biases, and also with the general public. And the stigma, bias, disdain, and blame towards women who have had children affected by use during pregnancy is just off the charts. So the researcher that headed up this, our research, Dr. Patrick Corrigan, was really surprised and blown away. He had no idea that we would kind of score like double that of women who had been incarcerated and lost their children and all kinds of other issues that are clearly stigmatized. But, girls and women that suffer with substance use or alcohol use disorders come in all different shapes, sizes, and ages. And I've been doing this. I am in long-term recovery. I have been clean and sober in 12-step recovery for over 37 years. And in those 37 years, I have been working in the field of addiction and fetal alcohol syndrome. And in all the years of my work, and I've traveled all over the world talking on this topic and working with government agencies and speaking at conferences and the like, but I've met all kinds of women. And I have never met not one woman who purposely harmed her own child. So some people hear about this issue and their knee-jerk reaction is, oh my goodness, you work with those women. Oh, poor you. Those women are monsters. They ought to be tarred and feathered. What a terrible thing to do to your own child. And that's just not how this thing plays out. So I'll tell you a little story about how it played out for me. And it's still, unfortunately, happening to many women right now as I'm speaking in much the same way. So of course, the session following me is an expert on motivational interviewing. And of course, that is part of the answer here is screening women for alcohol and other substance use, providing brief intervention, and referring them to treatment, certainly. So we've got to do a better job of talking with women and pulling their stories out of them and directing them to services and letting them know that we care about them. Because when we don't, we can hurt not only them, their children they haven't even become pregnant with, And it goes on and on and on into grandchildren and great grandchildren and down through the generations. But when one baby is born with effects, it absolutely trickles all the way through the community, the family, and the like. So we need to do better. I included this picture of me when I was 23 years of age. And at 23 years of age, I had already had 3 children. And I like this picture because this picture here shows a young lady who was very excited to have a baby, loved my baby. I had natural childbirth. I did not take one drug. I breathed, I did Lamaze, I had a midwife. I wanted to have a healthy baby. But unfortunately, with this baby and with all 3 of my children, I drank when I was pregnant. Now, this is a picture of my 3 children in 1977. I had my first 2 children, 71 and 73. The information about drinking and pregnancy hadn't even come out until 1973. So I had already had 2 kids. And when I was pregnant, we would hear things like, you know, if you want to have a healthy, fat baby, you should drink a beer a day. Wine's really good for the baby's blood. You know, I grew up in an environment, my family owned bars and restaurants, and I grew up in the restaurant business. My father suffered with alcoholism, but we didn't call it alcoholism. We just called, you know, he, you know, drank too much and then he went on the wagon and he acted like a jerk when he drank too much. Both my grandfathers suffered with alcoholism, but we didn't call it alcoholism back then. We called it liver disease, and, you know, it all got kind of covered up. So I had 3 children and drank, and I didn't drink. I was a young girl when I got pregnant. I was in 10th grade. I, you know, dropped out of school when I got pregnant in 10th grade. I married the father of the baby. He also suffered with substance use disorder. We had no idea. We were like 2 dumb kids, basically, and had no idea that what we were experiencing was an actual disease. We grew up in, you know, the Woodstock era. It was drug, sex, rock and roll. And, you know, I did not drink every day. I did not use drugs every day, but I did drink and drug as part of a lifestyle. You know, I would smoke marijuana. I would trip on LSD. Not when I was pregnant, though. I didn't do any of that when I was pregnant. I just drank, and I drank wine, believing that was perfectly fine. This is a picture of my daughter, Carly. Carly has fetal alcohol syndrome, and that's a picture of her when she was 10 years of age. And if you know anything about fetal alcohol syndrome, Carly has the classic facial features of fetal alcohol syndrome. She has a very thin lip, a very flat filter in the area of skin above her lip, under her nose. If you were to measure her eye opening, they would be a little bit shorter than what would be considered normal. She had microcephaly, or a smaller head. She was very thin and did not gain weight, and we called her string bean. When she was 10, she was diagnosed with cerebral palsy, etiology unknown. So I've jumped around a little bit on this, with this story, but, you know, just to back up and kind of underscore some of the main points. Drinking in my family was very normal. It was part of what we did. Had no idea that alcoholism was a disease that was treatable. Got pregnant young, and the reason I got pregnant young is because I was already an active alcoholic and had no idea. When I drank, I had blackouts, and when I went into blackouts, I did things. I obviously had sex with boys, or a boy, and I used drugs. And, you know, if drugs were around, here, smoke some marijuana, take this, take that. I just went right along with it, because being the child of an alcoholic, I was had the characteristics of a child of an alcoholic, and exposed 3 kids. And then my life got really crazy. I left my husband, found myself another addict, alcoholic, of course, because I recreated the family that I came from. I married a second man who also suffered with an addiction problem. But again, had no idea that we just were so ignorant about all of it. But I got pregnant with this second husband. I never planned on getting pregnant. I used birth control. But again, part of the story here is you don't use birth control that requires you to have to remember things every day when you're in active addiction. So I would forget to take my pills, got pregnant, and thought, well, maybe if I have this baby, it'll help us to blend together and be one big happy family. So I had all this distorted thinking. Had a little boy. My boy was born 2 months too early, and my son died the day he was born. And when my son died, I didn't have the coping mechanism to deal with his death. And I remember leaving the hospital, and all I wanted to do was, to get drugs. And by then I was a heroin addict. And about 9 months after my son died, and I went into a spiral of self-pity, pour me a drink. And about 9 months later, I got pregnant again, and I just couldn't even believe that I allowed this to happen again. But again, that unmanageability, when you live within substance use disorder, that's what it is. I couldn't manage anything, certainly not my own body. And I got pregnant, and I just didn't think I could have a healthy baby. I went to the doctor. I found a doctor at Georgetown University, an OBGYN, who took me on for free. I was scared to death to have the baby. I was on methadone. They told me I had to stay on the methadone. And sadly, I never heard anything about drinking. And the crazy part is that I never thought about drinking as anything other than eating a peanut butter and jelly sandwich. I never thought of drinking as a drug or anything like that. Drinking is just part of what you do. It's just, you just drink, and I smoke cigarettes. And so I was on methadone, smoked cigarettes and drank, and also was on a prescription of Valiums and kept trying to come off of them. But 2 weeks after I'd stopped taking them, I'd get really sick. And I had no idea about the afterlife and all of that. Sadly, the doctor that treated me had no idea about treatment and recovery, never suggested it, never asked me about my alcohol use. Well, I gave birth to a beautiful little girl, and I jumped off the methadone program. I did not like being on methadone. I hated it. I got myself a little apartment and was just determined to be a good mother, which is the irony to my entire life, really, is that all I ever really cared about was being a good mom. And, but of course, my addiction did not allow me to be a good mom. And I brought the kids and got my kids in school and was detoxing off of methadone on my own, taking gobs of pharmaceuticals and drinking. And when my daughter was almost 3 months of age, I went into her bedroom and went to pick her up. But she was lying very still. Sorry, there's a truck on my road that you're probably hearing. But I went to pick my daughter up, and she was not breathing. And my daughter had passed away. And I went into complete shock and was screaming. And long story short, that was the catalyst that led eventually to my recovery. And in recovery, I had to get my GED. I went to treatment. Thank God, it's what saved my life. Got into treatment. I got my GED. I started going to school. I eventually got my master's degree. But throughout this process, I started to uncover these webs of lies, basically, or just of ignorance. And I realized early in my recovery that my dear little Carly did not have cerebral palsy, but had full-blown fetal alcohol syndrome. And I brought her back to Georgetown and told them what I suspected, and she was diagnosed with full-blown fetal alcohol syndrome. I do apologize for the background noise. There's absolutely nothing I can do about it. So I had 5 children. My last 2 children died, I believe. You know, my daughter, they said she died of sudden infant death syndrome. And again, I've worked a lot in that field as well, working on alcohol as a causal factor in fetal and infant death. Both of my children died as a direct consequence of being exposed, of really me not getting treatment, is what the way is really the truth. So my daughter, here's a picture of my two little girls that did survive, but certainly all of my children were affected in different ways. But my daughter, who's now in her 40s, but when she was 35, I went to the doctor's with her once for a lupus checkup. And I just jotted down all of the health issues she had. One of the things that we know that is being researched now is that drinking in pregnancy, it certainly affects brain development, but it absolutely affects lifelong health outcomes. So my daughter suffers with autoimmune disorders, migraine headaches. She's got a brain tumor. I mean, the list goes on and on and on. Even though she's never been diagnosed with an FASD, I really believe that drinking during pregnancy sort of set her up for lifelong health issues. And the really good news is that when we intervene and we get women the treatment and the support that they need, we affect not only their life, but lives to come, as I mentioned before. And the miracle in our family is that none of my grandchildren were exposed to not one drop of alcohol or other substance. And that is a miracle, because in so many families, it becomes multi-generational. I had mentioned the stigma, and I just wanted to talk to you briefly about that in 2016, because it's a really big deal. I think it's a really important part of this and why women aren't getting the help they need. I allowed the Washington Post to do my story, trying to educate people. My whole life has been, once Carly was diagnosed with fetal alcohol syndrome, I became a spokesperson. I testified on hearings to Congress and became a change agent, trying to educate people about this. But the Washington Post did my story, and now with social media, all of the trolls came out, and there were just hundreds of thousands of people that did want to tar and feather me. And it became very clear that people don't believe that addiction is a real thing. People really do think that a lot of women can control their use and they should be punished severely. And, and I can tell you, as a birth mother and a person that knows a lot of birth mothers, if that worked, I would take the tar and feather. You can put me to death, actually, if that helped. It doesn't help. All it does is make things worse. What helps, I hate to be Pollyannish, but is love. What works is love and support and compassion and education on why some people become addicted and others don't. So here's some highlights here about stigma. Stigma leads to discrimination. When there's a stigmatized issue, they're not funded. Legislators do not want to fund issues that they think just happens to those people that they don't care about anyway. And there's always less dollars for stigmatized conditions. The way we stigmatize women today, the way we're acting it out, any group of people that we want to gain control over or power over because we see that them as less than, the first thing we do is to remove their kids. So now we have a system where we immediately remove the kids. And sometimes you have to, I get that, to take care of the kids. The kids come first, they must be safe. But we don't give any regard. There's no funding to help the mothers, the families to heal, to get them into treatment. So there's this whole system that seeks to criminalize women, to remove their kids. And it does more harm than good, I do believe, in many situations. Not to say God bless the people that foster care our kids and adopt our children. I'm not saying that. I'm just saying we need, our systems are really broken. And, and the other piece I just want to discuss very quickly is stigma hurts. Women do care about what you think about them. When you talk to women, be gentle, non-judgmental, have compassion, try to put yourself in their shoes. Try to assume that she's doing the best she can with what she has to work with, and avoid using stigmatizing language. And never underestimate the power of listening and connecting with someone, even just for 1 to 2 minutes, and let them know that you care. Look them in the eye, let them know they matter. Because if they don't know that they matter to somebody, they don't have a chance in hell in making it. And it does matter that people love them and see them as worthwhile. Just wanted to tell you about a group I started during COVID. There's the URL, recoveringmothers.org. We meet every Thursday. It's for any woman who has used any substance or any during pregnancy, alcohol. And we have brand new moms. We've birthed 4 babies, and we have moms that are old like me. There's the information on NoFast. And here's my email. And thank you so much. And I welcome an opportunity to connect with you. And I'm sorry I didn't have more time to see you and connect with you and take questions. But but maybe, you can connect with me via email or through NoFast. So thank you so much. And I'm going to turn it back over to the conference people now.
So first of all, thank you, Kathy, for that wonderful presentation. I am Robert Rogers. I'm the Director of Substance Use Prevention and Grant Services at Kennebec Behavioral Health, and I have the privilege of introducing our next presenters, Amy Shanahan and Lori Johnson-Wade. Lori, along with her husband, Dr. Von Zell-Wade, co-founded the Lost Dreams Awakening Recovery Community Organization and the LDA Recovery Community Center. Lori has a strength and passion for learning, a national certified behavioral specialist, Pennsylvania certified board recovery specialist, family recovery specialist, and recovery support supervisor. She is also a trainer of the CCAR Recovery Coach Academy and Ethics for Peer Providers. Additionally, Lori is a certified NADAC recovery coach, forensic peer specialist, trained facilitator of the Pennsylvania Family Support Alliance Recovering Families Programs, and the founder and president of Western Pennsylvania Grandparents as Parents. Lori's passion is advocacy, and she is a staunch representative of the recovery community locally, statewide, and nationally. Lori brings over 28 years of lived recovery. Amy Shanahan is an advanced implementation specialist for the Opioid Response Network. She is the owner of Compass Consulting and Training, LLC, where she draws on 25 years experience in addiction medicine. First as a clinician, then supervisor, and ultimately administrator. Amy has provided evidence-based behavioral health consultation and training to peers, professionals, and criminal justice personnel, providers, and others. She's conducted workshops and delivered presentations across the US and internationally on diverse subjects, including leadership, clinical supervision, motivational interviewing, LGBTQAI, contingency management, and creative problem solving. Amy has been a member of the International Motivational Interviewing Network of Trainers since 2016. Amy recently was the director of addiction medicine for Western Psychiatric Hospital at the University of Pittsburgh Medical Center for over 11 years, where she launched quality improvement initiatives and managed prevention and intervention programs in treatment clinics, specializing in co-occurring substance use and psychiatric disorders. I'll be monitoring the chat so we can have some Q&A at the end. And again, welcome Amy and Lori.
Thanks so much, Rob. We're just going to dive right in. We have about 40 minutes to leave you with some time to ask some questions, and we promise you we're going to give you about a day's worth of information. First, I want to say I would imagine many of you have heard of motivational interviewing. Some of you are probably practicing some of the motivational interviewing. And for those who may not, might be wondering, why should I care, right? There are over 2,000 clinical trials and meta-analyses that 2/3 of them show promising effects of motivational interviewing. The thing that stands out to me, a few tidbits as well, is using motivational interviewing, motivational strategies for 15 minutes shows a huge effect at 64%. And we know that MI outperforms traditional advice giving in the treatment of a range of behavioral health strategies and other diseases. I know my experience in the addiction medicine services at Western Psych that Rob just mentioned, we used motivational strategies in our outpatient clinic and saw a 20% increase to the second appointment in early treatment. So it really speaks to the notion of engagement in early treatment. And certainly if there's anything that we can convey today is the importance of engaging people in treatment in a non-judgmental way and leaning in to help them feel more comfortable so that they can come back and receive services. So we're going to do a quick overview about what MI is. We're going to explore the spirit a little bit. And then Lori and I are going to take you through an interview back and forth in a role play so that you can observe some of the skills and the notion of the spirit of MI. What is motivational interviewing? Simply put, it's a conversation that we have with people about change that they're ambivalent about. To me, this is the conversation that you'd have on the elevator to tell people what MI is all about. So we use a lot of acronyms. So I will be using MI probably interchangeably, and we'll share some other acronyms as well. MI is a guiding style of communication. And to me, this is about walking down the path with someone, as if you're walking with your colleague, your friend. And it's about providing them with their own ideas and empowering them to share their own ideas, drawing out from them their own ideas and motivations for change. And we hear a lot person-centered, and that's what this is about. It's about the person. So for me, in a summary, I might be the expert in addiction medicine, let's say, and the person I'm speaking with is an expert of themselves. And together we're going to explore change. We often talk about the motivational interviewing spirit as if it's without it is like having the words to a song without the music. The spirit isn't this thing that can't be seen or heard or felt or observed. So we identify the partnership as the first aspect of the spirit, is that notion of walking along the path with someone. So it's a little different than offering our advice about how they should go about something. We'll collaborate with them. The second aspect of the spirit is about accepting them versus rejecting them or judging them. This is truly that essence of honoring someone's worth and where they are and honoring their autonomy. Acceptance doesn't mean that we say, I agree with you, or that we have to agree with someone, but it's just understanding that that's where they are. And certainly this notion of compassion, we talk a lot about having empathy, understanding someone's worldview, stepping in their shoes to get an understanding of where they are. So really listening in to understand what's making them tick. And finally, the evocation part of the spirit is that notion of drawing out from them what's already there. We recently had a conversation with Steve Rolnick, one of the co-authors of Motivational Interviewing, and we asked him, so what would we tell people who are just exploring MI for the first time? And he says, let's not get too clever about things. If they could sit with a person and truly believe that this person knows much about themselves and how they want to go about that change, we could just be there with them and guide them along that process. Many of you are familiar with the OARS, which is open questions, affirmations, reflections, and summaries. These are the micro skills that we use in motivational interviewing. Miller and Rolnick, the authors of MI, lean in and whisper, we didn't invent the OARS. They've been around a long time. You often probably use them yourselves without knowing it, or you do it use them on purpose. And you could watch people interact, and we invite you to watch Lori and I interact and identify not only the skills here that you're seeing in our interaction, but also that notion of partnering and accepting as we just described in the spirit. Our conversation is going to unfold following these 4 processes of motivational interviewing. The 4 processes are the guide that helps us identify what's our intention with a person. The first aspect is engaging. We can't have a conversation with someone about change without forming a relationship, finding some rapport, engaging with them in a conversation. I often talk about the opposite of that is, we get the pen and the paper. Okay, now we get the keyboard, right? And start asking the questions and doing our assessment and checking off the boxes to get to the next phase of where this person needs to go. And I often encourage people to take our fingers off the keyboard and sit with a person, even just for a minute or two, to engage. And in the engaging process, we want to identify how comfortable is this person talking to us? Do I understand where they're coming from? Is the conversation collaborative? Oftentimes we'll use this metaphor of dancing versus wrestling. And when we talk to folks who want to practice motivational interviewing, we say, well, if you're doing a little bit more wrestling, maybe it's about rethinking some of these things and getting more into the flow. When we move to focusing, we want to identify what goals does this person have? Are my aspirations different than theirs? And are we clear about what direction we're going in? And here's that evocation again. What are their reasons for moving forward? What ideas do they have about how they want to go about the change? Is their reluctance more about their confidence or the importance about the change? And then finally, with planning, what are the reasonable next steps for them? Am I exploring the steps with them, or am I advising and telling them what I think they should do? And if I do advise, am I asking permission? So Lori and I are now going to spend the time unfolding using the OARS in these 4 processes. And we invite you again to identify what you see as far as the open questions, reflections, affirmations, summaries, and also that aspect of the spirit. Are we partnering? Are we collaborating? And is this whole notion of dancing going on? So hi, Lori. What brings you here today?
Hi, Amy. Well, my doctor sent me. I'm pregnant and having a hard time to stop using drugs.
So your doctor has some concerns about you using, and you might have some as well, and you're wondering what you might do?
Yeah, this is a really bad situation, and I'm really not sure what I'm going to do. I just don't know.
It's overwhelming. What are some things that you've been thinking about?
Well, I hate to say this, but I was thinking of not having it at all. And then I was thinking, well, if I did have it, how am I going to stop using? I don't know.
Yeah, it's a quandary. You're between a rock and a hard place. Which one should I choose?
Yeah. Really hard place.
And in our time together today, if we have the next 20 minutes together, which one of the two would you like to explore?
Oh, boy. Well, I wasn't brought up to not have a baby. I don't think I could live with that. I think I'm gonna have to think about how I can have it and have it safely. I don't know.
So maybe today you would want to explore your decision to move forward with the pregnancy at this time.
Yeah. Yeah. That's about right. That sums it up, I guess.
And you have some concerns about how you might go about moving forward.
Yeah, I don't see how I can do it. I just don't see it. I don't know. This is really the quandary. This is crazy.
So you're not sure you have support to help you get through this?
Oh my goodness. No, I'm not sure at all. I mean, my lifestyle is kind of revolves around this, and this is what the people I'm around do, and this is, this isn't going to be easy.
Yeah. And having a healthy baby seems to be something that you'd want to do, and you're not sure what steps to take.
Yeah, and having a healthy baby, but also I don't want any children's services in my life. I don't want to have that situation.
And you worry that that'll happen.
Yeah, and I'm even worried that the doctor knows. I'm kind of under a microscope here.
And tell me a little bit more about what that's about. What do you mean by that?
Well, the doctor knows. Okay, they know your analysis showed that I'm using. My pregnancy test came back positive. I mean, the doctor knows I'm pregnant. The doctor knows I'm using. He sent me over here to you, and I'm sure that he has some type of ethical obligation to, if I don't change this behavior, I mean, it's not going to be good. I mean, I don't want to have a baby and look up and have people from the children and youth looking at me.
So keeping this baby while you're using, that's the relationship of potentially having children and youth being a part of your life.
Yeah. Yeah. And I do not want that.
So what are some things that you would think of doing so that that doesn't happen? If you said, like you said, you decided you wanted to move forward with the pregnancy, now what ideas do you have for moving forward?
I'm going to have to stop. I'm going to have to somehow cut way back or quit altogether. I'm going to have to do something. I can't live how I'm living now.
When you look back over times when you weren't using, or when things were better for you, what was happening then?
Oh, that was good. I mean, I paid my bills. Everything was clean. I didn't have the worries, that I have. I didn't worry about people coming into my house who I couldn't get rid of. Yeah, it was just simpler. Life was just simpler and better.
You had some more order and control in your life. So if you fast forwarded maybe even a month from now and you had better control now, what would it look like?
It would look like some peace of mind. It would look like getting on some type of arrangements for my bills that I'm behind in. And I would be, you know, at least hopeful about being able to climb out of this hole. And it would look like being happy about being pregnant, maybe, instead of scared.
So if you could climb up a few steps, you see the light, you see the hope there.
Little bit.
Just a little bit. And there's still some things you'll need to help you move forward. So
Yeah.
when you look back in your days when you cut down or stopped before, how did you go about doing that?
Well, didn't open the door. I think I went to a couple meetings, like these meetings where people weren't using drugs.
Like self-help meetings, AA and NA.
Yeah, like those. Yeah. And that was a little bit weird for me, but I mean, it seemed to actually work.
Mm-hmm.
And then I thought the people were just a little bit different. You weren't like my old friends.
So let me see if I got this right. You've tried this before and you were successful by keeping your door closed. Maybe that means something about letting people that use with you come and go in your life, metaphorically or literally.
Yeah.
And you were able to find some support. Maybe it didn't always fit right with you, and you found that going to get some help in self-help meetings, support there, was helpful for you, and things started to get better.
Yeah.
And you see, maybe you'll do some of that this time around.
Oh boy. I guess I could think about that. I mean, it worked before, but you know, it's some of those people I just couldn't relate to them, but I guess if I would have kept on going, maybe I would have got used to it.
So you're not really sure about that one.
I'm not really sure about that one.
Yeah. And I'm wondering if I could share some information with you about some other resources that might be available to you. And especially during this time of transition, as you're contemplating how to move forward and go about this. I don't know how urgent it is for you to stop swiftly. You shared that was pretty overwhelming. And I'm wondering if I could share some resources that we have for you to consider.
Yeah. I mean, anything other than what's going on in between my two ears.
So you have a lot of information about self-help, which certainly that option is there. And there are other self-help meetings besides the traditional 12-step meetings of AA and NA. There's Smart Recovery and other types of meetings that we could certainly provide you with information about that. There's also people in our system, and we have someone actually in the office that is someone who has lived experience, meaning they've used before, they've gone through having children and gone through the treatment process. And perhaps they could be another ear to hear what you have to say and offer you some suggestions or support and guidance and resources. We have some case management as well, where folks can offer you some help. You mentioned paying your bills and having other things in order. And we call the person with lived experience peer specialists. We can use the peer and the case management interchangeably to offer you some support around some other things. I'm wondering what you think about some of those things that I just shared.
That actually sounds pretty good. I mean, I'd rather deal with the one-on-one type of help.
Okay.
Sounds like they might know, having been there. That might just be perfect for me.
So the person that has lived experience, might be a nice place for you to start having a conversation with.
I think so. I think that would actually, I think that would be a dream, because then I won't feel like so ashamed.
You're not alone. Mhm. Yeah. And you're willing to take a chance at meeting someone else and at least putting your foot forward. And what I didn't ask you is, if it's okay, I can introduce you to the peer. Her name is Amber. She's down the hall. And maybe you can connect with her and we could meet again in a few days. I know that you're really contemplating a couple things here, and it's really up to you how you want to move forward. And there's concerns from your doctor and maybe having children and youth in your life. And you seem a little nervous about reducing your use and keeping the pregnancy at the same time. So would that be okay if I introduce you to Amber and we could see each other in a few more days to continue our conversation about what you might do next, just to take it one step at a time, as fast as you want to go or as slow as you want to go?
Yes, Amy, I really appreciate that being off. That's perfect. Like, that's perfect. And if I could, the sooner the better to meet Amber, because I just feel like I'm still trying to process all of this, and maybe she can help me with it and give me like a plan or something.
Well, I think that Amber would be willing to talk to you about what ideas for planning you have. And we could
Okay.
work together collaboratively to see, how you want to go about this plan. So it's
Okay.
totally up to you.
This is perfect. Thank you so much. Thank
You're
you
welcome.
so much.
You're welcome, Lori. We'll see you in a few days. Thanks, Lori. So we'll transition and show a little video clip. I'll preface it by saying that while part of me wanted to lean in and address one or both of the issues and move forward with treatment planning and referrals, I had to slow it down and engage Lori in a conversation.
It's just, there's a lot of pressure, and sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
You have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
It was really hard.
It is. Thank you. Oh,
come on. If you would just
don't.
try to see things my way. Keep on.
All right. I realize we have a couple minutes left and just wanted to wrap up with, sometimes in the helping professions, we want to lean in and we want to fix it. And if there's medical folks in the room or non-medical folks in the room, what would happen if we literally took the nail out? Just leave you with that question, literally and figuratively. And, MI is about addressing what they want to address. Not necessarily pulling the nail out that seems so obvious and glaring. So I'm going to pause there, Rob, and see if there's any questions, comments.
So we've have one comment so far, and it's the comment that active listening does not involve a keyboard. So I'm thinking that notion that I could be asking all the right questions as MI goes, but also in the way it's delivered.
Sure. I mean, it's, I don't know if there's a question there, but if my hands are on the keyboard and I'm looking at the computer, it doesn't mean that I can't do that and look over. And or if Lori said something and I'm typing, because I know in certain office space we're working towards putting the data in the computer at the same time. I've had physicians do this and they turn and sit with me for even 30 seconds to look at me and hear what I had to say. So there's a balance there. Encourage people to try a little bit of both. But eye contact, and certainly when someone's saying something important, is powerful.
Currently, there's no other questions in the chat. I just want to say I appreciate the fact that you actually role modeled that for us. I think seeing it actually done, hearing people talk about it is one thing, but actually seeing it being used is very beneficial.
Yeah, I often ask, like, what things did you notice that seemed a little different? And not that we have a whole lot of time to have that dialogue, but what did you notice that was different that you might consider trying?
Lots of comments about it being a great video. For some people, it's their first time learning about motivational interviewing, so it was a great introduction for them. And important to start with the thoughts about the pregnancy. Don't assume someone is happy to be pregnant.
Beautiful. Yeah. And, we talk about this notion of wanting to fix something in MI. We call it the righting reflex. And my stomach gets tight, right? Because I have my own thoughts and beliefs about that. I have my own wishes for Lori, my own hopes for her. But it's not about me. It's about her. And that's the really tough part about balancing being neutral and being there for Lori.
Just getting lots more comments, really no questions at this point, but people recognizing that need for individuals to be heard, meeting them where they are at.
Yeah. A cliche that often is harder to do than it is to say it, meeting people where they're at, that cliche.
I'll throw a question out. I know there's some people on here, and sometimes it even applies to myself, is that notion of meeting people where they're at the same time you have clients or patients that are mandated to be there. So that notion of motivational interviewing for somebody who may be reluctant, but it's what's keeping them out of jail, or Child Protective Services has told them that they need to meet with you. Any thoughts on that?
Lots of thoughts on that. And certainly, Lori, feel free to share anything. But, people who are extrinsically motivated, that's that mandate, right? And Lori played that role, mandated to come in. It's about engaging them in a conversation, because right out of the gate for me, and I'll point to the scenario that Lori and I used, Lori chose to come. She didn't have to. So starting there, honoring that, using the affirmation in orders, I might not have thrown that out there, but you made a choice, and really mirroring their choice by affirming that, and then moving from there. As you could even tell in this short role play, and it doesn't always go that fast. I mean, we just did it for effect because we only have 45 minutes and really wanted folks to have some dialogue around this really fast-paced introduction, because to me, this is where the meat is, but really engaging Lori where she is. I already know a lot about her, and I would ask the audience who listened into how she unfolded. I mean, we practiced this a few times. We didn't come in cold. And the things that came out changed each time we practiced. So we don't have a script. We just rolled into that and different things happened. So I wonder, what you noticed about the things that we learned about Lori in a very short interaction. So even more to that point of time, I don't think I spent more than 10 minutes with Lori here in this scenario. And we learned a lot about her. Like right now I'd be in a classroom going, what do you know about Lori? Lots of stuff, right? She's worried about CYF. I heard a little bit about her values, about maybe if she considered not having the baby. It didn't fit with her. But I didn't go there because that's too deep of a value right now. And I don't know her yet, right? So we talk about that engagement process. And I just followed her a little bit and then guided to, let's just go somewhere together today.
I didn't know, Lori, I saw you put a few things in the chat. Did you just want to say those out loud for the other people?
Sure, particularly around your questions for mandating. There's a saying in some of the recovery circles, when the pain outweighs the pleasure, we tend to change. So when the pain of continuing to be incarcerated, or the pain of being separated and in isolation, when that outweighs the pleasure that I derive from the usage of the chemical, of the drug, then it motivates me to change, whenever, and I don't think that there's any wrong way to access a better way of life, improving your quality of life. I've seen it work that's the only thing that worked for people, is what they call a nudge from the judge. And so I've seen it work both ways. And then I've seen, like Amy said, people just blow it off altogether and they just go till they can't go anymore. So I've seen it on both sides, but I can tell you the whole idea of like diversion courts and things like that, they have some success rates. So, just giving enough of a buffer to be able to come back to one's self seems to work in some regards.
There's another strategy and tool that I often talk about that I modeled that with Lori, and I didn't highlight it here explicitly on the slide, is this notion of ask, tell, ask. It's something that folks can go ahead in their lives and start practicing right out of the gate, whether they decide to practice MI or not. And so you may have seen that I explored with Lori. So what have you tried before? Is it okay that I give you some information? So oftentimes we want to give advice, we want to offer suggestions. We may not have heard that Lori knows about it already. So I ask her first, what do you already know about something? What have you tried already? And then I offer suggestions based on what I know from other people who have tried doing this, or what we know about research, or what I know about what people have done, other people have done in your situation. And then offer a little bit of that information, not too much, because it could be overwhelming. And then end with ask, what do you think about that? What ideas do you have about that? It's a way to elicit that evocation and get a lot out of someone, while at the same time, it's an opportunity and a strategy for offering some advice.
So we did just get a question in the chat from Ellen. We have people that feel they are feeling pressured to be there, or that they have to participate. How would you change the language or the opening to help them?
Honoring that, mirror it. So that notion of reflections, reflections in a simple way, we can parrot what we hear people saying. In a more complex way, you may have seen that with Lori, that I try to assume what she's feeling and thinking, right? By the look on her face. I remember she wrung her hand around her forehead or something, and I used the word, this is really overwhelming. So with somebody like that, and I've done that before, you really don't want to be here. And I said that to Lori, I believe in the beginning, or maybe your doctor wants you to come here and you're concerned too, right? She didn't tell me she was concerned. She told me the doctor was concerned, but because she showed up, I'm like, well, that tells me something. So people don't speak always in words. And so responding to that and mirroring it. We use this double-sided reflection, especially because motivational interviewing is about exploring ambivalence. I want to have this baby, and at the same time, I don't. I want to stop using, at the same time, I don't. So that's a reflection we can give back to them to honor that and let them know we hear them to understand them. I love the Stephen Covey quote that says most people listen with the intent to respond instead of with the intent to understand. And listening to understand takes energy. I'm trying to figure out how Lori's feeling. So when you hear that ambivalence, you can offer it back in that double-sided type of reflection, which simply is, gosh, Lori, you really don't want to have this baby. And at the same time, it goes against your values to not have this baby. And if you notice, usually I'll ask the audience, what did you notice? I used and instead of but, to not negate it, to honor both sides of that ambivalence.
It looks as though we have 5 minutes left. We have no other questions in the chat right now. Do either you, Amy, or Lori have any closing thoughts that you want to share with the group?
I could offer another strategy that folks could consider if Lori's willing to role play it with me. Was considering doing that because I think this is a really powerful way to have a conversation with people, because we talked about when someone moves to planning, is their reluctance, whether they feel like it's important or is it about their confidence or not? So I put the ruler up here so you have a visual, and the notion about planning and moving forward. Like Lori might feel really that it's important, and she might not feel confident. So we use the same scale. So Lori's going to move forward and she's going to meet with a peer and she's contemplating reducing her use, right, Lori? So we're summarizing where you were because you're at this time. So we use language like that. At this time, Lori. And can I ask you, Lori, what do you think when I say that to you? When I say, hey, at this time, this is what you're choosing to do? Or the audience might have.
But not forever.
That you might change your mind.
Yeah.
Right. So change happens so fluidly. So honoring that and saying, hey, no pressure here. Right? Because I get eager. Oh, great, Lori, you can see the peer. You're going to stop using today. Let me send you to rehab. Right? So, Lori, when we think about you moving forward with maybe reducing your use and considering having a healthy baby at this time, on a scale of 1 to 10, 1 being not important at all to 10 being very important, how important is it for you to make this kind of change?
7.
So you picked a 7. Tell me a little bit more about why you picked a 7.
Well, it's pretty important. It's probably a 10 to my doctor, but it's a 7 for me based on where I'm at. Like, that's just being honest. I wish I could say it was a 10, but it's a 7.
It's more important for your doctor, and you didn't pick a 6. Why didn't you pick a 6?
Because it's pretty important. That's the highest I could get.
The highest you can get. What do you think it would take for you to get to an 8?
Oh boy. Quit doing what I'm doing.
Yeah.
Yeah. I mean, that would be the all-in thing.
Yeah. So part of you is, this is really important, and that that nervousness is keeping you below that 8 for now. Yeah.
Yes.
If we use the same scale, I mean, so it's really important to you, but we're talking about a scale now on confidence. On a scale of 1 to 10, 1, you're not confident at all. 10 being, I'm so confident, I know I could do this. I could even do it right now. Where would you fall on the confidence scale?
5.
So you're right in the middle. Why'd you pick a 5?
Safe.
Yeah, non-committal, right? And why didn't you pick a 4?
Well, I know it's more, I know I better muster up something because this is a serious situation and I cannot afford to be in the lower quadrant.
Yeah. So you're not really confident. You don't want to pretend you are. And you do have some confidence because it's an important, urgent matter for you. What do you think it would take to build your confidence to make it a 6?
Keep working with Amber.
Okay. So follow up with that connection with the peer.
Yeah.
Yeah.
That's my greatest hope shot right now.
Yeah. So you got a lifeline right now and you're going to move forward today to meet with Amber.
Yeah.
All right. So thanks, Lori, again for playing. Just some notes about the ruler. You go down, which is strength-based. If I said to Lori when she picked a 7 on the importance, hey, Lori, how come it's not an 8? Might be a little judgy, might be a little, I think it should be higher. So we want to go lower and dance around the numbers just right near where they picked, especially on an important matter such as this. Don't jump too high. Oftentimes they'll tell you why they didn't pick a lower number and offer more information. And then, you know, what it would take to get them an 8, and you could start to learn about their barriers and the things that get in their way.
Great. Thank you so much, Amy and Lori. And with that, I believe we're moving into our next session. Thanks, everyone.
Great.
Good afternoon. I'm Adrienne Carmack, and I'm a pediatrician in the Bangor area. I've been working at Penobscot Community Health Center since 2007, working with families affected by substance use disorder. I've worked with infants and children through my time here. More recently, I've been serving as the medical director of the Office of Child and Family Services. I'm honored to be working with our colleagues across DHHS and other agencies and our many community partners across the state, many of which are here today. The work of ensuring children's health and safety takes a whole team, and it takes every member of our community to do their part. Recently, we have all learned of several tragic deaths that occurred in our state to young children. It causes us all to pause and think how we can each better serve our children and families in Maine. So I thank you all for being here today to learn. I'm honored to introduce Dr. Jennifer Heyman, who will share valuable information on infant safety and what we as caregivers and providers need to know. The information is crucial to share with families that we serve. Dr. Heyman is a pediatric hospitalist at the Barbara Bush Children's Hospital at Maine Medical Center, where in addition to inpatient clinical service, she's involved with resident physician and medical student education, medical leadership, and participates in advocacy work to prevent unsafe sleep-related infant deaths in Maine. She has been an advocate for infant safe sleep since 2008, during which time she has provided educational and training sessions statewide on the subject of teaching safe sleep, teaching these practices for newborn and infant care providers. She also participates in the statewide multidisciplinary Safe Sleep Task Force and the Maine CDC's Maternal, Infant, and Fetal Mortality Review Panel. Dr. Heyman founded Cribs for Kids, the Maine chapter, to increase access to safe sleep environments to all Maine families. She has presented at conferences in Maine and nationally on infant safe sleep. She's the director of curriculum for the Tufts University School of Medicine Maine track. She has received excellence in teaching and notable teaching awards. Maine Children's Trust awarded her the Professional Advocate of the Year award. She also received Outstanding Pediatrician of the Year award from the Pediatric Residency Program at Barbara Bush Children's Hospital. She sits on the Board of Trustees for Maine Health Medical Group, where she participates in promoting physician leadership and academic integration across the health system. It is my honor to introduce our next speaker, Dr. Jennifer Heyman, to speak to us all on infant safety, what caregivers need to know. Thank you, Dr. Heyman, for being here today.
Thank you for having me. I just want to make sure folks can first hear me and see my slides. Someone wants to give me a thumbs up in the admin. Okay, excellent. I am very excited to be here today. I've actually spoken to this group probably, I don't know, maybe 6 years ago or so with my partner in advocacy, Kelly Bowden, who some folks on this call will know. And it's a great group and you're always very engaged. And I know today's going to be different because we're not in person, but please put questions in the chat and I'm happy to follow up with you if we don't have time today. I have no financial disclosures. And we have about 30 minutes and I know we're starting late. So if anybody needs me to pick up time, just send me a chat or something from the admin. But I'm going to go through, I was asked to talk about 3 topics referring to infant safety with you today. One is infant sleep. The second is shaken baby syndrome, which is now actually called abusive head trauma. And the third is vaccines. So we're going to go through a lot of information and I'm happy to share my slides for you to look at after this for things that we don't have time to delve into today. So first of all, when we're thinking about infant safe sleep, if you remember anything, I want you to remember this picture that you see on the right and this slogan, the ABCs and D of safe sleep. So the picture on the right, that baby is completely alone in that crib. Some people feel like that's baby jail. That looks terrible. There's no stimulation. This is how we want it. We want a baby flat on his back no toys, no pillows, no bumper pads, nothing. When the baby's in a crib, they should be sleeping. They don't need to have that interaction to stimulate their development and their brain. That happens when they're awake and doing tummy time, etc. So this is the model of infant safe sleep. Even though it looks a little stark, this is how we keep our babies safe. The ABCs and Ds refer to a baby being alone on their back in a crib and in a drug and danger-free zone. So this is drugs refer to illicit substances, over-the-counter drugs that impair a guardian's responses or make them sleepy, and other dangers that can impact the safety of infant sleep. So alone on their back in their crib, no drugs or dangers. So what is unsafe sleep? I showed you a picture of what safe sleep is. Unsafe sleep is pretty much everything else. Something that you hear often about that is unsafe sleep is something called bed sharing. And that's a baby sleeping on a surface with the furry friends of the family, siblings, parents, or guardians. It's a baby who's sleeping any way except on their back. So a baby on their side or their stomach is unsafe. I put in red here because I'm going to talk about this later too. It's really important to understand the danger of a baby sleeping on a couch or a really soft, like oversized recliner. Those are probably even more unsafe than a baby sleeping in bed on a mattress. Or if there's anything else in the sleeping area that can cause entrapment or asphyxia. Important in this is bumper pads, pillows, stuffed animals, other blankets, that sort of thing. When we talk about safe sleep, we're talking about infants less than a year, with the understanding that the highest risk for an infant to die in an unsafe sleep scenario is actually in the first 3 months. So that's where we really want to hone in our education. After that, the risk falls down a little bit with each month, but we really like babies to be in safe environments up to 1 year of age. I'm going to call out some nomenclature today, the alphabet soup that I like to call it. Most people on this call probably know what SIDS or sudden infant death syndrome is because we've heard about this for a while. In 1994, roughly, the Back to Sleep campaign came out. And I love this little onesie. If you can't see it, it says this side up while sleeping. So just a reminder to care providers that babies should be on their back and belly up with sleep. When we started the Back to Sleep campaign, we saw a 50% reduction in SIDS over the next few years. That is an incredibly successful public health campaign. And SIDS, it's important to understand, refers to the death of an infant that we can't explain after a full autopsy and after a thorough death scene review by a trained investigator. So 20 years ago or so, a lot of babies' deaths were coded as SIDS. Now, many fewer are coded as SIDS because if there is any unsafe aspect of that safe sleep environment, we're not using that code SIDS anymore. SIDS really should be when we don't have any risk factors for death. So what do we call deaths in those situations? So SUID, or sudden unexplained infant death, is currently the term, I think this is going to change very soon, but is currently the term that we use for all unexplained infant deaths, as it sounds like. SIDS is part of that, but another large and rising category is called ASSB, or accidental strangulation and suffocation in bed. These deaths, typically, this code is used by the medical examiners when a baby dies of an overlay injury, which is where a parent or guardian reports that they woke up and they were on top of a baby, or they died in any unsafe sleep conditions like I just told you about, including bed sharing, sleeping on a couch, etc. So why do we care about this in Maine? I don't want to burden you with a lot of numbers, but the things to focus in on here are that in general in Maine, we know that about 10 to 12 babies die each year in an unsafe sleep circumstance. Most of those are potentially preventable if we had changed the environment or something about how that baby was put to sleep. At least half of those deaths occur when an infant is sleeping with another adult or a sibling. You can see here from 2015, I just gave you a couple years of data that we get in working with the medical examiner's office. But in 2015 to 17, 94% of babies who died were in unsafe environments, and there were about 11 per year. In 2018-19, they were all in unsafe environments, also about 11 per year. And in 2020, we're really happy to report that only 6 babies died They were all in unsafe environments, so that's not great. But you can see that that rate fell almost in half. And I'm going to talk later more about this, but this is a great website to go to, safesleepforme.org. And this is a part of the Safe Sleep campaign that the Department of Health and Human Services of Maine put out, talking about the ABCDs, like I mentioned. And we're very hopeful that we're going to see a continued decrease in the numbers of babies dying in unsafe situations in Maine because of this. So the American Academy of Pediatrics, which is the kind of advocacy and governing body for pediatricians like me, most recently put out a safe sleep guidelines that is done by their Safe Sleep Task Force, which who are tasked with looking at all of the data that comes out on infant safety and infant death. And in November 2016, they reaffirmed things that you may have already heard about and that we've talked about, things like sleeping on a firm sleep surface for each sleep, being on your back, keeping objects like bumper pads and pillows out of the crib, not letting the baby overheat. They also talked again about room sharing. Room sharing without bed sharing means that the baby sleeps in a crib or a bassinet in the room with the guardian, so that the guardian is there to respond if needed, but not in the bed with the guardian. They also reminded people to avoid alcohol, drug, and smoke exposure, both during pregnancy, but after birth as well. There's evolving data that up to 25% of what now remain as SIDS deaths, these deaths we can't explain, may be due to environmental tobacco smoke that the baby is exposed to in utero and after they're born. The expanded recommendations in 2016, and these are not all of them, but really highlight what I mentioned, which was the very concerning lack of safety for sleeping on couches and armchairs. Additionally, and I'm going to have some pictures of what these are, there have been more what we call bedside and in-bed sleepers to put babies to sleep in. And it's really important to understand that there are no studies that look at whether these are safe or whether they're unsafe. We do know that there have been many recalls due to concerns of these products being linked to infant death. And the CPSC, which is the Consumer Product Safety Council, does not have any guidelines for what could make any of these in-bed sleeper units safe. So in general, we should be telling people don't use them. Put the baby in a crib or a bassinet next to your bed, not in your bed. Now, what am I talking about with these in-bed or side bed sleepers? So on the right, you can see a baby in a little white and gray striped, looks like a bassinet. This is not recommended though, because this is meant to be placed in bed, typically between two sleeping parents. The sides are mesh and completely collapsible. So parents can roll over, and we all know, or a lot of us know, what it's like to be an exhausted parent, and you don't even realize in your sleep you're rolling over onto that baby. A better option is what you see on the left. This is called a co-sleeping unit. It's important, I just circled the strap that is attached to that unit under the mattress to the other side of the bed to keep that unit snug on the mattress. This is important because it prevents that baby from rolling and getting stuck between the co-sleeper and the mattress and asphyxiating. So if parents are not going to do sort of that completely separate safe sleep space, this on the left is a nice option to offer. Here are some things that you may see in the patients that you're working with or hear about. On the left, a very popular sleep product called the Rock and Play has been recalled because it has been associated with infant deaths. On the right is something called a DockATot, which is similar to the gray and white striped bassinet looking thing on the previous slide that's meant to go in bed with the parents. And you can see that DockATot looks very soft and fluffy. And if that baby moves, the face can become entrapped and asphyxiated, or a parent can roll over onto the baby. These are other examples of recalled products that are really important to get the word out that they're not safe for sleep. The P-Pod travel bed on the right, and a Nap Nanny recliner on the left. So I do want to talk about the Department of Health and Human Services multiple safe sleep initiatives that they have going on right now. And I'm lucky enough to be a part of some of these, but there's fantastic people running these, and I think they're really impacting infant mortality in Maine. I mentioned the safesleepforme.org Safe Sleep campaign. Additionally, DHHS and Department of Child Services have partnered with all of the birth hospitals in the state to help them all get safe sleep certified. And what that means is that all of our birth hospitals are hopefully modeling how babies should sleep safely, and then parents are modeling that behavior at home when they leave the hospital. Additionally, DHHS and CDC partner on the Maternal, Fetal, and Infant Mortality Review Panel, which I'm a member, and we review deaths to make kind of recommendations broadly to the state about advocacy and policy issues that could improve or decrease infant mortality. And DHHS partners with the Maine Children's Trust on a safe sleep coalition that also works on messaging and things like that. So lots of things going on in the state to decrease infant mortality. I'm going to shift now to abusive head trauma. I want to make a disclosure with this. I understand that this topic can be very upsetting, and I know that a lot of people on this call don't routinely take care of infants or children who are injured. I'm going to share some somewhat graphic or potentially upsetting pictures. And the reason I'm going to do that is a lot of them are going to be characteristic for abuse. And once you see them, you never forget them. And I think it's important to understand sometimes subtle things that are mistaken often for abuse. And so I'm hopeful, I will warn you when they're coming up, but I'm hopeful that seeing them will help you be able to identify this in children in our state. You can turn your head or turn your screen off if you don't want to see the pictures. So I'm going to talk about abusive head trauma, and I'm going to do so by using a case. So this is a 1-month-old who reportedly put their arm through the crib slats, and the family heard a pop. On X-ray, which I'm going to show you now, there is a what's called an oblique hairline fracture that you can see right there. That is a bone fracture in an infant. The baby saw the orthopedist, who thought that mechanism made sense and sent the baby home. At age 2 months, they had bruises on the sole of the foot and around the toes. This is an unusual place to bruise because it's kind of a fatty area. There were labs that were done to show that the patient didn't have a problem with their bleeding. Everything was fine. They didn't bruise or bleed too easily. And they also noticed what I'm going to show you next, which is a picture of a forearm bruise in the office when they saw their doctor. This is important to understand that what you're seeing here, the kind of round, very purpley thing on the bottom is pretty classic for a thumb imprint. And above that, the more linear bruise is a finger imprint. So this is classic for a bruise from a grab. The baby was sent home and unfortunately at age 4 months presented to the pediatric intensive care unit unconscious and essentially in a coma. I'm going to show you next the head imaging of this child. The black that you see on the top is all blood, probably more recent bleeding that should not be there. And the baby's brain is a little bit swollen and crowded beyond what it should be. The next picture I'm going to show you is a demonstration on X-ray of rib fractures. And all of the arrows are pointing towards rib fractures. And I put a circle around what you can see that looks like almost a circular area of bone. And that shows that that rib is actually being remodeled, that rib was fractured prior to when these X-rays are taken. So these are healing or older rib fractures. The location and type of these rib fractures is almost pathognomonic for abuse. They don't happen except with inflicted trauma. The next CT scan that I'm going to show you shows progression of this infant's bleeding, and also shows that this infant had a stroke or infarct from lack of blood flow. So this unfortunately was a fatal injury. This infant did not survive. And during all of this, the parent did confess to the broken arm was not an arm through the crib, but it was a grab on the changing table. And when the baby presented unconscious, the parent admitted that the child was crying and that was upsetting, and that they squeezed the head and threw him into a chair to make the crying stop, which is a common story that we hear, that a baby is upset and it's hard to deal with that. So I bring this up to highlight a couple of key points. That, first of all, a 1-month-old infant who gets their arm stuck in crib slats cannot make enough force to break their arm. And any bruising, I'm going to talk about this like 5 times today, any bruising or multiple bruising in a baby less than 6 months of age needs to be considered abuse and worked up until we prove otherwise. So there are some key things about this story that the global royal we could have, should have picked up on. I want you to be aware of what some of the abuse risk factors are. So there's things inherent to the baby that make them more likely to be abused. If they are substance exposed, which all of you on this call are obviously well aware of today. If they have physical or developmental problems, if they have a chronic illness, if they were born premature, if they have really bad colic. There's also an increased risk for abuse if the parents have a history of uncontrolled, that's important, uncontrolled serious mental illness. If there's a history in the family of domestic violence, drug use or misuse, or police involvement. So these are things to just be aware of, and not that you should bring bias into an interaction with a family, but just understand that based on the numbers and the statistics, if these things are present, that baby does have a higher risk of being abused. So thinking then about when should I be thinking about abuse? Like I mentioned, the arm in the crib slats and a baby breaking their own arm or hearing a pop, that is inconsistent. That injury is inconsistent with that explanation. If the explanation changes a lot, that can be a red flag. And again, if it's not consistent with the developmental age of a child. You're going to see this on the next slide, but I want to say it so you remember it. If they can't cruise, they can't bruise. Same thing, if they can't cruise, in general, they can't break bones unless they fall, and we'll talk about that. So here I'm going to show some more pictures next, but I want to talk about when you see something on exam, what should raise your antenna. So unusual locations for a bruise in the fleshy areas, not over the bony prominences, are of a concern. If there's bilateral or both side bruising, multiple locations that are bruised, or if you see something that looks like a hand or what we call an implement bruise, which you are going to see next with the next slide. So these are bruises inflicted by a belt, and you can sort of see that in the linear pattern of those bruises, and they're more pronounced on the left buttock, which is the first buttock that was hit with the belt, and then it goes on to the right buttock. Buttock bruises are rarely accidental. The next picture is going to be of a broken arm. And this is a 6-month-old. And it's important to know that about 30% of all childhood fractures are actually inflicted. This tells us that we underdiagnose inflicted trauma. And in age less than 1 year, 3/4 of the fractures are inflicted, including this one. I'm going to talk a little bit later about what the period of purple crying is, but this is a great primary prevention tool. But first, actually, I want to talk about what is secondary prevention. That's sort of prevention that happens after there's been an event. And it's important to understand sentinel injuries. The case that I shared with you, that baby had several sentinel injuries. The arm fracture, the bruises on the feet and toes, and the bruises on the arm were all sentinel injuries. And what this means is that when a baby comes in extremely injured or we think killed from abuse, when you look back retrospectively in the chart, you find evidence of either unexpected or poorly explained injuries like this baby had. And those are the sentinel injuries, meaning sentinel, like they're saying, hello, this is abuse. And if we can intervene then, we can hopefully prevent worse abuse. If an infant has these, no matter what, even if it's just on report, that patient needs to be referred, usually to the hospital, to consult with a child abuse pediatrician if available. So mandatory reporting. What does Maine statute say? Because now I've talked to you a lot about what could be abuse. How do you know if you need to report it? So anybody who is working at work, essentially, when you're off the clock, you're not mandated to report. But when you have reasonable cause to suspect abuse or neglect, you need to report. it's not just medical professionals that need to do this. I've listed many people here. It's social workers, it's clergy members, it's firefighters, it's anybody in the school, it's dentists, it's chiropractors. So there are a lot of people who are mandated reporters. There is something called anonymous versus confidential when you report. Mandated reporters can't actually be anonymous. So when you call, you must give your name, but you can request to keep your identity confidential from the family. That's what means anonymous. And sometimes people will do that if they are worried that having that family get upset and breaking that relationship might put the child at greater danger than what they are. You should be considering getting mandated reporting training every 4 years, and I've listed some resources here to do it on your own or in a group. And this law, LD 1523, is what I referenced a little bit earlier, that really makes it easy for those of us who take care of children who are injured less than 6 months of age, because we can say we are mandated, not through the mandated reporting law, but through this specific legislation, which came out in part due to concern that sentinel injuries were being missed in our state, that any baby who is less than 6 months of age, who has any fracture, significant bruising, any bleeding in their brain, that's what subdural hematoma is, burns or evidence of poisoning, you must report that. For folks who might not know how you make the report, this is the central intake number and somebody is available there 24 hours a day. You won't need to fill out any paperwork necessarily unless the DHHS staff asks you of that, but you'll have to provide a lot of information on the phone. I mentioned period of purple crying. This is a helpful acronym because it sort of explains what this crying or sort of exaggerated colic can look like. It's unexpected. It resists our normal soothing techniques. The baby looks like they're in pain. It lasts a long time. It often lasts in the evening. There's several what we call doses of period of purple crying in Maine. First is in the hospital. Right now it's education with a video, although that's probably going to be changing to an app-only mode of education and communication. It's reinforced in multiple ways in our community, and then in the general public as well with public service announcements. It's really important to work with your local hospitals to keep this training up so that every baby who's born in Maine, the parents get this training for the dose 1 in the hospital prior to going home. I wanted to share this curve with you because this talks about what to expect with crying. So you've got your low, average, and high criers. It's important to know that this crying peaks around 6 to 8 weeks of age, which typically, if a parent gets a parental leave from work, that may be when they're going back to work. And that's a stressful time. Everybody's tired. And then you have this baby who's crying up to 5 or 6 hours a day. That's a high risk time for abuse. So it's important to understand the timing of this crying. I've never met a baby who's a low crier, only 20 to 30 minutes of crying a day. I think probably all of you would have loved to have a baby like that. That seems kind of low, but this is important to normalize that up to 5 to 6 hours a day of crying can be normal. Not even that it feels like excessive crying to us, and it's higher, but it's still normal. So this is helpful to share with families. Finally, I'm going to talk to you about vaccines, and I'm not here to talk about COVID vaccines or politics or anything like that. I do love this comic, though. The little boy says to his mom, "What's that mark on your arm, Mama?" She said, "My smallpox vaccine scar." And he says, "Well, why don't I have one?" And she says, "Because it worked." And smallpox is a great example. It's sort of the one thing, and we're close with polio, but not all the way, but it's the one thing that we have honestly eradicated as a risk for infectious disease all through vaccination. So basically the take-home part of this part of the talk is that vaccines save lives, especially in infants. So just a little bit to understand, why are infants different than adults? And we know and we hear, well, breastfeeding infants get antibodies from their mom. So why do they need vaccines? Well, not all of those antibodies are absorbed very well. Additionally, infants essentially are immune compromised. And this is because they don't make antibodies or have T cells, which are two of the main ways our body fights infection very well for the first months of their life. This is one of the reasons that infants need to be boosted. So they make some of these cells and then they kind of forget how to make them and those cells drop off. And then we booster them to remind that immune system what to do. And then it gets old enough and takes over. It's very important to understand that we need community immunity or herd immunity to protect our infants in this vulnerable period, which means everybody who can be vaccinated should be vaccinated. And what percentage of people we need vaccinated to offer herd immunity to the infant depends on a lot of things, including how contagious or transmissible that disease is. So this is just a great pictorial of what happens if we don't have herd immunity. So herd immunity or you get that from good vaccine coverage on the right or side B. So that person who's sick, the transmitting case, goes into a community that has a lot of vaccinated people where there is herd immunity. And you can see then nobody gets sick from that. If that sick person goes into a community that does not have herd immunity, meaning most people are susceptible and there's a minority of vaccinated people, you can see there that people are going to get sick. And this again depends on how infectious that risk is as to how many people will get sick. There's just a couple of papers here that I've put them here if you want to delve more deeply into them, but I think it's really interesting to think about a couple of key diseases. I mentioned smallpox, we've eradicated, and this chart kind of shows the percentage of decrease that we've seen after vaccinating for these in the 20th century. I did not circle on here, but you can see polio is also 100% decrease. There still is polio in the world though, so we have not eradicated that. Measles and measles and pertussis are great examples that you're probably hearing a lot about now. Measles outbreaks in a very popular amusement park a few years ago might ring a bell to people. And that was traced to unvaccinated children, then passing on the illness to unvaccinated people. Pertussis I put on here, so still a 92% decrease, which is great, but you probably all remember that we have had outbreaks of pertussis in Maine. And that's because our pertussis coverage rates in Maine, meaning people who are vaccinated, have not reached that herd immunity, or they've fallen below that herd immunity. So we're going to see outbreaks of pertussis that you've read about in the papers. And then finally, I'm just going to wrap up very quickly with thinking about how we both prevent disease and death as being an important role of vaccines, but also what is the economic impact of this? So this is a study that looked in the United States with 9 very common vaccines, and in the US preventing over 40,000 deaths per year. And we look at cost savings when you include the direct medical costs plus the indirect of missed work from parents, et cetera. $70 billion are saved from vaccination programs. And then this is looking over about 55 years, specifically worldwide with those 5 specific diseases. And 1.4 million children under the age of 5 die every year due to lack of vaccination. And I think that's just a really telling statistic of, again, how vaccines save lives. So in conclusion, remember the ABCs and Ds of safe sleep. Maine did have a very poor infant mortality rate, but it's been downtrending since, thanks to public health efforts like Safe Sleep for Maine and other things through the Department of Health and Human Services. Definitions matter. If there is an unsafe sleep circumstance in a baby's death, we do not call that SIDS anymore. If we can identify sentinel events like bruising or fractures that don't make sense in an infant, we can prevent further injury and death. If they can't cruise, they can't bruise. There is a law in the state requiring reporting in any infant less than 6 months of age that we should all be aware of. And vaccinations, simply put, that was the title of one of the articles I shared with you, save lives. Thank you very much.
Thank you so much. This was great information. So I think we can wrap up and move to the next speaker. And we'll look through the chat, and Dr. Heyman, if there's anything you could add to that, because there was so much great information. There were a couple of questions that I think some of us, both Kelly and I, addressed some of them. But so we'll keep moving to our next speaker. Thank you so much for all this information. And thank you all for being here. And I think our next speakers are about to go. Thank you.
Good afternoon. My name is Angie Belfler. I work on the maternal child health team at the Maine CDC. I have the pleasure of introducing Christine today. Christine Theriault is a Family First Prevention Services Program Manager within the Office of Child and Family Services. Ms. Theriault has a bachelor's degree in behavioral science, a master's degree in social work, and holds a licensed master social work and Maine Certified Prevention Specialist credential. She has worked in state government for nearly 23 years, which has included work in child welfare, as well as practicing macro level social work and behavioral health treatment and prevention. She has worked on special project topics, including but not limited to tobacco, substance abuse prevention, the impact of substance use on families, substance exposed infants, problem gambling, workforce development, grant writing, strategic planning, prevention credentialing, social work field instruction. And most importantly, and why we're here this afternoon, is for her to discuss her planning and implementation of the Federal Family First Prevention Services Act. Join me in welcoming Christine.
Thank you, Angie, for that introduction, and good afternoon, everyone. I'm pleased to share information with you this afternoon on the Family First Prevention Services Act. I will start sharing my screen. There we go. All right, so I want to get started by sharing with you all information about the federal law, which is sort of the foundation for this initiative that we're doing within OCFS. So the Federal Family First Prevention Services Act is a federal law that was passed back in 2018, reforming the Title 4E section of the Social Security Act. So this was pretty critical legislation because it allowed states to begin claiming Title 4E dollars for prevention services to prevent the need for foster care. It also modified the Social Security Act and Title 4E as it related to youth who are in foster care by setting specific standards of practice for those programs. So traditionally, Title 4E funds youth who are in foster care. It funds the placement for that. So again, this act really modified that to allow us to not just support the placement of youth coming into foster care, but also preventing them from coming into care by funding specific services. So this is really important because this really provides an opportunity for additional services to be made available to families and to our staff at OCFS to refer families to, again, with the goal of preventing the need for foster care and out-of-home care placement. So there's really an intentional focus on those youth who are at imminent risk of entering into foster care by providing services to those families and safely keeping the children within the home setting. This initiative also provides an opportunity for us to increase access to and information about the services that are available to families through different resources that we're developing, which I'll talk about in just a moment. And last but not least, again, the improved the improved goals around residential treatment to really make sure that youth are in residential treatment services only when there's a clinical need. It also provides an opportunity for youth to receive services after they exit residential treatment services by providing 6 months of aftercare support. So in whole, Family First really does provide an opportunity to support our families in Maine and really bring more light to tertiary prevention services. So I'm going to start by talking about the prevention services aspect of the Act. So beginning October 1st, Title 40 dollars will be available for prevention services that are referred to after the department has intervened, again, with the goal of keeping children safely in their home and preventing them from entering into foster care. So Maine had to develop a state plan, specifically outlining our plan for how we would implement this, and we just received federal approval of that plan on September 13th, meaning that we can begin implementation starting this Friday. So the services that are funded under Title 40 are very specific in the categories that you can see on your screen, and I'll talk about these in just a moment. So the eligibility for Title 40 funded services is very specific. So there's two layers. There's a layer of the federal definition, which indicates that youth who are candidates for foster care, meaning that they're imminent risk of entering into foster care without specific prevention services. Maine was responsible for developing our own criteria to kind of bounce off that foundation. And so as you can see on the screen, we have three elements of our candidacy eligibility. The first part of that eligibility includes a child who is a victim of maltreatment, meaning the department has made findings of abuse and neglect within the family unit. The determination has been made that safety and risk factors can be mitigated with in-home supports and services, but that the child can remain in the home safely with a specific prevention plan. Our second layer of eligibility includes pregnant and parenting youth who are in foster care, and then also children who may have exited foster care through reunification, guardianship, or permanency, or adoption, and may be at risk of re-entry into care. So this is sort of our eligibility, but there's some important pieces that go with that. The determination of eligibility is made at the time of investigation and the use of structured decision-making, which is our current practice within OCFS. OCFS must have an open service case with the family in order for us to be able to claim Title 40 dollars for these services. And at the same time, the children cannot be in the department's custody. They have to be in the custody of the parent. So I want to highlight that Title 40 is actually only one piece of the financial puzzle that helps to support families. There's other federal and state dollars that are out there that support families through different services. Title 40 is sort of only one piece of that puzzle. So many of you who have worked with me over the past nearly 2 years on this project has seen this visual before, but I like to share it because I like to highlight this continuum of prevention that is available in our state for families and sort of where Family First falls in. So primary and secondary prevention are often services provided to families prior to the department even becoming known to the family. And that's really the goal, is that further upstream prevention. Tertiary prevention, which is where Family First falls in, those are services that are provided after there has been a problem that has been identified. So it includes treatment, recovery, other kinds of supportive services. So I want to highlight what are the prevention services that will be funded under Title 4E. So the federal government is very specific about what services Title 4E dollars can be spent on. They have to be evidence-based and they have to be on a Title 4E clearinghouse of evidence-based programs. The programs also cannot be funded by Maine Care or other state funds. Title 4E really is a payment of last resort. So as you can see on the screen, I have the listing of some of the evidence-based programs that are on the Title 4E clearinghouse. The ones in the white boxes are programs that are funded through Maine Care or other state and federal dollars. The programs that are highlighted in the orange box are programs that are going to be funded under Title 40. That's sort of our preliminary plan for what those services will be. We were very limited with what we could fund under Title 4E because of Maine Care funding some of these other services, and the registry was very small to begin with. So Kinship Navigator Programs is an eligible service that we can use Title 4E to fund, but unfortunately right now there's no listed evidence-based programs in that clearinghouse. OCFS continues to fund the Adoptive and Foster Families of Maine, which is a program that is a Kinship Navigator program, and we're working with other states in the nation to develop some evidence behind that, so that way maybe our hope is that maybe that would be funded by Title 4E in the future. I want to also just mention there are several initiatives happening, even though Title 4E is only going to be funding these two specific services. My goal is really to make sure that our staff, parents, other providers have knowledge about some of these other services that are evidence-based, and that we're working within OCFS, within the Children's Behavioral Health Program, to sort of expand the availability of some of these other programs, such as the PPP Positive Parenting Program and Trauma-Focused Cognitive Behavioral Therapy. There's some work happening to educate more providers and get more providers credentialed in those curriculums, so we can expand our capacity in the state. So I'm going to talk a little bit about each of the two 4E funded programs and what our expansion and development projects are going to look like with these. So I'm going to start with Parents as Teachers. So Parents as Teachers is a voluntary home visiting evidence-based program that really focuses on parenting practices, early childhood development, looking at and detecting developmental delays, making sure that youth are ready for school, and really preventing child abuse and neglect. The services are usually provided in the home setting. Sometimes they're provided within the community. This is a curriculum that actually is currently being implemented by the Maine Families Home Visitor Program within our state. And so what we're looking to do with Family First is actually expand that program to expand the eligibility of the program. So currently the program serves children ages 0 to 3 years. The referral eligibility is actually prenatal to 3 months of age. I apologize, I got that, didn't fix that error on the screen, but prenatal to 3 months of age is the current referral eligibility. And what we're looking to do to expand is to serve children ages 0 to 5, because we know the data within OCFS where youth entering into foster care are a majority of them are ages 0 to 5. So we're looking to expand the referral eligibility from 4 months to 4.5 years, so that if there's an older youth, say 2.5 or 3, that could benefit from the program and their family could benefit, that we could make referrals to that program. This is really a huge opportunity to serve more families that are involved in the child welfare system and serve them for a longer period of time as well. So our implementation plan of this expansion project is going to be a phased approach. Our first phase is going to include the counties that you see on the screen. When referrals are ready to be taken, as staff are being hired, we're going to be having individual meetings with our local offices and doing sort of meet and greet and going over the referral process and all of that. So I want to take a moment to also just share that we encourage everyone to also make referrals to the Maine Families Home Visiting Program as well. Again, for those children who are prenatal up to age 3 months for the referral period of time. Please, use the Cradle Me referral system to make those referrals. We're excited to be working with Maine Children's Trust and the Maine CDC to make this expansion project happen. So I want to shift over to Home Builders. Home Builders is a intense family preservation, family reunification program. The eligibility for this program is a little bit broader, where we have ages 0 to 17 and their families can be served. It focuses more on child welfare families, those high-risk families. They will only be taking referrals from child welfare. And really focused on reducing the risk of harm within the family, looking at modifying some of the behaviors that might make it unsafe within the family setting. So this slide really just shows the intensity of the program. Within 24 hours after the referral is made, they're responding to the family. They're available to the family 24 hours, 7 days a week. There's usually a 4-week time period that they're involved with the family, and it's usually about 40 to 50 hours of direct service. So they work with the family on all kinds of different things, skill building pieces, meeting their basic needs, all of those things. So excited about this program. It's brand new, coming into our state. We have a webinar that we recorded on the Home Builders program that provides a lot more detail on implementation. If you're interested, please email me and I'll share that link with you all. This program is slated to begin after the new year. As I said earlier, I really wanted to highlight that there are other services that we want to make sure that our staff know about, that they can refer families to, and also, highlighting this not just for our staff, but for others as well. So I have on the screen just some of the different resources that we're sharing with our staff. We are developing a family services resource guide that will be also available to not just our staff, but to parents, to other service providers. That'll be completed by the end of this calendar year. So there's really an opportunity with our prevention services, this act and this initiative in our state to really increase, again, the availability of services to families and increase our opportunity for youth to stay safely in their home setting and again, reducing youth entering into foster care. I want to briefly move into children's residential treatment services. So for those youth who are in foster care, I'm going to shift from preventing youth from entering foster care to talking about those youth who are in foster care and need a residential treatment service level of care. So the foundational value of Family First and the modifications to Title 4E claiming for residential treatment services is really trying to prevent youth from being in a group care setting and really focusing on youth being in a family-based foster care program if they have to be in foster care. So the problem across the nation was that there was a lot of youth across many states who were in group care settings or residential treatment program settings and for longer periods of time. Maine is actually first in the nation to have the lowest number of youth in residential treatment programs, which is a huge success on Maine's part. But again, the national standards were established because of varying practices across the nation. So the solution was to develop qualified residential treatment program standards that must be met in order for states to claim Title 4E for those placements of youth in foster care and residential treatment programs. And so again, I sort of talked about the opportunity with reducing the number of youth in residential programs, as well as the inappropriate use of those programs when there's no clinical need. So on the screen, I've sort of broken up the standards into sort of 2 different layers. So there's process standards, which are required of us. We have to have a service intensity assessment completed before the child is admitted into a children's residential program, again, to really make sure that clinical need is there. There has to be a judicial review to make sure, again, and review the clinical need and the assessment that was completed. And there has to be a monitoring of timeframes because Title 4E will be limited for how long we can claim Title 4E for youth who are in foster care moving forward. And on the right side of the screen, you see a listing of all of the different treatment standards that are required of our treatment programs. We have 10 programs across the state for children's residential treatment. They've all committed to meeting these standards, and very excited to be working with them over the course of time to meet these standards. We've also been working with Maine Care and Licensing to incorporate these standards into rule, which are currently pending, but that would mean all of our providers across the state will be implementing these services consistently. So there's really the opportunity with these, these new standards that are required through Title 4E to, again, improving our standards. We've, again, with the opportunity through Maine Care and licensing rules, this will be standards of practice for all youth, not just youth who are in foster care. And also the aftercare support, which I briefly touched upon earlier, is an opportunity for youth and their families to be more successful after the youth is discharged from the program with 6 months of aftercare support. So I want to end with just sharing, some of the things that we have moving forward. So as I mentioned earlier, our state plan for prevention has been approved. So implementation will begin October 1st. The Family Services Resource Guide that I mentioned earlier is going to be developed, and more information will be coming out about that as we finalize that and get input from people who will be utilizing that guide. Obviously, evaluation and continuous quality improvement are going to be a big part of the work that we do. And we're going to continue to look at the Title 40 clearinghouse to see if there's other opportunities and programs we can potentially bring to the state using Title 40 dollars. I do have a state plan webinar this Thursday at 9 a.m. If anyone's interested in learning more about our state plan for prevention services, certainly email me. And I want to just end about the importance of collaboration and communication. There's a whole continuum of prevention, primary, secondary, and tertiary prevention that I mentioned earlier. And it really does take everyone in each of those different fields to work together to make sure that our families are safe, happy, and healthy and successful. So I think prevention is a big field, bigger than what we might think. So that's all I have. I think we'll open it up to any questions if we even have time for questions. So.
Thanks, Christine. We do have one quick question. There's a question about MAT and whether methadone is the only accepted medication, or would Suboxone or another medication be accepted?
So the Title 40 clearinghouse only lists methadone maintenance. That doesn't mean that there's not other clearinghouses that are out there and other evidence-based registries that list Suboxone. We know that Suboxone is an evidence-based program. It's just not something that was specifically studied under the Title 4E clearinghouse.
Great, thank you. All right, I think that's the time we have for questions, but if there are any additional questions, we put Christine's email in the chat, so please feel free to be in touch with her. And thank you very much for your presentation, Christine. All right, we're just about the end of the day, and just wanted to say quickly on behalf of the New England PTTC, one of the sponsors of this summer, we're very happy that you've all been here on day one and look forward to seeing you on day two. But we're going to now transition to wrapping up the day with a recovery story.
In early 2016, I was looking at 3 Class B trafficking charges as a result of my active use, and that's how I supported my habit, was selling drugs. And it caught up. I had charges in New York, I had charges up here in Maine, and so I was already going through IOP programs and treatment when I got pregnant with her. My name is Sophia McFarlane, and I am a mother of 2. Struggled with addiction for upwards of 23 years, and currently a recovery coach with Kennebec Behavioral Health, and working with people in early recovery and helping them navigate that process, since that's something I've managed to successfully do. I started using substances at a really young age. I was 12 when I first started using and drinking and partying, really got involved with the wrong crowd of people. By the age of 15, I was an IV user and managed to graduate high school even with that, and struggled with that until at the age of 18, I went to the methadone clinic. I spent 5.5 years at the methadone clinic. When I left there, I was in my first semester of college and knew I needed to function, and ended up seeking an intensive outpatient program, and that's when I was put on Suboxone for the first time. And I managed to complete 6 years of college, but still my mental health wasn't improving. I really wasn't working on myself. I ended up having my son, who currently is still with my mother, and hopefully working to get him back with me at some point. And I also have my daughter, who's going to be 4 this month, and went through DHS involvement with her, lost custody of her, ended up working months and went into another intensive outpatient program, and managed to get her back. When I lost my daughter, that's when I started really digging deep and talking about past traumas and, you know, what led me to where I am today, and the thought of my daughter growing up without me in her life, you know, as her mother and provider due to addiction, whether it be because I lost custody or overdosed and died. I couldn't imagine doing that. You know, all she has is me. So if it wasn't for her, I wouldn't have made the decisions that I had made to get to where I am. You know, I always say my worst day sober will always be better than my best day high. And I appreciate the things I've had, because I've really had to rebuild my life from scratch, you know, and it's been a lot of work and it's been a journey, but I've learned a lot, and very blessed to have some of the opportunities that I do today that I would not have if I wasn't sober. Recovery is possible. And for me to sit here and talk about what my life looks like today, it is proof that recovery is possible. Because like I said, I started use at 12. I don't remember a life before substances. So this is all new to me, you know, but life is good. Life is really good today. And I'm thankful for that.
Good afternoon, everyone. Thank you for attending day one of our Maternal and Child Health Conference. There was a lot of great information shared today. The recovery stories were touching. And we started off the day with the state of the state, hearing from lots of different departments on what's going on with maternal child health and substance-exposed infants. Throughout the day, learning about how alcohol impacts the fetus, recovery stories, motivational interviewing. It's just a wonderful day with lots of great information. We thank you for participating, and would like to, if you're not attending the conference tomorrow, you will be getting an evaluation email from Lorena at AdCare. This is really important to give your feedback. We use this to help plan our annual conference. And if you are attending tomorrow, we will see you then. So thank you all for participating in this great day of information, and have a good evening.